She's slotted for 8th, Dr. Karthik. So maybe let's see.
Doctors, we are live.
Yeah. Thank you to the whole UC Governing Council. On behalf of UC Governing Council team, I would like to extend a warm welcome on behalf of the President, Dr. Devakant Sir, Secretary Nilesh, our immediate past President Sonal Kalia, Dr. Aditya Sethi, the Treasurer, and myself, and Dr. Karan, the Vice President, and myself, the Joint Secretary. So welcome to YOSI NOI NAADI 2.0. It's a unique case presentation competition. So we did have the capsule 1 last year in the month of March in 2023. So we are a group of 4 organizers, which I'll be handing over to Dr. Karthik now. So myself, Dr. Prasanna, Dr. Karthikeyan, Dr. Pranesh, and Dr. Naranjan. So we are the organizers of this, and a warm welcome to all the 30 participants. And for the next few hours, we are going to have a wonderful case discussion as well as scientific deliberations. So over to you, Dr. Karthik, to welcome the first session judges, followed by the participants.
Yeah, thank you, Dr. Prasanna. Okay. Good evening, everyone, and warm welcome to all the judges and all the participants. And I thank the UCGC for giving this opportunity. First, we have first judge. We have Dr. Geeta Bera. She completed training of MBBS at 2001 in AIMS, New Delhi, MD Ophthalmology and Senior Residency from AIMS, New Delhi. She works at various capacities hospital like in Aravind, Pondicherry, Boston Eye Hospital, and other hospitals. Now she is currently working as an associate professor at Jitmar, Pondicherry. She has completed 26 research projects, and she was a guide for various PG students. She has over 37 publications to her credit. It H index of 7, and she peer-reviewed over 15 PubMed index journals. She has made over 100 presentations on national and international forums, and she is currently interested in glaucoma, diagnostic imaging and ocular blood flow, and cornea, keratitis, ocular surface research. Okay. Dr. Prasanna, can you introduce the welcome Dr. Geeta Bera, and then next stage.
Very warm welcome.
Thank you.
It's a pleasure to have you here. Next, we would like to introduce Dr. Mohammed Ibrahim Asif sir. As you can see, he's an MD, FRCO, FRCS, DNB. I think there is no degree that sir has not finished. FICO, FAICO. Thank you, sir, for being here. He's graduated or post-graduated from the RP Center in 2017, trained in the field of cornea and ocular surface, cataract and refractive surgery, received the Best Senior Resident Award in 2021, worked as a full-time corneal consultant in I7 Chowdhury Eye Center, has published over 60 articles in various peer-reviewed journals. He has presented in various conferences, received the VK Kalra Memorial Trophy, and by DOS awarded the best paper in refractive surgery and second prize in cornea free paper session. And he has won the second place in the Grand International Quiz by South Asian Academy of Ophthalmology, and to name a few more awards from DOS, Winter DOS, and ISCRIS, as well as AOS quiz competition. Welcome, sir. Welcome you once again. Looking forward to your wisdom and expertise.
Thank you, Prasanna. Thank you for the welcoming me. Thank you.
Thank you, sir. Dr. Karthik, can we move to the next slide?
Yeah, I'll move to the next slide. Can you introduce the next judge also?
Yeah. Is Naranjan there? Okay. So we have Dr. Gunjan Buttiraja, a good friend of mine and an executive member of our own YOSI. A very good academician, as you can see, MBBS, DNB, DO, FICO, completed DO with distinction and a secondary DNB as well from Venu Eye Institute. She's a cornea and refractive fellow as well as ocular surface at Dr. Shroff's Charity Eye Hospital, Delhi. She has completed her training at LVBI, working as a cornea, cataract, and refractive consultant in New Delhi, with numerous publications in international and national journals, with many award-winning presentations from DOS, national and international, and she is a reviewer for European Journal of Ophthalmology, DJO, and AOS proceedings. Welcome, Dr. Gunjan, and thank you for your time, as well as looking forward to your expertise.
Thank you so much.
Thank you. Thank you, Dr. Gunjan.
Thank you, Dr. Prasanna, for introducing the judges. Now we'll call upon the first speaker, Dr. Aanchal Agarwal, to present her case, Size Matters, a DSEK story. And Dr. Prasanna, can you please start the timer?
Yes. Once Dr. Aanchal is starting to share her screen, I'll start.
Okay. I think all the other participants can be muted. Yeah, it's mute.
Dr. Aanchal, you are good to go?
Yeah, am I audible?
You're audible. We are starting the timer. Over to you.
Hello.
Yeah, over
Good
to you.
evening, everyone. I'm Dr. Aanchal Agarwal. So I'll be discussing today a case on Descemet stripping endothelial keratoplasty. A 74 years old female underwent uneventful phacoemulsification in both the eyes, and there were no underlying Gutta or any other corneal pathology. Her post-operative best-corrected visual acuity was 6.6 in both eyes. She had on and off episodes of redness and DM folds in her left eye. She was started on Ripasidil. DM folds resolved, but then eventually she developed honeycomb epithelial edema. And 3 months after the surgery, her left eye vision drops to 6/36. Specular microscopy was done and she was found to have low endothelial cell count in both the eyes, which was more or less in the left eye. And as we can see here, the cell density is reduced significantly and percentage hexagonality is also reduced to a large extent. So patient underwent DSEK. After scoring the DM with a reverse Senskew, the DM was taken out and using a manual technique. And the graft was inserted with a needle push through technique. In this, I took a desmetorexis size of 7.5 mm and a graft size of 7.5 mm. As we can see on postoperative day 1, graft was displaced superiorly. We went ahead with graft repositioning and rebubbling along with venting incisions on day 2, but graft was still displaced. Something went wrong, but what? The first surgery was uneventful. Descemet's membrane was removed in toto and the graft was correctly oriented. However, few difficulties were encountered, including there was some difficulty in visualization of the graft margin, and also I was not able to see the classical double ring sign. So we went back to the records and looked at the patient's white to white. And she was found to have a small white to white of the vertical was 10.3 and the horizontal was 10.78. So we went ahead with a repeat DSEK on day 6, and this time we inserted a disc size of 7 millimeters. So after taking out the previous disc, the graft was prepared similarly using a manual technique and inserted through a needle push through technique. And it was good to see a well attached disc on the next day. And so graft size does matter. It's always a good idea to check for white to white in all cases of DSEK, especially for beginners. Margins are also seen well and manipulation is easier with relatively small grafts in small eyes. Larger grafts can lead to crowding of angles and secondary glaucoma. Thank you.
Thank you. Thank you, Dr. Aanchal, for finishing well on time. Over to the judges for your quick comments or questions.
Should I start or?
Yes, sir. Please.
Dr. Aanchal, it was a nice and well documented case, and I have certain queries. First, you said the first graft was 7.5 mm, correct? And then
Yeah.
the second graft was 7 mm. So, do you think the displacement of graft will be common in a larger graft or a smaller graft?
So, because I feel the opposition might not be so good in case of a larger graft, because the eye was of a smaller size, and usually we take around 2.5 to 3 millimeter lesser size as compared to the if we check for white to white.
Yeah. Actually, if the graph size is larger, it has less space for it to get displaced. So yes, it can cause overcrowding, but displacements are in generally more common with the smaller graphs. And more than did you check the thickness of the graft operatively? Because usually when the grafts are thinner, and if the patient is not maintaining a proper post-op posture, and probably that can lead to displacement of the graft rather than graft size per se. So was there any difference in the thickness between
So,
the
so it was prepared manually. I don't have intraoperative guided
uh,
to check for thickness. Yeah. So there might be a manual variation might be there in both the graphs, because I prepared it manually. But usually I ask the patient to sit to lie down in a supine position for around 2 hours, just immediately after the surgery.
all right. Okay.
Yeah.
Okay, thank you.
Thank you.
So I have a small comment here, Dr. Anshul. So would it have been better if you had done a desmetorexis of about, say 8 or 8.5 mm, if that was possible, like what we do in cases of DMET, where you're going for a large desmetorexis, and then, you usually will not have any problem with placing the DSEK graft. Do you think that may have,
Your voice is not audible. Can you
can you
please
hear,
repeat, ma'am?
can you hear me now?
Yes, ma'am, we are able to hear you, ma'am. I think
Yeah.
Right. No, so my question was, so my comment rather, not question, was that do you think it would have been easier for you if you had done a desmetorexis of about 8 or 8.5 millimeter versus if you did a desmetorexis for 7.5 and took a graft of 7.5? That would have this right?
Right.
Hello?
Yeah. So, ma'am, I think I'll go in for a bigger desmetor exercise the next time.
Yeah, I
ma'am, I
think
think
he
we are
has
having some
problem.
internet difficulties
Yeah.
for
Yeah, in general, it is advisable to go for 0.5 mm oversize. You just, I mean, 0.45 mm of decimeter axis bigger than the graft size that you intend to place.
Right.
And staining of the graft would have also helped you in the visualization part. I mean, probably you could have stained it well, but rest all it was fine, excellent.
Oh, okay. Sorry. I think I found my voice finally. Yeah. So I could not hear what Asif just said now. But my question was, from what I understood from your presentation, you took in a graph of 7.5 and did a decimal excess of 7.5 as well, correct?
Yes, ma'am.
Yes. So would it have run in your favor had you
ma'am,
done a decimal excess? Hello?
ma'am, we are
Hello.
having
Yes.
some internet turbulence from your side also, ma'am. That's why we are
Oh.
losing you.
Okay.
Anyway, ma'am, we can move to the next speaker if it's okay, ma'am.
Yes, fine.
Now I want to ask one question from Dr. Anchal.
Yes,
Yeah.
yes.
Dr. Anchal, I think one thing I would like to ask, one very well documented, but I just wanted to know what was the ASOCT picture on the next post-op day. One is this. Second, I want to know, as when we had started learning our DSEK, we were told to always measure the cornea before starting because that's how you decide the graft size. So, I mean, is it your normal practice not to measure white to white during the surgery when you're starting it before you procure the graft? Do you do it?
Yes,
Do
ma'am.
it
It was missed. I didn't I didn't check the white to white this time. So because when my graph was displayed, so next time when I took the patient, then at that time I checked the patient's white to white.
All right. And any particular reason why did not you do a ASOCT in the next day? I mean, that could have also given a good clue about, not
Yes,
just
I did ASOCT, but the graph was not seen on that picture, so that's why I'm
because
not.
because you haven't shown us the ASOCT picture. That's why I'm asking the question to you. So if it had been
Ye-
also there, we could have taken a very conclusive call. Yeah.
Right, ma'am, but graph was not seen on that, so that is why we took the patient, we did the rebubbling. So I have not shared that, but we did the ASOCT
Yeah,
next
even you
day.
haven't shared yeah. So whenever you're sharing your cases, it's very important, especially in endothelial keratoplasties, to have a ASOCT the next day that gives you a very good clue why exactly this is happening. This is very important. One is this. One is also white to white should be measured in all the cases. I would recommend that you do it in the beginning only, because later on it's very difficult to lose the graft. It's already very difficult to get good tissues for endothelial keratoplasties.
Right.
All
Thank
right.
you. Thank you,
Thank you.
dear judges and Dr. Anchal. So we'll move on to the next speaker, Dr. Nishi Prasad. Over to you, Dr. Nishi.
Yes. Put my slide. Visible, sir?
Yes, yes. Start, doctor.
So I'm going to present a case of a custard apple seeds induced bilateral toxic keratopathy. So there was a 10-year-old female child who came with complaints of photophobia, watering, pain, and difficulty in opening both eyes. There's history of applying custard apple seeds ground to a paste to her hairs for remedy of head lice infestation a day before presentation. So on ocular examination, vision in both eyes was 680. There was bilateral conjunctival congestion and severe bilateral keratitis. There was epithelial defect in right eye of 8 into 6 and left eye 8 into 8. Anterior chambers were white and other anterior segment and posterior segment was within normal. So diagnosis of custard apple seeds induced bilateral toxic keratopathy was made and patient was given topical moxidobra, Juali, lubricant Juardi, cycloplegic, hometropin 3 times a day, dexamethasone to reduce the inflammation 0.1% 3 times a day, and abundant lubricant eye ointment and chloramphenicol eye ointment at night. On the next day, she improved symptomatically and the epithelial defect in her both eyes decreased in size to 3 mm, and she was advised to continue the same treatment. On day 3, keratitis and epithelial defect was further reduced with some loose epithelium which was scraped and removed. On day 4, the epithelial defect in both eyes was resolved completely with marked reduction in keratitis. Only few punctate epithelial erosions were present. So topical antibiotics and steroids were tapered, hometropin was stopped, and lubricants were continued. On day 7, vision in her both eyes regained to 6/6. Keratitis was completely resolved. Antibiotics eye drop was continued for a week and lubricants were continued for a month. So custard apple, commonly known as sitafal, belongs to genus Annona and family Annonaceae. The seeds in powder form are used in some parts of India to kill head lice infestation and for skin exfoliation. When this comes in contact with the ocular surface, it causes severe inflammation due to toxic chemical toxicity due to presence of some active compounds like alkaloids, acetogenins, and cyclohexapeptide. The aggressive treatment, frequent follow-ups, and close monitoring are very important for healing ocular surface and to prevent infection or any complication. So our case highlights the importance of prevailing traditional harmful effects and health education and public awareness of harmful and toxic effects of custard apple seeds powder should be created to prevent such chemical injury. And my take-home message is the exposure of custard apple seeds to ocular surface, which is highly toxic and can cause severe toxic keratopathy. So careful management and frequent close follow-ups are important to prevent infection and to monitor inflammation. More education and public awareness of the harmful effects of custard apple seeds powder are needed. Not much of case report has been published, only 2 to 3. That also showed toxic keratopathy when it comes in exposure to the ocular surface, and they were also given topical antibiotics and soft steroids to reduce the inflammation and to control the infection. So that's it from my side. Thank you, sir.
It was a nice presentation and a very well documented case. And I have a question. So, what is the particular reason for starting a strong steroid? Because usually in custard apple keratopathy, they usually some people even don't give steroids, and some people do give soft steroids. And any particular reason? Because you said like inflammation was not there in the anterior chamber as well.
Yes,
So,
anterior chamber inflammation was not there, sir, but there was severe keratitis, that too in bilateral, both the eyes. And patient was also 10-year-old female. She was having too much, she could not even open her eyes. There was so much keratitis, and so we had given dexamethasone 0.1%, that too, but we started with less frequency, only 3 times a day, to reduce the inflammation so that she can be comfortable.
how long did you give?
Of course, we then tapered, sir. After 4 days, we tapered, and in 1 week, we stopped, sir. And
All
then after 1 week, only antibiotics was given and lubricants.
All right. Thank you.
Any other questions from any of the judges? Yeah. If there is no questions further, thank you, Dr. Nishi. We'll move to the next presentation by Dr. Shekhar Paul. Dr. Raj, are you ready to go?
Yes, hi.
Yeah.
Is my presentation visible?
Visible, yes. So you can go to the full screen.
Full screen. Right. So, hi, good evening, everyone. Myself, Raj Shekhar Paul. The topic of today is granular trouble and exclusionary diagnostic challenge. This is a 15-year-old male with a left eye redness, foreign body sensation, and diminution of vision on and off since past 2 years. He was being treated elsewhere as a recurrent viral keratitis and had a history of intake of oral acyclovir tablets and application of topical acyclovir for multiple times. Right eye was within normal limits, but the left eye had coarse granular raised SPKs, also diminishing his vision to 2030. The child came from an urban metropolitan locality with no history of contact with any source of contaminated water, no history of any contact lens wear. Keeping the working diagnosis as microsporadial superficial keratitis, we took a diagnostic epithelial scraping for Grams, KOH, calcofluor. We also did PCR for HSV and culture sensitivity, and empirically started him on topical moxifloxacin and voriconazole. We did stool for microsporadial ova and cyst. Microbiologically, all tests were negative. So after 1 month of therapy with moxifloxacin, there was no resolution of symptoms. So we switched to topical fluorometholone acetate in tapering dosages, along with moxi and the lubricants. All the coarse SPKs cleared off, leaving no underlying scarrings. The child had similar 3 recurrent episodes in the next 2 years. Apart from repeating his microbiological tests, his serological tests were also negative. Differentials were microsporadial superficial keratitis, viral keratitis, thygosons. Thygosons punctate superficial keratopathy. The points in favor were chronic course with exacerbations and remissions, healing without scar formation, no response to antibiotics, dramatic response to topical corticosteroids, absence of conjunctival hyperemia, no preceding history of any decreased immunity, cough, cold, or fever. Only concern was unilaterality, which is less commonly seen. We did IVCM, and it also showed us signs of Hygerson superficial keratitis. At the superficial epithelial layer, we found starburst-like appearance. At basal epithelial cell layer, numerous Langerhans cells were noted. Anterior stroma showed highly reflective materials. On his 5th year of recurrence, we went ahead with epithelial debridement with amniotic membrane transplantation and used topical moxi and topical fluorometholone. BCL was applied, which was removed after 1 month. Currently, for the past 4 years since his debridement, he did not report any recurrence. He's on topical lubricants and topical tacrolimus. Even the IVCM characteristics have improved. This is the 8-year-old timeline where 5 recurrences have been shown until date. Now he is also currently under follow-up. There is no such recurrence. So to conclude, This entity is named after Dr. Takayasu, where SPKs have been associated with immunological causes, HLA-DR3. Epithelial deformation is the main cause of association of recurrences and exacerbations. Amniotic membrane as a treatment option because it's an immunomodulatory properties. It aids in reepithelialization and it's also anti-inflammatory. So in this particular case, amniotic membrane transplantation aided in early epithelialization, which was maintained later with topical immunomodulators. Hence, amniotic membrane transplantation could be a viable therapeutic options in such recurrent Takayasu SPKs. Thank you.
Thank you, Dr. Raj. Over to the judges to have a quick comment from the judges.
Dr. Raj, I mean,
Yes.
you in the timeline after 2016, I guess 16, cyclosporin was started, and then there were multiple episodes of recurrence. So was the cyclosporin, topical cyclosporin was maintained throughout the course, or it was stopped somewhere before that?
Sir, used tacrolimus.
Tacrolimus was used towards the end. In your timeline, it was written 2017, I guess 2000.
Yes, the topical. No, sir, we stopped the topical cyclosporin because the child
How long
used
did
to
you give cyclosporin?
Sir, 3 years, sir.
Okay, so after that, the recurrence happened, or it was under the cyclosporin, the recurrence
Sir,
happened?
even under the cyclosporin, the recurrence, he was having recurrences.
Okay, all right. Okay. So tacrolimus, how long are you maintaining on tacrolimus right now?
Sir, this is the 4th year that he's having tacrolimus.
Not having any ocular.
Sir, we taper it off many a times. Like we have done this instead of a daily usage, we have asked him like alternate day usage. Then again, when he says that he's a good patient, he comes occasionally. Whenever he comes again, saying that there is some kind of uneasiness, we again just increase it. Till now, we have not given any fluorometholone or loteprednol in his eyes since we have done the debridement, the final debridement that I showed.
Yeah, it's a nice case, and it's very commonly misdiagnosed. Thaigyssen's mostly it's neglected and mistreated, so it's nicely well managed.
Thank you, sir.
Yeah, it's just a very well documented and a very interesting case.
Yes.
And I just have one query. So, do you plan to do an immunological evaluation for this patient to confirm this further?
Ma'am, actually, we planned. We were planning because we have the facility, but since we were planning it for an HLA evaluation and all such things, but the patient somehow this is actually the cost affair came into the picture, ma'am.
Okay. Okay. Thank you. It was a very nice.
Yeah, thank you.
Thank you. Judges, Dr. Arun, with that, we'll move to the next presenter, Dr. Arun. Yeah, over to you, Dr. Arun, to share your screen.
Thank you, sir. Can you all see my screen, sir?
Yeah.
Yes, Dr. Arun, but go for the full.
Yeah. Is it visible?
Yeah. You can start.
Proceed.
Yeah. Good evening, everyone. Today, I'm going to present a case. This is a 22-year-old female college student presented with sudden onset painful diminution of vision in right eye for 1 week, which is associated with pain, redness, discharge, watering, and eyelid swelling. There is history of intolerance to light and history of frequent eye rubbing present, and there is no other significant negative history. There is history of contact lens use for the 3 years, and there's a history of overnight usage of contact lens for the 1 day. The patient had similar history of sudden onset painful diminution of vision in left eye 3 years back, and as per records, we have diagnosed it as bilateral keratoconus with left eye, acute eye drops, and she underwent a gas injection in the left eye followed by penetrating keratoplasty. And for the right eye, she was started on a rigid gas permeable contact lens, and she is compliant with it. And there's no significant family history. General examination, systemic examination was within normal limits. Ocular examination, head position was erect, facial symmetry was maintained, and the visual acuity in the left eye was 360, perception of light present, and projection of rays accurate. Then Coming to the anterior segment cornea examination, there were two small epithelial erosions of size 1.2 cross 1 mm located in the paracentral and the inferiorly with surrounding infiltrates, and the epithelial bullae was seen. On close examination, there was stromal infiltrate surrounding the epithelial erosion, and in slit lamp examination, you can see central dense corneal edema and with corneal thinning. Upon staining, the epithelial defect was stained by fluorescein and diffuse SPKs were present. The left eye was post-optical penetrating keratoplasty state, and the vision was 6/9, and the anterior segment was within normal limits. We have taken an anterior segment OCT in this patient. As you can see in this picture, you can see the epithelium. There is a defect in the epithelium, which can be seen as the ulcer, and localized stromal edema followed and exudates are seen in the anterior chamber. So I put my differentials as contact lens associated keratitis or acute eye drops in advanced keratoconus. By examination, we came to a diagnosis of both eye keratoconus with right eye contact lens associated keratitis with left eye post-optical penetrating keratoplasty state. Initially, we started the patient on moxifloxacin loading dose followed by 1 hourly dosage. We have sent the initial microbiological investigations, in which the conjunctival swab yielded pus cells, budding yeast cells, and gram-negative rods. Contact lens and solution also yielded query budding yeast cells, but the corneal scraping didn't yield, probably due to small quantity. Later, based on microscopy reports and clinical appearance, we have changed the medications to topical moxifloxacin, tobramycin, amphotericin B, and homide. The culture grew coagulous negative staphylococci, which was just Staphylococcus epidermidis, which is sensitive to clindamycin, erythromycin, linezolid, and tetracyclines. So this is the table highlighting the most common organisms. Here you can see in gram-positive, coagulous negative staphylococci is the most common organism associated with contact lens. The first image shows the initial presentation of the patient, where the vision was 360, and you can see two epithelial infiltrates with surrounding lens corneal edema. The second picture is the 2 weeks following the treatment, and this is the current 2 months picture where the epithelial erosions, ulcer, everything is resolved, and you can see minimal scarring. So complete healing was seen at 3 weeks, and all antibacterial medications were stopped, and antifungals were continued at tapered dose for another 2 months. So these are the risk factors for development of keratitis in the contact lens wear.
Can you summarize?
So to prevent mishaps in case of contact lens associated keratitis, we have to take detailed history and examination. We should do initial early microbiological workup, and use of anterior segment OCT, and a proper patient counseling helps in preventing these infections. Thank you.
Over to the judges.
Doctor, yeah.
Yes,
Dr.
ma'am.
Arun.
Yes, ma'am.
So one thing, nicely documented case. I just wanted to know one thing. What was your microbiological picture? What you told me something? What did you actually perceive from your microbiological diagnosis after the scraping?
Initially, scraping yielded no reports, ma'am. They told it's a poor quantity, but the conjunctival swab and contact lens solution yielded gram-negative rods and budding yeast cells, but they told it was mistake from the lab side and they misdiagnosed it. And finally, the report came as Staphylococcus epidermidis.
So, as a clinician, what would be your picture? In what kind of treatment would you decide from this kind of microbiological picture?
We have to initially start the patient on broad spectrum antibiotics. Then, following the culture, we'll taper it down to specific antibiotics.
But you started the patient on antifungal as well, am I right?
Yes, ma'am. Since there was a doubt of
But
budding
which
yeast cells,
kind of antifungal did you decide for from your picture?
Amphotericin B.
You did not mention in the text. That's why I'm asking. Okay.
I
One thing I
mentioned
would like to just mention that, sometimes when we get this microbiology picture, sometimes this budding yeast cells are sometimes very commonly diagnosed, and sometimes it's not very significant also. So if it is not growing in the culture, we have to take it with a pinch of salt, because amphotericin B is also very toxic to the cornea. So we have to be very, very sure before we are putting the patient on these kind of drugs. Okay, one is this. Secondly, I saw that you mentioned bulle as well. Didn't you mention bulle in your
Yes, ma'am.
case?
Yes, ma'am.
Yeah.
There was one
So
small bullet.
yeah, one. So I would want to ask why you think bulle were there. Yeah. Was the patient tolerant on the contact lenses?
Yeah, ma'am, she was tolerant.
What was the
There was
endothelial? Okay, what was the endothelial count of this patient? Because sometimes when patient is a chronic lens user, CL user, there may be compromise of endothelium as well in such kind of patients. So we have to look for
Yes,
that
ma'am.
as well. Okay,
Okay, ma'am. Okay.
thank you.
Thank you.
Arun, it was a very nice case. How was the further? I'm quite interested. How did you further manage the visual recovery for visual improvement for the patient? I mean, like you put back him on
No,
RGP or
currently she's on follow-up, sir. We'll put back.
okay, still on follow-up.
Still, yes, sir.
Okay.
Thank you, sir.
All right.
If we don't have any other questions from judges, we can move on to the next presenter, Dr. Kagyapriya. Can you start sharing your slides?
Sure, sir.
You can go to the full screen though.
Okay.
Yeah.
A very good evening, one and all. My case will be on management of scleral following a chemical injury. So our patient is an 18-year-old male, a college student from Nagapattinam, who came with alleged history of assault with acid while coming back from college 5 years back, following which he had pain, redness, spotting, and gross diminution of vision. Before coming to a consultation elsewhere in a private clinic where he was admitted to given thorough ocular wash and the lubricants and was referred to higher center. There's no history of past ocular systemic comorbid illness. We did a thorough ocular irrigation with 2 to 3 liters of ringal lactate for 15 to 20 minutes before subjecting the patient to examination. So general examination and systemic examination were within normal limits. Head position was erect, eyebrows were orthotropic, facial symmetry was maintained, and extraocular movements were full and free in all quadrants. Coming to the examination of right eye, his visual acuity was 4/60, and they are accurate. There was excoriation of the skin with matting of lashes. Sclera was normal. The limbal examination showed 3 to 4 clock hours of limbal ischemia, infranasally around 4 to 6 clock hours. Conjunctiva showed circumciliary congestion with inferior tarsal conjunctival defect, although the perilimbal conjunctiva was staying negative. There was diffuse corneal edema with a near total epithelial defect. And intraocular pressure was 15 millimeters from to the anti-segment. Details were unclear because of the hazy cornea. Coming to the examination of left eye, his visual acuity was 1/60, and there was excoriation of the skin with necrosed lid margins and singeing of flashes. The sclera was normal. A limbal examination showed 11 clock hours limbal ischemia and circumciliary conjunctival congestion. There was perilimbal conjunctival defect along with tarsal conjunctival defect. Cornea showed diffuse corneal edema with total epithelial defect. And intraocular pressure in that eye was 5 millimeters of mercury. So he was diagnosed to have both a chemical injury, but the right eye DUAS grade 3 and left eye DUAS grade 6. Patient was admitted and he was started on topical moxifloxacin and dexamethasone combination 6 times a day for both eye for a week, along with preservative-free lubricants, which was given at a frequency of half hourly both eye. Neosporin H, which is neosporin is a combination of neomycin, bacitracin, polymyxin, which was given at bedtime, along with acquisaprecin, timolol, and patient was given a DCL in both eye. With oral vitamin C 500 mg TDS, oral doxycycline 100 mg BD, oral prednisolone, and omeprazole. A B scan showed both eye retina attached, but left eye had a choroidal thickening, retrochoroidal thickening. As you can see, by the end of 1 week, corneal defect seemed to have reduced in size. However, in the left eye, the visual dropped to PL plus at the end of 1 week when the patient was planned to be taken up for amniotic membrane transplantation.
but the eye is spontaneously auto-eviscerated. And 2-3 days later, patient was taken up for a complete evisceration with primary orbital implantation in the left eye. The specimen sent was negative for any growth. In the right eye, the visual acuity remains 6/36. However, the left eye infranasal, the right eye infranasally, you can notice the prominence of limbal ischemia, along with the development of still thinning and necrosis with overlying conjunctival defect and a small adjacent corneal defect at 4 to 6 clock hours, which seemed to have increased in size over a period of 2-3 days. Hence, this patient was started on autologous serum 20% eye drops along with tacrolimus eye ointment over the lid. Right eye permanent tarsorrhaphy was done, and patient was taken up for amniotic membrane placement with genoplasty. However, the amniotic membrane disintegrated over a period of 3 days, and the patient was managed on medical topical drops in view of severe inflammation, which was autologous serum, topical steroids, lubricants, and oral steroids. So, as the scleral thinning seemed to have worsened, patient was taken up with scleral patch graft and amniotic membrane for entropia until lamellar shortening was done. And over a period of 1 month, the scleral defect seemed to have reduced with conjunctivalization, and the vascularization has set in.
Dr. Kavipriya, can you summarize? Yeah.
So from this case, it's very evident that stepwise management is based on severity, and the stage of presentation is important. Autologous serum is in, and amniotic membrane may hasten the recovery in moderate to severe burns. In case of scale melt, obviously a scale patch graft with genoplasty can be done. And the most important is patient counseling and long-term follow, which had helped to save his right eye. And as always, prevention is always better than cure. Thank you.
Thank you. Thank you, Dr. Kavya. Can you stop sharing your screen? Over to the judges.
Yes, sir.
For their comments.
It's a nice case, but I want to know, why didn't you do amniotic membrane graft immediately? Because I know though they say after 7 days, first 7 days you do a medical management, but it is always the key factor for in these cases the time. So the earlier you intervene, the better are the results. So you need to control the inflammation very strongly during the initial period. So I would suggest it would have been better if you had done amniotic membrane graft even in the primary diagnosis. When you made the diagnosis within the first week, you shouldn't have waited for 1 week and then proceeded with the amniotic membrane graft. Is there any particular reason you didn't go for amniotic membrane?
No, sir. He was planned exactly just the day before I got auto-eviscerated. So we were planning to do.
Yeah, I agree with Dr. Asif. You should have planned AMT earlier in this patient. Also, I want to know, did you keep the patient on any systemic medications as well?
Systemically, he was only on oral steroids. Along with the initial period, he also received vitamin C and oxycycline, but for a period of 2-3 months, steroids were given and tapering dose.
Also, did you do any wash in the primary sitting when the patient came to you?
Oh, yes, ma'am. I had mentioned just before examination, we had given a thorough ocular irrigation with 3 liters of ringer lactate, and for a period of 30 minutes.
Yeah.
Although the patient had previously received irrigation too as well.
All right. Okay.
Thank you, judges. If we don't have any other questions, we can move on to the next participant, Dr. Priya.
Dr. Priya?
Sir, one second.
Yeah.
I'm not able to.
Click on play.
No, it is in the.
It is in full screen only. Yeah. Perfect.
Okay. Good evening, everyone. So I'm going to present 3 glaucoma masqueraders, which mimics optic nerve and the RNFL changes similar to glaucoma. With the help of OCT, we identify 2 signs. One is a temporal sign, where there is a loss of temporal fibers with the papilla-macula bundle, which is very unlikely in the early stages of glaucoma. The next is a red circle sign, where we appreciate due to the loss of GCL in the macula, we appreciate this red circle in the deviation map. So these two differentiated them from the glaucomatous optic neuropathy. So first case, a 50-year-old patient who has been treated with anti-glaucoma medications for 10 months. And is a known case of adult onset leukodystrophy for 5 years and diabetes for 2 years. And on examination, his vision in the right eye was 6/60 with a corrected IOP of 19 and left eye 6/6 with corrected IOP of 17. And both eye color vision was defective and pupil was sluggishly reacting. And general examination shows a slurred speech with the clumsiness in coordination. So when you see the fundus picture of both the eye, though the cupping looks like glaucoma, there was more pale NRR. Corresponding arcuate fibers, when you see, it's almost healthy. Now have a close look on this area, that is papillomacular bundle area, that shows a typical thinning. So the OCT has been done for this patient. For this amount of cupping, the MRW was almost healthy. So RNFL shows mainly thinning involving the temporal fibers. So this is called as temporal sign. So posterior pole analysis shows generalized loss of GCL without any pattern loss, more involving the papillomacular bundle with the red circle sign. So for this patient, we stopped the anti-glaucoma medication for 3 weeks. Down the line, his IOP was 16. So we asked him to stop the medication. So this is a case of optic atrophy due to adult onset leukodystrophy. So second case, 58-year-old patient who was on AGM for 3 months. So this patient was slightly eye myope on the right eye with a BCV of 612 and corrected IOP of 20 and left eye 6/6 with corrected IOP of 17. Color vision was normal with bilateral immature cataract. So when you see the fundus picture of the right eye, this shows a 0.73 cupping with a tilted disc and an extensive peripapillary atrophy. So for this amount of cupping, you can see the BMO MRW is almost healthy with a generalized RNFL defect, more involving the temporal quadrant. Again, you can appreciate the red circle sign. When you go back to the left eye, shows around a 0.75 cupping. Again, you can appreciate the temporal thinning with a loss of papillomacular bundle and the red circle sign. So the reason for this, when we asked the history, 15 years back, she was on ATT. So we asked the patient to stop this medication. Down the line, her IOP was 18 and 16. So we did a diurnal variation for this patient. As there was no much fluctuation, we told to stop the medications. So this is a case of a right eye myope with a both eye toxic neuropathy due to ethambutol. The third case, a 50-year-old patient who has been treated as an NTG for nearly 1 year, and she is a known case of psoriasis with a methotrexate for 5 years. So her BCVA was 6/6 and IOP was 18 and 17, and she's pseudophakic. Color vision was normal. So when you see the fundus picture, 0.6 cupping in the left eye and 0.5 in the right eye and 0.5 in the left eye. So corresponding OCT, again, you can see a typical temporal sign with a loss involving a papillomacular bundle and the red circle sign. This is a classical case. So again, this is a case of toxic neuropathy due to methotrexate. So we asked to stop the medications. So these patients are on the regular follow-up now. So non-glaucomatous optic neuropathy distinguished from glaucomatous optic neuropathy by more of pale NRR, involvement of papillomacular bundle in the early stage with the presence of temporal and the red circle sign. So normally glaucoma follow this pattern, cupping with NRR loss with an RNFL loss, which should correlate with the BMO thinning and RNFL thinning with the associated GCL loss. So any glaucoma patient should undergo all these investigations before ruling out they are non-glaucomatous. Thank you. So this is for just to know what is the pattern of loss we usually seen in glaucoma. This is a GCL loss we usually seen in glaucoma.
Thank you. Thank you, Dr. Arundhati.
That was a very nice 3 cases you presented, Dr. Arutpriya. So I have just a couple of questions for you. So can you please tell me of 2 other optic nerve diseases, 2 other diseases, not necessarily always affecting the optic nerve, but neuroophthalmic disorders in which you can see this typical one disease in which you see a red circle sign, just like the one you showed on the GCIPL in all these 3 cases. And another one where you see a C-shaped pattern of GCIPL loss.
Ma'am, actually, we have seen one more case for retrobulbar neuritis. So on the follow-up,
Yes.
we have seen this.
What kind of pattern did you see in that retrobulbar neuritis case? C or O?
The retrobulbar neuritis was mainly showing only the C pattern, ma'am, morely of C pattern.
Yes.
And traumatic optic neuropathy, again, we have in the follow-up, the second case of traumatic optic neuropathy, where that O-shaped defect was seen. Then one more case, HCQ toxicity. So those patients also, they have shown these type of defects. And
Okay. Yeah, so the patient, retrobulbar neuritis patient in whom you saw the C pattern, would you like to investigate further for any particular neuroophthalmic illness? Would you do any other further tests to look actively for something?
multiple sclerosis?
Yes, in the C pattern, you would actively do an MRI to
Yes.
look for multiple sclerosis. And in the O pattern, is there any other associated optic neuritis similar to multiple sclerosis where you can see that O pattern?
No, ma'am.
NMO you can get that O pattern in NMO also.
Okay, ma'am.
Okay, yeah.
Okay.
Yeah. All right. Nice presentation. Thank you.
Thank you.
Nice presentation, Dr. Avipriya.
Stop
And just
sharing your screen,
one
Dr.
question out
Avipriya.
of curiosity. How do you measure IOP in these patients?
Sir, all the patients, we did only applanation tonometry, sir.
Okay. Do you give odd numbers in applanation tonometry?
Sir, actually, we don't give odd numbers, but if we get that Myers in between these two lines, we just assume as it is in between those odd numbers. For example, if we get between 14 and 16, if the Myers correlates, not all the patients, few patients. So we take actually 2 or 3 readings for that, and out of that, we take 1 reading. So all the patients, we take 3 readings, sir.
Yeah, fine. It's a nice presentation. You have differentiated glaucomatous from non-glaucomatous very well.
Yes, sir.
Yeah.
Thank you. Yes.
Can you stop slide sharing?
Yeah,
And judges, do you have, if you don't have any further question, we can move to next presentation.
Yeah.
Yeah.
Next,
Kirtana.
Dr. Kirtana, can you start your slides?
Can you go to full screen and start presenting, Doctor?
Are the slides visible?
Yeah, please proceed.
Okay. Good evening, everyone. I'm presenting a case called A Tale of Two Hypersensitivities. A 15-year-old girl presented to us with redness, diminution of vision, pain, and discharge for 3 weeks in the left eye, whitish opacification for 3 days in the left eye, and a small reddish lesion for 3 days in the right eye. There was no history of trauma, and the child did not give any systemic complaints. However, on examination, she was found to have a thinly built stature, mild pallor under the eyes, papules over the forehead and the cheeks, and some scaly crusted lesions over bilateral retroauricular areas near her philtrum and over the axillary region, over the waist area and the mons pubis. On ocular examination, she was found to have visual acuity 6 parts in the right eye, 636 not improving in the left eye. IOP was normal. Adnexa was within normal limits in the right eye, whereas she had mild lid edema in the left eye. Conjunctival examined revealed mild discharge and nasal congestion, a whitish nodule at the limbus which took up stain with surrounding inflammation in the right eye, whereas the left eye showed diffuse congestion and discharge. On further examination of the cornea, there was mild MGD on the right eye, otherwise it was normal, whereas the left eye showed diffuse corneal haze, there were marginal infiltrates, and there was a very severe crescent-shaped ulcer, 3.5 into 1.2 mm, which took up stain. And there was also diffuse punctate staining over the cornea. There was a clear zone between the limbus and the infiltrates, and the sensation was preserved. The AC details were deep and hazy. They were not clear. There was a 2.5 mm hypopyon, and the rest of the details were not clear in that eye. And the fundus had a poor glow, so ultrasound was done for that eye, which revealed grossly anechoic. So this was the day 1 picture, and this is of the right eye. So this shows the whitish nodule which took up stain, and this is the left eye, and we can see the marginal infiltrates And you can also see a large crescent-shaped ulcer inferiorly. This was the ASOCT picture which was done, which showed that there was severe thinning, almost impending perforation, 97 microns was the thickness. And when we took scraping, it did not reveal any fungal or bacterial elements on KOH or gram stain, and the culture was also negative. So on a provisional diagnosis of right eye flictin and left eye marginal keratitis, we started treatment. So the patient was started on tablet ciprofloxacin twice a day. And in the right eye, she was started on gatifloxacin, prednisolone, and homatropin, whereas in the left eye, she was given cyclosporin as well, in addition to these three. And we took a derma consultation, and they said that the skin lesion suggested atopic dermatitis with impetigo and scabies, and the patient was started on amoxiclav, levocetirizine, ivermectin, fusidic acid, betamethasone, mupirocin, and since we started amoxiclav, we discontinued the ciprofloxacin. We sent her labs, and this showed that there was a microcytic hypochromic picture suggestive of iron deficiency anemia. There were raised inflammatory markers, and her ALP came out to be very high. We also got ultrasound whole abdomen done to see if there was any biliary dilatation. There was none. And we found that there was low normal calcium and a low phosphorus. So combined with the high ALP, it was we sent parathyroid hormone and vitamin D, and it was actually vitamin D deficiency, resulting in secondary hyperparathyroidism. All the rheumatological panels were negative, and a chest X-ray was done, which actually showed post-infective sequelae. Mantle was strongly positive. On day 3,
Dr.
yes, sir. Yes, sir. Day 3, hypopin had actually resolved, and by day 10, the patient was discharged with significant improvement. 220 microns were seen on the ASOCT, and this was 1 week follow-up after discharge. And the skin lesions had also resolved. So this case actually tells us that on a background of poor nutrition and environmental factors where nutritional deficiencies can result, and the patient also developed scabies and impetigo, and she had a predisposition to hypersensitivity, which is indicated by her atopic dermatitis. And in a country like India, we have TB endemicity. So altered immune function resulted in her having right eye flictin and left eye marginal keratitis, 2 different hypersensitive reactions. Thank you.
Over to the judges. Thank you, Dr. Keertana. Can you stop sharing?
Yeah. So, Dr. Keertana, I have only one question. So, what do you think is the primary hypersensitivity reaction to in this particular case? Is it to the tuberculosis, that is the TB bacilli, or is it something else? Could it be something? Could it be something else also?
We are still unsure of whether it was due to staphylococcus or if it was due to TB, because there are factors suggesting either. Because of the marginal keratitis and the history of impetigo, and so all these are in favor of staphylococcus, but she did not have any blepharitis, so that is against staphylococcus. And in a country like India, it is always important to consider TB. She did not have any active TB, which we knew from the pulmonology and the medicine consultation that we had done. But clearly, from her strong mantle positivity, she had underlying hypersensitivity to TB as well. So this could be a mixed presentation, or it could be just staphylococcus or just TB, but we could not find out.
Okay. No, so here comes my second question. Did you investigate her for other immunological diseases? Because I would highly recommend that. There are, or can you name at least 1 or 2 or 3 immunological diseases you would actively investigate her for, even for the future?
We had sent a rheumatological panel. We had sent ANA, ANCA, RF, and ACE. So all of them came back negative. So
Okay, thank you.
Yes.
Yeah.
Dr. Keertana, it was a nice presentation, but it looks like, to me, in the first go, it looks like, say, secondary hypersensitivity to tuberculosis, because it's a very classical presentation of marginal keratitis as well as flictin. But what did you do for the thinning? Like, you cannot leave the patient with the impending perforation. Though it has healed, did you do anything for the tectonic support further in the left eye?
So in the left eye, we kept the patient. She was actually admitted under us. So every day we used to send serial ASOCTs to see the thickness, and it was always improving, and it reached 220 microns around 1 week later. So after that, we always kept a close check on whether it was decreasing, whether there was any thinning. We were considering having a banana patch graft also, but because it never thinned any further, it always was increasing. We kept her on medical management, and she's doing very well now.
All right. Okay. Thank you.
Thank you. Thank you, judges. If there are no more questions to Dr. Kirtana, we'll move to the next presenter, Dr. Shruti Nair. Over to you, Dr. Shruti. Please share your screen.
Good evening, sir.
Your slides are not visible. Can you share the screen, Dr. Shruti? You can go to, yeah.
Is it visible?
Yeah, you can go to full screen. Yeah, same.
Good evening, everyone. Today I'm going to be presenting a case of peripheral ulcerative keratitis. So we had a 40-year-old gentleman who presented to us with pain in both eyes since the past 2 months, associated with redness, watering, and severe intolerance to light. So the pain was of pricking nature, which was insidious in onset, and it progressed in severity. This was associated with severe pain to light. There was no history of similar episodes in the past, no history of contact lens use or ocular trauma and surgery, and no other systemic complaints were present. He was a known diabetic for the past 1 year on oral anti-hypoglycemic agents. He had consulted outside at a local hospital 1 month back and was started on topical medication, following which he was referred to the higher center for further management. He was a chronic smoker since the past 20 years. General and systemic examination was within normal limits, and there were no signs of underlying systemic disease. Ocular examination was fairly within normal limits. The uncorrected visual acuity was 6.6 in both eyes. Eyebrows, lashes, lids were normal. Conjunctival and both eyes showed circumcorneal congestion. The cornea in both eyes had a crescent-shaped peripheral corneal ulceration with undermined edge that was abutting the limbus, associated with corneal thinning. So in the right eye, it extended from the 5 o'clock to the 10 o'clock position, and in the left eye, it extended from the 1 o'clock to 7 o'clock position. So inferotemporal in both eyes. The rest of the cornea was clear. There was no associated vascularization, and intraocular pressure was within normal limits. The anterior chamber was quiet. Fundus examination showed both eye moderate non-proliferative diabetic retinopathy. To summarize, there was a 40-year-old male with pain, redness, watering in both eyes for the past 2 months, with visual acuity of 6.6 in both eyes, with circumcorneal congestion and crescent-shaped peripheral corneal ulceration in both eyes with moderate NPDR. So we had a provisional diagnosis of both eye peripheral ulcerative keratitis with NPDR. Differential diagnosis being Morin's ulcer and PUK due to autoimmune disease. So we sent a panel of investigations, the routine CBC, renal and liver parameters, and to rule out other systemic causes. So RF titers, anti-CCP, ANA, and ANCA was sent. Chest X-ray and Mantle was done to rule out TB, sarcoidosis, and serology was also sent. Inflammatory markers were also within normal limits. So the plan of management in general PUK case, the goals are to minimize the inflammation, promote the healing of the ulcer, to prevent super infection, and to prevent perforation. So we go on a stepwise approach where initially we start with topical preservative-free lubricants, steroids, cyclosporin, and antibiotics, along with oral steroids and doxycycline and vitamin C, especially if it is bilateral. If there is no response, we can shift to steroid-sparing agents like methotrexate, azathioprine, etc., and can take a patient up for conjunctival dissection, following which we can also do a lamellar keratoplasty. So the hospital course for this patient, the patient was admitted and started on topical steroids. We gave prednisolone eye drops hourly and CMC eye drops hourly, along with oral prednisolone 1 mg per kg per day and doxycycline 100 mg BD. This was given for 2 weeks. And in the meantime, due to progression, immunology opinion was sought, and we started the patient on azathioprine 25 mg OD. After 3 weeks of this, the ulcer continued to progress with severe thinning and perforation risk. So then both eye conjunctival peritomy was done, and we gave 1 stat dose of IVMP 500 mg, followed by tapering of the oral steroids. Following this, complete healing of the ulcer was noted and the patient is currently using topical prednisolone and azathioprine since the past 3 months and is on stable follow-up. So our learning points are that timely identification of progression and inadequate response to conservative management in cases of PUK can prevent disastrous consequences and avoid visual morbidity. And IV pulse steroids have a role in halting progression and preventing perforation in cases of severe PUK. Thank you.
Thank you, Dr. Shruti. Dear judges, over to your comments. Can you stop sharing your screen, Dr. Shruti?
Dr. Shruti nicely presented case. I just wanted to know what was the diagnosis? I mean, what was the systemic diagnosis? Could you reach to that level, or were you just
systemically, since everything came negative, it's a diagnosis of Moran's ulcer, the idiopathic case. There were no other systemic comorbidities.
And one more thing, you said conjunctival peritomy. What is the surgical treatment if we have to do in these kind of cases?
A conjunctival resection, ma'am, to reduce the inflammatory load of the limbus.
So what is how do you do it? Can you describe it?
So about 1 to 2 mm in the conjunctiva adjacent to the limbus is resected or removed.
And hello. Are you there?
Yes, ma'am. Yes, ma'am.
And what else do we do?
Not sure.
What is the basic science behind this conjunctival resection?
To reduce the vascularity and the inflammatory mediators that reach the limbal area and promote the.
What else can help you in doing that?
Cotiline.
Sorry?
I'm not sure.
Okay, so just go and read also about it.
Okay.
And yeah, okay. Thanks.
I'd like to add one point. It's a nice presentation. If your diagnosis is if your diagnosis is like Moran's, I would always recommend you to consider a resection, conjunctival resection before considering immunotherapy because they really work well. And if it is a PUK case, you can consider immunotherapy before any conjunctival resection. So in your case also, after resection, it had a very dramatic response, I guess. But it could be either because of the ongoing immunosuppressant as well. But if you think it is a Moran's, I would suggest you can go for a resection, just one step. In that step ladder pattern, you consider a resection before immunotherapy.
Okay, sir.
All right.
Thank you. Thank you, dear judges. If there are no further questions, can we move to the next speaker? Would request you to stop sharing the screen so that we can speak. Dr. Raj, over to you for your second presentation.
Hi, is my screen visible?
Yes.
Yeah, it's visible.
Yeah.
You can continue.
Thanks. So good evening again. This presentation is named as Bubble Trouble, which a stitch in time. So this is a 68-year-old female complaining of both eyes diminution of vision with foreign body sensation. On examination, her BCVA was counting fingers in the right eye and 20/60 in the left eye. IOP was in the normal limits, and on retinal examination with some corneal haze, NPDR changes were noted. This was the slit lamp diagram that was done on the day of presentation, where we see corneal edema with corneal bullae. Both eyes had ACIOL, and there were huge two peripheral iridectomies, which were patent. The patient had undergone both eyes sequential cataract surgery 20 years ago after an alleged history of trauma. She had both eyes angle-supported anterior chambered IOL. Right eye, according to the patient, was always the less seeing eye. A diagnosis of both eyes pseudophakic bullous keratopathy was made. For symptomatic relief and visual rehabilitation, she was undertaken for DSEK in the right eye, which was her most symptomatic eye. challenges in this eye as shown in the figure A and B. Plate loop ACIOLs whose superior haptic had passed into the superior iridectomy, and a large superior iridectomy shown by the red arrow, which was already giving a correctopia kind of a conformation. So DSEK was performed in the presence of ACIOL, and the trailing haptic was also brought above the iris. The end of the surgery was uneventful with full chamber air bubble tamponade for the graft attachment, or so I thought, because on the next day there was less than 1/3 air and the graft was detached. The next plan of action was rebubbling with air after performing a single pass 4-throw pupilloplasty to close the superior iris defect. This is the slit lamp examination along with ASOCT, which is showing the separated disc from the recipient. This is a short video which shows creation of a single pass 4-throw. The next day, at the day 1 post rebubbling with pupilloplasty, there was more than half a chamber air bubble tamponading the donor disc against the recipient. A strict supine posture was maintained for the next 3 days. Figure A and B show the attached donor disc on the day 3 post-op. At the end of 8 weeks, a well-attached DSEK disc with subsidence of the stromal edema and bullae, stable ACIOL covering a single but vertically oval pupil, inferior PI which we made was patent, and a pinhole vision improved to around 20 to 120. So to conclude, ill-placed ACIOLs have been associated with pseudophakic bullous keratopathy. Endothelial keratoplasty in vitrectomized unicameral eyes is challenging. Conflicting research reports over DSEK with retention of well-placed ACIOL and DSEK with secondary IOL after removing the ACIOLs are there. So the current patient has been on 8 months follow-up, maintaining stable vision and IOP, and more importantly, being asymptomatic. Hence, the air bubble was well tamed with a pupilloplasty stitch. Thank you.
Thank you, Dr. Raj. We come in from the judges.
Dr. Raj, I mean, what was your ACD? I mean,
yes, sir, it was 3.2, sir.
Okay, so that's why you
yes,
went
sir.
ahead without
Correct, sir.
I guess that's why you didn't do an ACIOL explant, or like
exactly. Yes, sir. Yes, sir. That was the plan. Even on the first day picture only, we measured it. It looked deep also. And that was one of the primary reasons we went ahead with.
Otherwise, it would have been like an explant followed by DSEK.
Correct, sir. Correct.
And do you know any technique how to prevent this detachment in especially these vitrectomized eyes? Is there any technique you are aware?
Yes, sir. This surgery I did like 6 months ago. Then I did a similar surgery again. From now onwards, what I do is I take a 30 gauge needle and I inject salines from the into the vitreous pars plana root, sir.
Yes, absolutely. That is a very good technique, and it really works well.
Yes, sir, it has worked, sir. Yes, sir.
All right. Excellent. Thank you.
Thank you, sir.
If there are no more questions, we'll move to the last speaker of session 1. I would like to invite Dr. Vijita Deb, the last speaker of session 1, for her presentation.
Good evening. Is my slides visible?
Yeah, visible.
Good evening all, and thank you for this opportunity. I'm going to present on corneal perforation sealing with Tinel's patch graft and amniotic membrane. I have no financial interest in this particular case. So a 29-year-old male presented to us with sudden gross diminution of vision with brownish discoloration of his right eye. He had associated redness, photophobia, and watering from the same eye. He did not give any past history of trauma or surgery in the same eye. He gave some history of on and off corneal problem for the last 2 to 3 years in the same eye. He was asymptomatic in his left eye. On examination, his vision was found to be hand movements with accurate projection of rays, and his cornea showed a macular scar which measured around 6 into 4 millimeter in the paracentral area. A corneal perforation of around 2.5 into 3 mm with iris prolapse was noted. And there was the edges of the perforation looked more like punched out, where there was no surrounding corneal melt. There was also superficial vascularization noted in the scar. Also, when I checked the corneal sensation, it was diminished. His left eye was normal, and his fundus examination, genital B scan were also normal in right eye. Past history did not bring any medical records, but he brought around with him a cyclovir ointment and moxifloxacin eye drop, which he was using over and over again for the past 2 to 3 years. So at this point, he made a provisional diagnosis of long-standing neurotropic cornea with a paracentral corneal perforation with iris prolapse, most likely secondary to viral etiology. His other investigations were all normal. So we planned for a surgical treatment. At this point, we decided to go for a Tenon's patch graft along with amniotic membrane with BCL placement. We also explained the patient the need for any further surgical procedures. I'm sorry, I don't have video of the surgical procedure. So we harvested around 4 into 4 mm Tenon's patch from the superior conjunctiva and trimmed it to the size of the perforation, and we tucked the Tenon's patch along the perforation and did 2 to 3 multi-layered AMG patch grafting over that with box sutures and closed the perforation. So this is the image the next post-operative day. He had slight photophobia, so he was not very cooperative for the picture. So this is the next picture. And this is the post-operative regimen followed for this particular patient. Post-operative outcome, the sutures were removed at 3 months. BCL was also removed, and patient was continued on topical lubricants during the whole period of time. And we followed him up for the next 6 months. And this is the picture at his 4th month when he had come for follow-up. His vision unaided with 624, where the best corrected vision improved to 6.9 with refractive error. And he is maintaining the same vision over this period of time. So coming to discussion, we all know that corneal perforation is one of the dreaded complications, and the cause can vary from infective to non-infective to multiple causes, and the management depends on the size, location, and the underlying etiology. And there are various methods by which we can go ahead and treat such perforation. We decided to go with Tenon's patch and multi-layered AMG in this particular case because, as we can see, they reduce the vascularization load which was seen in this patient, and also if considering the viral etiology, also they provide some amount of volume replacement. So that was the reason we had chosen, and it also provides a good tectonic support. It is available in emergency condition. Also at the same time, it is non-immunogenic. So these were the all reasons. And as we know, there are multiple causes of perforation, and there are multiple list of indications where we can go ahead and plan a Tenon's patch graft. So these are my references. Thank you.
So Dr. Bijita, nice, smart.
Hello, ma'am, you're not audible.
Mr. Can you switch on the slides, switch off the share screen? Yeah.
Can you stop sharing the screen? Yeah. Perfect.
Now am I audible?
Yeah.
Yes.
Yeah. So Bijita, good way of managing is a smart way of managing this perforation. Also, you could have done tassorrhaphy in such patients because it gives a very good ocular coverage in these kind of patients, because the recurrences are going to happen. We cannot stop it. Did you maintain the patient on antiviral prophylaxis as well?
Yes. I had maintained the patient on 1 month. For 1 month, I had given him oral acyclovir, but after a month, I stopped because I did not see any melting or I did not see any recurrence. So I stopped the patient.
You could have gone for a longer prophylaxis in this kind of patient, but anyway, good management. So please remember doing tassorraphies also if you are actually going for a surgical treatment too. Okay.
Sure. Thank you.
Thank you, dear judges. So before we wind off session 1, we have with us our President UC, Dr. Divakant Mishra, sir. We would like to have the President's address before we move to the sponsorship video as well as the certificate distribution. Over to you, sir, Dr. Divakant Mishra, sir.
Thank you so much, Prasanna, and congratulations to the team first for conducting such a nice session. I joined in between, also very nice presentations. Prasanna, can you hear me?
Yes, sir, loud and clear. Yeah.
Yeah.
Welcome, sir.
And thanks to thanks to Dr. Niranjan, Dr. Karthikeyan, Dr. Pranesh, and of course Dr. Prasanna, and all of our 3 judges for taking out their time for judging Dr. Geeta, Dr. Asif, and Dr. Gunjan. So best of luck to all the participants, and may the best presentation win. And congratulations to all for such great presentation.
Thank you, sir.
Thank you, sir.
So we would like to distribute the certificates virtually in presence of you in the first session. So with that, we'll go for the certificate distribution of session 1, NOI NAADI.
Please go ahead. Yeah.
Just a second. Thank you once again to Divakant sir and the whole governing council of UC along with the executive members. So with that, we have come to the wrap of session 1. We have well on time. We have 6 more minutes for the next session. So first, we would like to thank Dr. Geeta Behra, ma'am, one of the judges. Thank you, ma'am. Followed by Dr. Mohammed Ibrahim as sir. Thank you, sir, for once again taking your time and sharing your expertise. Thank you, Dr. Gunjan Budiraja, for again your valuable expertise and your comments for this session. Thanks to the 3 judges. Without you, we would have not had this wonderful discussion and excellent insights and focal points for our young ophthalmologists. And once again, thanks to all the 10 presenters, without which this session would have not been what it is. Starting from Dr. Anshul Agarwal for Size Matters, a DSEK story. We had Dr. Nishi Prasad for Custard apple seeds induced bilateral toxic keratopathy. Then we had Dr. Rajshekhar Paul for granular trouble and exclusionary diagnostic challenge. Thanks to Dr. Arun Sahi, contact lens associated keratitis in keratoconus patients. Dr. Kavi Priya, management of scleral melt following chemical injury. Dr. Arut Priya, decoding glaucoma masquerades. Dr. Keertana Kasi, a tale of 2 hypersensitivities. Then we have Dr. Shruti Nair, PUK, a lesson in healing. And we had Dr. Raj for his second presentation, Bubble Trouble, a stitch in time. And the last but not the least, Dr. Vijita Deb, Sheath in Shining Armor, Tenon's patch with amniotic membrane graft for corneal perforation. So once again, hope I have not missed anybody. Thanks to all the 10 presenters. And we would also like to thank our sponsors, Elazar for sponsoring. Is my visible with the video?
Yeah, video is it's not playing, but you can start playing.
Yeah, video is visible, but not.
An auto perimeter is investment, particularly for my clinical field.
My patients have to travel to another hospital just for perimetry, sometimes to a different city.
Because of these reasons, many glaucoma patients miss out. AVA bridges this gap by being a diagnostic device for glaucoma with the accuracy of gold standard perimeters at just 1/5 of the cost. Take one step towards expanding your ophthalmology practice and delighting your patients. Sign up for a demo today.
With that, I'm handing over it back to Karthik. Karthik, over to you for the closing comments of this session.
Yeah, thanks, Prasanna. It was a wonderful session. All presenters presented very well, and judges asked a very good discussion with the presenters. It's a very nice session. Yeah. Next, we'll move on to the next session.
Karthik, we have 2 more minutes. Can we request anybody to quickly, if they have not shared their screen?
Okay.
We'll start on time. We'll start sharp on time. We have 2 more minutes break in between. So if any one of the session 2 participants want to share your screen, check your videos, I think we have 2 more minutes to go. Please do pitch in. We'll have a quick 2-minute break and we'll start sharp on 6:30. Is it okay, Dr. Karthik?
Yeah, it's fine. We have 2 more minutes. We can start. By the time we'll see the judges for the next session already.
And meanwhile, judges for the first session, can you please start compiling your marks and send it to any one of the 4, or even the group would do, Karthik. The judges group is also fine.
Yeah, I can get. Yeah, first I'll thank Dr. Geeta ma'am for judging session even in a busy schedule, and I'll thank Dr. Asif sir and Dr. for patiently listening and judging the sessions. Yeah. Next participant can present their slides. We have 1 more minute for people. Dr. Ahan, are you ready?
Good evening, sir. Yes.
Yeah, if you want, you already checked it. Does anyone want to check their slides? Yeah, doctors. Okay, Dr. Sujit is here. Dr. Deep is here. We just want to. Dr. Digvijay sir is also ready. Yeah. I think.
We have a.
Yeah. Hi. Good evening. Good evening, guys.
Good evening. Welcome, sir.
Digvijay sir, welcome, sir. A few words before we start the session, sir, at 6:30 sharp.
Yeah.
Yes. I'm looking forward to a absolutely wonderful session, and I'm sure that it's, we always do well. It's going to be better than 1.0, 1.0. 2.0 is always a step ahead. So all the best to everybody.
Thank you, sir. Karthik, can you have the screen at 6:30? We'll start the session.
Yeah. Can you see my screen at present?
Yes, Dr. Karthik.
Yeah. It's welcome to the session 2, miscellaneous about neuro-ophthalmology and oculoplasty. First, I'll introduce our judge, Dr. Digvijay Singh. He's the director of NOI Eye Care, Gurgaon. He's HOD of ophthalmology in Narayana Super Specialty Hospital and Madhukar Rainbow Children's Hospital. He has a special interest in pediatric ophthalmology, strabismus, and neuro-ophthalmology. Holds his credit 20 awards, 75 publications, 20 book chapters, 1 book, and 60 abstracts in proceedings. Has delivered over 100 lectures in international, 16 national, and 24 state conferences, apart from virtually delivering over 20 lectures. He has a great interest in technology of eye care and is a co-founder of technology company Kalpaha Innovations, where he has developed an artificial intelligence tool for glaucoma diagnosis called RIAG. She's a research guide, co-guide, and advisor to over a dozen of students from different universities across the country. He is currently a treasurer of INOS, and to say he is the past president of Young Ophthalmologic Society of India. Thank you, sir, we are privileged to have you here as a judge. Yeah. Next, I'll give to Dr. Pranesh to introduce the next judge. Dr. Pranesh?
Hi, I'm there. I just had a small connectivity issue. Yeah. Yes, I'm online.
So with that, I would like to introduce Dr. Sujit sir. Sujit sir is a consultant oculoplasty and pediatric ophthalmologist in Win Vision Eye Hospital, Hyderabad, Telangana State. He has finished his MD and senior residency from RP Center, and he has more than 50 publications, among which 27 are PubMed Index. And sir has also been one of the judges in our season 1 NOI NAADI as well. So thank you, Sujit sir. Over to the next judge, Dr. Pranesh. Please introduce.
Yeah. The next judge for this session is Dr. Deepshekhar Das. He has done both his JRship and SRship in RP Center AIMS. He's authored more than 70 publications and has multiple chapters in his name. He's a member of the team who described the double globe in single orbit sign, boomerang sign, and disinsert, retract, and rotate technique for brachyblock therapy. Reviewer of AJO case reports, BMJ case reports, BMC, Curious, IJO, Helion, and TJO, assistant editor of IJO and IJO case reports. He's currently working as a AP in AIMS in his field of interest are oncology, orbit, oculoplasty, and neuro-ophthalmology. Sir is continuing with us for the second time for this 2.0 session, and we thank him for being a part of NOI NAADI 2.0.
Thank you, Dr. Pranesh, for the kind introduction. Hello, Dr. Prasanna. Hello, Dr. Karthikeyan.
Hello, sir. Hello, sir. Happy
Thank
to
you
have
for
you back once
giving me this
again, sir.
opportunity once again. So I guess we are going to have another fun session. Let's see.
Thank you. Thank you for being again for season 2 as well, sir. Thank you, sir.
Okay, I'm happy to say that Dr. Deep and Dr. Sujit were my batchmates when we were doing PG in AIMS New Delhi.
Wonderful, wonderful, sir.
Yeah, I think we can start the session. Dr. Ahan, can you start your presentation?
Yes, sir. Sure, sir. Are my slides visible?
Can you make it as a full screen?
I've done. Is it not so?
Can you use?
I think you're in presenter's view. So yeah, great.
Good evening, one and all, respected judges, organizers, and my fellow participants. So I'll be presenting a case of reversible cerebral vasoconstriction syndrome, that is RCVS, and papilledema. So did you know that RCVS is, although a benign entity, is responsible for 5 to 10% of cases of RCVS may land up with permanent neurological deficits. Up to 40% of them have an associated stroke with them, either hemorrhagic or ischemic. And more than 90% of them are debilitated by thunderclap headache. So with that said, let me begin with the case presentation. A 35-year-old female comes with complaints of 8-day history of recurrent thunderclap headaches, which are predominantly right-sided, lasting 2 to 5 minutes and which occur every 2 hours with spontaneous relief. The patient has no history of any loss of consciousness, seizures, or abnormal movements, and the patient denies any history of any triggers, including medication usage or head trauma or recent illnesses. No other past medical history. The patient has history of hypertension in father and breast cancer in mother. Otherwise, ocular history is of refractive surgery 8 years back. On presentation, anterior segment was within normal limits, but you can see that the patient is having papilledema. With a visual acuity of 6/9, the patient is still ophthalmologically fine without any symptoms, but the patient has thunderclap headaches. And this is an image of OCT RNFL. Just a minute. This is an image of OCT RNFL where you can see that the RNFL are considerably thickened with a value of 251 and 283 microns respectively for right and left eye. So lab investigations were done, which showed that there was no abnormality of any bleeding or clotting time, and CSF analysis was within normal limits with an opening pressure of 25 centimeters of H2O. Now you can see that in this image, the patient has a right temporoparietal intraparenchymal bleed, and the patient is having ventricular effacement as well. Digital subtraction angiography was done to rule out other causes, which can be aneurysmal rupture causing bleed, which was ruled out through DSA. And we can see that here in this image, there is proximal vasoconstriction followed by a distal vasodilatation in middle cerebral artery. Another finding that can be seen is multifocal narrowing of vessels in the MRI time of flight sequence, which was done for our patient as well, involving transverse communicating artery and posterior communicating artery as well, along with the vessel mentioned in DSA. So with these 2 images, what we have done is ruled out other primary etiologies like berieaneurysmal rupture or venous thrombosis. C fields showing a characteristic pie in the sky defect, that is homonymous left superior quadrant anopia, which is probably secondary to the right temporoparietal bleed. Over time, the patient was started on nimodipine, which is actually a wonder drug for this scenario. It is a calcium channel blocker causing vasodilatation. It is very helpful in abating headache in these individuals, which is severely debilitating, as mentioned before, thunderclap headache. 60 mg QID was the dose started, and the patient was also given oral acetazolamide to control the raised intracranial pressure. So after 1 month, you can see that how nicely the bleed has resolved. And over time, this is the slide showing clinical course. The patient's RNFL value and papilledema was worsening initially, so the dose was hiked up to 250 mg QID. And following serial monitoring with color vision, contrast sensitivity, OCT RNFL, fundus photos, and neuroimaging, as shown before, the patient's RNFL reduced by the time of July 2024 on medication to 106 and 101 microns. This image shows resolution of papilledema, and as these findings can evolve rapidly, have permanent neurological sequelae, it is important to actually be aware of this condition as ophthalmologist. So this slide briefly shows the pathophysiology of RCVS, where the triggers.
Dr. Shah, can you summarize?
Yeah, just wrap it up in a few seconds, please. Yeah, please.
So I'd just like to conclude by saying that nimodipine, which aborts headache, and acetazolamide to control the papilledema can be a go-to treatment for these patients, and ophthalmologists should be aware of this scenario when this patient come to us in emergency department. Thank you. These are my references.
Thank you, doctor. Over to the judges.
Thank you, sir.
Yeah. Am I audible?
Comments.
Yes, sir. Yes. All right. So I think it was a good case. And so how do you differentiate this from, vasospastic migraines? And do you think this could also have led to Terson syndrome? Were there any other hemorrhages that were there in the retina, or any kind of a small hemorrhage even in the vitreous cavity?
Yes, sir. So vasospastic migraine may be associated with aura and visuals like photopsias, which was not there in our patient. And a thorough medicine neurology workup was done. And with their consultations, the patient was diagnosed with RCVS. The patient did not have any hemorrhages in vitreous cavity or on the retina. No subhyaloid hemorrhages were noted, but the patient did have few splinter hemorrhages and dot blot hemorrhages in the fundus, thus again supporting our primary diagnosis, sir.
Right. Yes. So I think in migraines, very often there would be triggers, and these headaches would happen without any of that as well. So yes, right. Yeah. Oh, thanks.
Yes, thank you, sir.
I have a question. When do you,
Yes.
I mean, the CSF opening pressure was 25 centimeters of water. So
Yes,
what
sir.
is the, criteria to say it has a raised ICT?
Thunderclap headache, sir, which could be because of the reasons mentioned in the slides, like aneurysmal bleed or CVT.
I'm not asking regarding that. I think the main treatment was given by neurologist, not by you. Right?
Yes, oral acetazolamide therapy was initiated by us. And
25
then
centimeters of this H2O is quite borderline.
Yes, sir.
Actually, for which they have given acetazolamide 250 mg TDS.
Yes, sir.
Usually twice is also sufficient, but later on they have increased it to QID. They made
Yes,
it
sir.
as a 1 gram daily dosage.
Yes, sir. So the patient was coming from neurology to us for serial OCT RNFL and fields review. And
So
when
how
they
much
noted,
percentage change, was there any increase in the thickness which made you increase the dose, or was that there it was static, it was not increasing, and also it was not reducing, that you had to increase the dose?
yes, sir. So as mentioned in the clinical course here, after seeing that the RNFL thickness had increased from 236 to 263 and 211 to 275.
Okay.
After neurology consultation, acetazolamide was spiked up for this reason, sir.
Okay. It might be because of the secondary etiology in the CN, there was a bleed, right? That might be hampering the impairment of CSF drainage.
Yes, true, sir. So
Once the main pathology has come down, the CSF pressure has come down. So temporarily you have increased the dose.
Yes, true, sir.
Dr. Ahan, I had a question, like, what's the age of the patient? I think I missed out, or you haven't mentioned it. So what's the age of the patient? Because
35,
Huh?
sir.
30.
35.
I haven't mentioned it actually. And one of the more common reasons for the syndrome you're talking about, it's commonly associated with preeclampsia. So was there any association with
Postpartum,
pregnancy or something related to it?
No, sir. The
So
patient
you haven't
had.
mentioned it in the history as well. So
Yes, sir. I mentioned the age, but I did not mention that postpartum. I mentioned the age, that is 35-year-old female, sir. But that postpartum history, I did not mention, as you are correctly saying. The patient did not have
they
any
typically
history of
happen
recent
in
depression or. Yeah, that is one of the main triggers, sir. Yes, sir.
yeah.
True.
If you have mentioned preeclampsia, then we would not have thought of all these things, like baki kuch aate hain. Yeah. Anyways, a good presentation, good case. Okay. Thank you.
For the next presentation, can I hear Dr. Nishi? Dr. Nishi Prasad.
Yes.
Actually, due to emergency, the order has been changed. So judges, please note, this is the 5th in the number of the.
Okay. No worries.
You can, sorry to interrupt. Judges, you can just look at the case and the contestant, and then you can give the marks accordingly in the live sheet. Thank you.
Good evening, everyone. So I'm going to present a case of post-varicella periocular necrotizing fasciitis associated with keratoconjunctival. So there was a patient, 13-year-old male, who had developed fever and skin rashes over face and upper part of trunk 10 days back, followed by swelling in right eyelids. Then there was blackening of skin over right upper eyelid since last 3 days, and followed by diminution of vision in the same eye, right eye, since 2 days. Immunization report was not available with the patient. On general physical examination, there was papillovesicular rashes over face and upper trunk, which was in healing stage, and generalized swelling over right side of face. Patient was febrile. On ocular examination, right eye, there was axial proptosis, vision was hand movement, PR was accurate in all the quadrants. On lid, there was necrotic tissue over eyelid, extending to underlying fascia and muscles with discharge. There was a saucer-shaped corneal ulcer of size 3 × 2 mm square at mid-periphery with well-defined margin, sloping edge, sloughed base, and surrounding infiltration. Pupil was sluggishly reacting to light, and ocular movements was semi-restrictive in all the cases. Fundus was not clearly visible. Left eye vision was 6/6 apart from diffuse lid edema. Anterior segment and posterior segment was normal. So with the blood investigation, when we calculated the laboratory risk indicator for necrotizing fasciitis, the score was 8, which was under high risk. Other investigation, blood culture was positive for Streptococcus species. Corneal scraping culture was positive for Pseudomonas species. HIV was negative. USG B scan was normal. MRI brain was normal, while MRI orbit showed right orbital cellulitis and right preseptal cellulitis, and of infective or inflammatory etiology. So diagnosis of right eye orbital cellulitis with periocular varicella zoster necrotizing fasciitis with secondary bacterial keratitis was made. And patient, based on the sensitivity, patient was started on broad spectrum higher antibiotic and NSAID. Locally also antibiotic, cycloplegic, and loss of lubricant. And next day, right eye upper and lower lid necrotic tissue debridement was done, and the specimen was sent for the histopathology, which came as necrotic tissue with acute inflammatory cells. On day 7, repeat MRI orbit showed resolving inflammatory changes suggesting response to therapy. On 2 weeks later, secondary graft repair was done, and split thickness skin graft was taken from the right lateral thigh region, and the size was nearly same as that of the exposed tissue. So a cicatricial lid retraction was noted a bit. So necrotizing fasciitis is a rare but lethal complication of varicella zoster, and most common organism involved is group A beta hemolytic streptococci. It can involve from conjunctiva till optic nerve. It needs aggressive multidisciplinary treatment and intervention with early medical and surgical debridement to prevent as it has high mortality and morbidity rates. So my take-home message is skin and soft tissue infection can be a fatal complication of varicella. Necrotizing fasciitis requires early and aggressive surgical debridement to prevent complications like muscle necrosis, dysfunction, and death. That's all from my side. Thank you.
Can we have the judges over for the discussion? Digvijay sir.
Yes, I know that was a good case, and I think well presented. Uh, what would the systemic risk factors, specific to these cases that you had looked out for when you were doing the evaluation systemically?
Yes. So it is most common in the immunocompromised patients and also in diabetics. So we had seen for the RDS, sugar was normal, sir. And we had done viral markers also, which was negative in this case. So there was no immunodeficiency as such.
Anything else? Yeah. So any other form of immunodeficiency also that could have been looked for? Basically, you were looking at basically HIV and diabetes, right? Primarily.
Yes.
Or
Yes.
are there other immunodeficiencies?
Malignancy and all, so a young age,
Yes.
young male patient.
So did you do a peripheral smear because leukemia? So these are a lot of other forms of
Histology,
immunodeficiency also.
histopath report was sent, which showed just a necrotizing fasciitis, necrotic tissue with acute inflammatory cells, predominantly neutrophils and few lymphocytes.
Right. Okay. Thank you.
Deep sir.
I had a question, like, why was a split thickness advised? Why not a full thickness graft? Am I audible?
Yes, sir. Yes, sir.
Why was a split thickness advised? Like, I think you mentioned in the slides, you have used
split
a
thickness graft. So
yeah. Why not from a retroauricular full thickness graft? Just a simple question.
it was just the tissue, exposed tissue was just only fascia was involved in this case. So we had taken split thickness graft.
Usually, whenever the
Actually,
tissue debridement happens,
yeah,
like
actually
whatever
for
went through,
necrotizing fasciitis, we give as it is till the surface heals. You don't place the graft immediately. Was there any culture growth in the tissue which you
the
have done? Did
debrided
you check for
tissue.
any culture?
Yes, sir.
Was there any growth? Any bacterial infection, anything was
Blood
Once
there?
you have
culture
debrided the
was
tissue, the debrided tissue, was it
okay.
sent
No,
for
sir. No,
culture?
no growth in that. So no.
No growth. So it was mainly
Possibly
immunologic kind
necrotic.
of thing.
Yeah.
Yes.
You have
Okay.
mentioned about varicella infection as well, I think.
Yes.
So, how was that diagnosed? Like,
So there was skin rashes. First, history of fever 10 days back, and then there was papillovesicular rashes all over the face as well as upper part of the trunk.
it's not looking like a typical one because one is also noted on the other side of the face, I think.
There was
Yeah.
swelling into the other side. That's right.
Okay, fine.
I think
The
you should
idea
look
was
into
like what
more
I
of
was trying to
autoimmune.
say, Dr. Sujit was also adding to it. Usually in such cases, we let the tissue heal on its own. We let it form a granulation tissue on top of it, and then maybe in later phases we can, plan for a, reconstructive surgery later on. Is it what you are trying to say, Sujit?
Yeah. Primarily, you can do just a torsography
Yeah, and
and
let the
leave it as it is. Yeah, let the cornea and the
bare.
heal. Did you do autoimmune workup for this?
No, sir.
No, I mean, because the other eye also, as Deep pointed out, both the upper and lower lid seems to be little bit swollen.
So
It's kind of a
yes,
bilateral presentation.
Bilateral thing. Rarely we came across cutaneous lupus erythematosus, which was having recurrent eyelid edema like that. So autoimmune workup you should also include if you have the patient in the follow-up.
Okay, overall, nice presentation. Thank
Yeah,
you.
next presentation.
Nishi madam, we're going to stop sharing.
Yes.
Can we have nice discussion, judges? Can we have next Dr. Pooja Kurup for a presentation? Dr. Pooja?
Yes, sir.
Yeah, nice.
Shall I start, sir?
Yeah, doctor, you can share your screen, doctor. Please.
So, good evening, everyone. This is case of a 21-year-old female who presented with.
One sec, doctor. Nothing is visible.
No, you have to go down and click the share screen button, green color.
I have clicked.
But we are not able to see your slides. Can you? Yeah.
Yeah.
Now.
Now we are able to.
Yes.
You have to go to full screen.
Yes. Good evening. This was a case of a 21-year-old female who had presented with complaints of persistent headache and doubling of vision associated with one episode of projectile vomiting and transient visual obscuration for 1 week. She did not have any significant comorbidities and she was not on chronic medication intake. The rest of the history was not significant. On examination, she was well built and nourished, and mild pallor was noted. Systemic examination was within normal limits. Ocular examination showed that she had a small right face turn with less than 15-degree right isotropia. Limitation of abduction in the right eye was also noted. Presenting visual acuity in the right eye was 6/12 parts, improving to 6/9, and left eye was 6/9 parts, improving to 6/6. Contrast sensitivity examination, both eye was reduced. The rest of the anterior segment examination was normal in both eyes. The fundus examination of both eyes revealed that there was marked disc elevation with 360-degree blurring of the disc margin, with peripapillary dilated and tortuous vein and hemorrhages in both eyes. This was the fundus picture, dilated fundus picture of both eyes, showing established papilledema. Visual field examination was done, which showed peripheral concentric constriction of the visual fields, which was noted. OCT RNFL showed increase in the RNFL thickness. B-scan ultrasonography, which was done, showed an increase in the optic nerve sheath diameter to 6 mm. Her routine blood investigations sent were within normal limits, except for her CBC, which showed low hemoglobin level. MRI brain with MR venogram was done, which showed signs of elevated intracranial pressure, such as empty cella sign. A guarded lumbar puncture was performed, which showed a CSF opening pressure of 35 centimeter water. The rest of the CSF analysis were within normal limit. A diagnosis of benign intracranial hypertension with iron deficiency anemia was made, and the patient was started on oral acetazolamide 250 mg QID. 1 week later, the patient was reassessed, but the patient did not have any clinical improvement, and also, in fact, the disc edema had worsened, and OCT RNFL also showed increased RNFL thickness. So the patient was planned for optic nerve sheath decompression surgery. This was done via medial transconjunctival approach, where a limbal pectomy was done. A medial rectus is identified. Then the tendon is secured using 6-0 Weichel suture. The medial rectus is then disinserted, following which traction suture will be placed using 5-0 Ethibond suture, which is then pulled laterally, and then so that the globe is retracted laterally, and then we'll follow the posterior ciliary arteries to identify the posteriorly. We'll then retract the retroorbital fat and the posterior tenons capsule. The optic nerve sheath, retroorbital part of the optic nerve is identified, and then a small fenestration is made using a sharp blade. Once CSF egress is noted and satisfactory CSF filtration is seen, then we'll reinsert the medial rectus and then close the conjunctiva. Then the patient was then re-examined 1 week post-operatively, where she showed mild symptomatic improvement, and even her disc examination revealed that there was a marked reduction in the disc edema in both eyes. The patient was continued on oral acetazolamide 250 mg QID and was asked to regularly follow up 2 weekly. In her most recent visit, the patient reported that her symptoms had almost completely resolved, and also fundus examination showed that there was almost complete resolution of the disc edema in both eyes. The patient was then, even her visual field examination showed that there was improvement. The patient was then asked to be to maintain on oral acetazolamide 250 mg BD till visual field stabilization. So through this case, we can see that optic nerve sheath fenestration surgery is a safe and effective procedure, especially in medically resistant progressive benign intracranial hypertension patients. And also, this patient had associated anemia, and anemia could be a possible risk factor for BIH because it can increase the cerebral blood flow and venous pressure. So timely ONS of surgery can help in visual stabilization in patients with intracranial hypertension. Thank you.
Now over to the judges.
Yes. Yes, I think wonderfully presented, and we very often do notice, iron deficiency anemia as one of the, risk factors that we are seeing with IIH. I'm not sure if it strictly remains IAH if you have that as a strong factor that's there. So what do you think is the pathogenesis apart from just the cerebral blood flow is very well regulated. So anemia causing that much of a change in cerebral blood flow is usually not that likely, though that's what it's postulated. But there are other postulates also as to why IDA causes it. Do you have any idea of that? And secondly, if you have a cause, you have a risk factor which is correctable, in that case, was ONSF still your primary choice, or would you have tried to manage that risk factor and medically control? So the surgery was well done.
Yes, sir. So the most commonly postulated theory is that because anemia can result in a volume overload condition, it increases the cerebral blood flow. It can cause an elevation of the intracranial pressure and subsequently increased can cause IIH. But in this patient, since the patient was already having constriction of her visual field, so we couldn't wait till because anemia correction can also take it's a chronic treatment, so it can take a prolonged time. So it was seen that her papilledema was progressing despite starting on anti-edema measures. So that's why a surgical intervention was preferred in this case.
Yes, and is there something different you would do in an ONSF, for this case versus, let's say, an ONSF where there is a TBM or something else that is causing the papilledema to cause a vision loss, or rather the reverse?
Sorry, sir, I couldn't hear.
Yeah. So when you're doing an optic nerve sheath fenestration for a cause like, let's say, a TB meningitis or some other cause of raised ICT, versus when you're doing it for IAH for an ID or a vascular cause, is there a difference that you would do in terms of your procedure? Typically in these situations, you can get away with a small window also. Because in things like TBM or other things that are causing exudative changes, you have a lot of pockets in and around the optic nerve that could still cause the nerve sheath to continue to have compression in one other pocket. So in these cases, it's always good to make a small window because it's a stopgap measure, and you're looking at this for an interim period while you're taking care of the systemic. So in these cases, small windows, single windows are what you look at.
Okay.
All right. Yeah. Thanks. Great.
Thank you.
So your voice is not audible, sir. Deep, sir.
Can you stop?
Am I audible? Am I audible? Hello?
Yeah,
Yes, sir,
audible.
you're
Dr.
audible.
Pooja, it was a very nice video which you actually demonstrated. I have to congratulate you on that. The thing is that, like Digvay sir said, can we actually call it a benign essential, because we already are, having a reason and deficiency. And one more thing, did you measure the weight of the patient or anything?
Yes, sir, it was measured. Her BMI was 24.7. Her weight was 60 kgs.
Was it
She was
okay? So
it
was
was
it
not within the normal range for her age. So it was
okay. Okay. Yeah.
Sujit, sir. Sujit, sir.
I don't have any question.
Yeah. Okay.
Just I just have one small query. Like, is it for benign intracranial? Is there a rationale that we do this as a first line, sir? I'm just having a query for the judges. Usually orals, and then if it doesn't, then tap, and then you go for
Yeah,
this.
I just wanted to ask Dr. Pooja, what is the risk of vision loss in cases of optic nerve sheath fenestration? What is when you are doing surgery in a seeing eye, obviously you might have explained the complications. So what are the chances that the patient might lose vision? What is the percentage rate?
There have been reports of vision loss post ONF surgery, sir. So I'm not very sure of the exact percentage, but cases have been reported of patient having sudden vision loss post ONF, probably due to optic nerve ischemia or this.
And did you stop the oral acetazolamide before doing optic nerve sheath fenestration?
No, sir, it was not stopped.
Because basically, whenever you are doing optic nerve sheath fenestration, you want the optic nerve to be taut.
Okay.
So you have to stop the medication. Otherwise, the pressure will come down, and whenever you're doing a puncture, there is a risk
The
of injury to the nerve.
Okay.
Most of the vision loss that happens in the cases of ONSF is because of a bleed or a hematoma that develops around the optic sheath. It's not so much the touch of the nerve that because the surgeons are fairly careful on that. But if you don't have enough of a cuff of fluid around the nerve, then that is risky. So as you want the ICP to be high, you want, as he said and correctly said, and you want there to be a cuff of fluid, and you also be very careful that you're not touching any of the vasculature, and which is why I said then when you have an IDA based ONSF, your vessels are engorged. There's a lot of flow. So that's the risk is of a hematoma, the sheath, and that could lead to vision loss. But fortunately, I think that it was looking quite okay there. So, all right. Anyway, good case.
Thank you, sir.
Thank you, judges. We can, I think, switch over to the next participant, Dr. Gautam. Yeah.
Sir, is my screen visible? Am I audible?
You're perfectly audible. Your screen is clearly visible. You can go ahead, Dr. Gautam.
Okay. I'll be presenting my case, which is early Parkinsonism, misdiagnosed as ocular myasthenia gravis. So our patient is a woman in her late 60s. She came for a routine checkup post bilateral cataract surgery. Her best corrected visual acuity was 20/20 in both eyes. Her past medical records showed that she had a history of diplopia, for which she was diagnosed with ocular myasthenia gravis, which resolved with oral neostigmine. So the patient was on tablet neostigmine 15 mg thrice daily for the past 1 year before presenting to us. On examination, we noted both eyes europhakia. Her right eye showed 4.5 millimeter pupil, not reactive to light, and her left eye showed 3 millimeter pupil, reactive to light. There was no ptosis when the patient presented to us, and the extraocular movements were full and free in all directions of gaze. The rest of the anterior segment and dilated fundus examination was within normal limit, and gross neurological examination showed no focal neurological deficit. So there was inconsistency with myasthenia gravis because it typically spares the pupils. So we decided to confirm the diagnosis of myasthenia gravis. Anti-acetylcholine receptor antibodies were negative. MuSK antibodies were negative. Repetitive nerve stimulation showed no decremental response. MRI brain showed small vessel ischemic changes consistent with the patient's age. HRCT thorax showed no evidence of thymus, and thyroid function tests were within normal limits. So we ruled out ocular myasthenia gravis. We couldn't do ISPAC test because on presentation the patient did not have ptosis. So on further careful physical examination, we noted mild rigidity, slight bradykinesia, and slight tremors. So we took a neurology consultation and we ordered for TRODAT nuclear medicine scan. This TRODAT nuclear medicine scan is done for assessing the dopaminergic function of the brain. This is the normal TRODAT brain scan. You can see that the basal ganglia is highly active, whereas in our patient, the TRODAT scan shows decreased uptake, indicating dopaminergic dysfunction. So this led us to a diagnosis of early Parkinsonism in our patient. So we decided to do further ophthalmic workup for Parkinsonism. We noted that her blink rate was slightly reduced. Subsequently, her tear film breakup time was also reduced. So she was started on lubricant eye drops. She also had slower saccadic eye movements compared to a normal patient. And her near point of convergence showed that she had slight convergence insufficiency. So coming to the management, she was initiated on pramipexole 0.25 mg thrice daily. The patient remained stable and there was no recurrence of diplopia. So coming to early Parkinsonism, the key motor features are tremor, bradykinesia, and rigidity. Ocular features include reduced blink rate, difficulty with saccadic eye movements, diplopia, decreased pupil reaction, and rarely it can present with ptosis. There will also be mild cognitive changes and mood disorders. So the diagnosis of early Parkinsonism is based on clinical examination and the response to dopaminergic therapy. Imaging techniques like SPECT can help assess dopaminergic function, like in our case. The management is by dopaminergic medications like levodopa and pramipexole. So numerous articles have reported cases of Parkinson's disease and myasthenia gravis occurring concurrently in the same patient. In our case, ocular myasthenia gravis was ruled out with comprehensive investigations. By improving neuromuscular transmission and reducing muscle fatigue, oral neostigmine could have alleviated diplopia in her case, but it had a lot of side effects to our patient. So the take-home messages are: cases of early Parkinsonism can present to the ophthalmologist first. The features include reduced blink rate, difficulty with saccadic eye movements, diplopia, and decreased pupil reaction. It is necessary to differentiate it from other mimicking ocular conditions, and timely intervention can slow down the progression of Parkinsonism. These are my references. Thank you.
Great presentation, Gautam. Over to judges. Digvijay.
Can you stop sharing?
Yes. Great presentation there. So the MRI scan that you had said basically you were mentioning it to be ischemic changes. So was it really ischemia, or was it just age-related atrophy or Parkinson's-related cerebral atrophy that was happening there?
Those were just age-related changes, sir. That was Prasek grade 2, so it was only age-related. She was already 67 years old.
No ischemia related. I thought I heard that there was some ischemic changes or something as well. And see, one can never probably be 100% sure that there is no coexisting myasthenia gravis, particularly in the early cases. But I think that said that what is the kind of follow-up that you're going to keep for this patient now?
Actually, right now, pramipexole was started 1 month back. She's still maintaining. So we are planning to keep her on this dose. If she's not tolerating pramipexole, we'll plan to reduce the dose or hike up the dose depending on her response. Right now, she is stable.
All right. Okay, great.
Dr. Gautam, in your presentation, you had shown that neostigmine test was positive, right?
Actually, she responded to neostigmine. We were not very sure of the exact pathophysiology, but probably because we didn't do neostigmine test per se. Outside, she was started on neostigmine.
Neostigmine or pyridostigmine? Because usually they give on oral pyridostigmine.
She was started on neostigmine, sir.
Okay, neostigmine they had given. And with that, she had improvement.
That's what she subjectively says. We hypothesize that probably by improving the neuromuscular transmission.
And ocular motility examination, was the squint only for near or it was for far? I mean, diplopia only for near or was it there for far also?
When she presented to it, she didn't have any diplopia.
She was on oral neostigmine.
Neostigmine.
Okay. I think it's a coexisting condition. Maybe the patient might be having coexisting ocular myasthenia along with this thing.
That's what we also.
But you have started on Parkinsonism medication also. Even with the Parkinsonism medication also, this diplopia resolves in patients with early Parkinsonism.
Yes.
What's the incidence of Parkinson's patients presenting with ocular problems? Like
actually,
it's uncommon.
Initially presenting to the ophthalmologist is actually very uncommon. So I'm not sure of the exact incidence.
Yeah, so it's very uncommon. There's likelihood that because already the patient is giving history that the patient was started on neostigmine, or it should be ideally pyridostigmine, but that means possibly the patient has an overlap itself. There might be a possible overlap.
Okay, but from our side, all the investigations turned negative. That's
okay. But
it can, I mean, seronegative ocular myasthenia can also be there in few cases, which neurologists start them on as a trial basis. They start, and if they see improvement, they continue this pyridostigmine. Few neurologists do like that also.
Okay, good case.
Thank you.
Thank you, judges. Now we go to our next presenter, Dr. Disha Agarwal. Dr. Disha?
Yes, sir.
I think, yeah, can you start your screen share?
Yes, sir. Just. Can you see my screen, sir?
Not yet. You have to just go down and pick the screen share, that green color arrow button. Up, put this arrow. Yeah, it's started. Then you can do full screen slideshow.
Yeah. Can you see my screen, sir?
Yeah, we can see your screen.
Good evening, everyone. I'll be presenting a case of arthritic anterior ischemic optic neuropathy as an initial presentation of Takayasu arteritis. So we have a case of 31-year-old female who presented with a sudden painful loss of vision in her left eye for last 2 weeks, which was associated with left-sided temporal headache. There was no other significant history. There were no history of previous similar episodes or episodes of giddiness, neurological weakness, joint pains, or fever. She had an episode of outside consultation for which some laser was done in the left eye, but there were no records available. On examination, in the right eye, her vision was 612, and in the left eye, it was perception of light present, which projection of rays inaccurate in 2 quadrants, and left eye showed grade 3 RAPD. On fundus examination, we could see a small disc in the right eye with microaneurysms over the posterior pole, and in the left eye, we could see again pallid disc edema with laser marks in inferior temporal and nasal periphery. We went ahead and did a fundus fluorescein angiography, which revealed microaneurysms over the posterior pole in the right eye and sectoral filling defect in the left eye, along with microaneurysms in the posterior pole. We basically had a case of a young female who presented with sudden painful unilateral loss of vision associated with headache. And on examination, her vision in that eye was PR inaccurate, grade 3 RAPD with FFA revealing microaneurysms in both the eyes and a pallid disc edema. So we went back and did a general examination, which revealed that the blood pressure in both the upper limbs was not recordable, with normal blood pressure in both the lower limbs. And on pulse examination, we got feeble pulses in both in bilateral upper limbs and carotid artery. Rest general and systemic examination was within normal limits, and there was no evidence of pallor. So we went ahead with systemic workup. Blood examination revealed there was elevated leukocyte count, platelet count, and raised ESR. Hemoglobin was 8.9, which was below the normal level. And a CT angiogram revealed diffuse circumferential segmental thickening and vascular occlusion of the thoracic aorta, left carotid artery, and subclavian artery. Left carotid artery and vertebral artery and bilateral subclavian arteries. So we made a diagnosis of both eyes, Takayasu retinopathy with left eye arthritic AION with Takayasu arteritis. It was basically fulfilling 4 out of the 6 criteria of American College of Rheumatology, and ETA score was 15. So basically, the management included blood workup and CT angiogram followed by an immediate immunology opinion, and treatment included intravenous methylprednisolone 1 gram OD for 5 days followed by a slow taper. Coming to the discussion, so Takayasu arteritis is a granulomatous large vessel vasculitis predominantly affecting the aorta and its branches and pulmonary and coronary arteries as well. It is basically seen in 3rd to 4th decade of life with a female predominance. Ocular involvement is seen in around 45% of cases, with most common presentation being Takayasu retinopathy. Also, it has been noticed that in 74.6% of cases, ocular involvement is the first manifestation which leads to the diagnosis of Takayasu arteritis. Ocular involvement is secondary to basically two pathology. First is most common is involvement of carotid arteries, which leads to hypoperfusion, which can cause ocular ischemic syndrome and ischemic optic neuropathy, and then systemic hypertension. There have been stages described for Takayasu retinopathy, which is basically dilatation. 4 stages have been given: dilatation of small vessels, second is capillary microaneurysm, third is AV anastomosis, and fourth is ocular ischemic syndrome. So the take-home message in our case was that it basically highlights the importance of a detailed fundus examination in cases of disc edema. Like in our case, if we would not have done a closer examination with a 90 diopter or 78 diopter lens, we would have missed the microaneurysms and we would not have gone back for a detailed systemic workup. Takayasu arteritis, being a multi-system disorder, can have varied modes of presentation, and therefore a detailed ocular and systemic examination is important to correlate the findings at the first presentation of the patient. And also the importance of compliance to treatment and follow-up has to be explained to the patient, since it is a chronic inflammatory disorder which may lead to further deterioration of the disease as well. Thank you.
Nice. Yes. Can you stop your screen there, judges?
Yes, it was well presented. So was the CRP done? I missed. I think you mentioned the ESR, but did you look for other blood inflammatory markers?
Yes, sir. CRP was also done. It was also elevated. But like the treatment was started before we got the CRP results itself, because since it being a emergency condition.
Okay. And in terms of Takayasu, in cases of Takayasu, is it
I did not get.
which is more common, or is it actually the ischemic neuropathy more common?
Sir, can you
More
please
frequent?
repeat
Am I
the
audible?
question? I did. Yeah.
Yeah.
Can
Can
you
you hear
please?
me?
Yeah, I can hear you now. Can you
Yeah,
repeat the
I said,
question, please,
yeah,
sir?
I said, is it generally is it in so Takayasu, the commonest thing that you'll typically get is retinopathy changes followed by the ischemic changes, in the optic nerve or ocular ischemia that comes a little less lower down. So
Yes,
yes, the
sir.
retina must always be examined.
Yes, sir.
And as you rightly did, that the steroid dosage here is you to give beyond what you would give for the ONTT or other forms of steroid.
Yes,
It's
sir.
much higher, 1.5 grams or even more. In
Yes,
terms
sir.
of mg per kg, you would go for much higher as well.
Yes, sir.
But so that was rightly done. Yes, the CRP is an important parameter. We must immediately write ESR CRP whenever we suspect this
Yes, sir.
arteritic changes. All right.
I think I don't have any questions unless Sujit has any, so we can move on.
I too don't have any question. It was a nice presentation.
Nice presentation, Dr. Disha.
Thank you, sir.
Next presenter, can we move to Dr. Arut Priya, please? Arut ma'am, are you there?
Yeah, yes, sir. Yes, sir. 1 second. Is my screen visible, sir?
Yeah, you can start.
Hello, my screen is visible?
Yes, you can start.
Okay. Good evening, all. So I'm going to present a case of congenital versus acquired optic disc pit and how to analyze based on the OCT finding. So first patient, a male patient, 45-year-old, who has come for regular examination. His vision was 6/6 and anterior segment was quiet. When you see his fundus picture in the right eye and both in the right eye and the left eye, inferior temporal, you can appreciate a gray-white defect with a corresponding RNFL loss. So optic nerve at OCT was done for this patient. So when we run over this defect, closely watch this area. So where you can see her deep excavation involving that particular area. So corresponding to that area, you can again see an MRW thinning with an early loss of an RNFL. So posterior pole analysis of this patient shows loss of a papillomacular bundle with an corresponding GCL loss. So for this patient, a wood map was done. The wood map is nothing but it helps in predicting what will be the future field effect corresponding to the GCL loss. So it shows the involvement of an papillomacular bundle area. So he might develop a centrocecal scotoma if there is any serous detachment. So this is a case of a bilateral congenital optic disc pit. So second case, 48-year-old female patient who has been treated as an NTG. She has come for a regular follow-up. So when you see the fundus picture, right eye 0.75 cupping with an inferior RNFL defect, and the left eye 0.8 cupping with an more widened RNFL defect. When you have a close look of this inferior pole, you can see a grayish white slit involving the inferior pole. So optic nerved OCT has been done for this patient. So corresponding to this defect, you can appreciate a shallow discontinuity in the NRR. So corresponding to that area, there was an MRW thinning with an RNFL thinning and complete washout of the GCL. So the field defect shows deep scotoma involving the fixation. So this is a case of a normal tension glaucoma with a left eye acquired optic disc pit. So normally this optic disc pit is nothing but a gray-white excavation in the optic disc area, which can be a congenital due to a incomplete closure of the embryonic fissure, whereas an acquired you usually seen in an NTG. This indicates that there was some previous ischemic changes occurred over that area. Maybe a Dran's hemorrhage also present in that area. So congenital usually a unilateral and 15% are bilateral. In OCT, you can appreciate this deep excavation, whereas acquired can be again unilateral or bilateral. The excavation will not be much deep as compared to the congenital. So usually the site is inferotemporal for congenital, whereas in acquired it's either an inferior or superior corresponding to the arcade fibers. So the papillomacular bundle usually involves the GCL loss usually involves the papillomacular bundle in congenital, whereas in acquired it can be in either or superior or an inferior arcade fibers. So mostly these patients will be asymptomatic, whereas the acquired disc pit, they will have a deep scotoma involving the fixation. So that's all. Thank you, sir.
Thank you, Arat, madam. Well on time. Moving on to judges. Digvijay sir, Deep sir.
Nice presentation, Dr. Arut. Well, usually what I think of that most commonly acquired ones associate with glaucoma, and glaucoma is the intraocular pressure is the higher intraocular pressure is responsible for this pit to develop, what I can recollect. So anything you want to add on to that, or am I wrong? Anything else other than the glaucoma which can cause an acquired? Is there anything else?
I think the cause is very often vascular as well, as she's saying, right? There is
yes.
It's beyond just it's beyond just the mechanical aspect.
So your voice is breaking, I think.
Dropout that's happening that is causing it there. So yeah, can you hear me?
Yeah, yes, yeah, better now.
Yeah, I said it's so basically I think from what is coming out is that it's actually the cause is more like a dropout that's happening there and vascular rather than just a mechanical, and which is why this is different from what we are getting in the congenital ones.
Yes.
And while in glaucoma also, as our understanding is going up, it is actually we're realizing it's a lot beyond. It's a lot more of vascular than other causes.
Going towards vascular.
Correct.
The reason is becoming more vascular. That's what I was asking. So.
Achha, I thought she was not answering, so I was trying to.
I thought he's asking the other judge. I didn't.
Okay. Sorry. So anyways, now we know. So that's a good case. Much initiates that discussion.
It's a very good case. Otherwise, yeah.
Yes.
You have beautifully demonstrated the differences between them, how they typically represent, and what the locations are. So yeah. What I wanted to add was like that initially it was believed that glaucoma is the thing which was responsible, but with studies it's becoming that the reason which is coming out is ischemic damage to the areas near the disc.
Sir, actually she's a normal tension glaucoma. She's been a 1 year follow-up, so her IOP was around 17-18 only. So maybe as he said, it's an ischemic cause that causes changes in the NRR. So any patients, we have evaluated other patients where they had a trans hemorrhage and resolved. In those patients also, they developed a pit over that particular area where they had a hemorrhage.
Basically, focal RNFL loss to be there whenever there is hemorrhage in that area, right? Did you evaluate what is the? Did you evaluate any systemic cause for this normal tension glaucoma in this patient?
Sir, our pulmonary evaluation was done. There is no history of any sleep apnea. Other than that, there are no other systemic illness, sir.
Okay. Very nice presentation.
Nice presentation. We'll move on to the next speaker. We'll invite Dr. Nupur. Welcome.
Hi, good evening, everybody. So I'll just start sharing my screen. Yeah, my screen is visible and I hope I am in slideshow mode. Yeah. So very good evening, everyone. At the outset, thank you all. I'm Dr. Nupur, and today I'll be presenting a case titled Piece the Puzzle. Often you will not know it's there and why it's titled so. That we'll come to know as we move on. So these are my acknowledgements. So this was a 9-year-old male child who presented with a left eye pain, swelling, discharge near the lower lid since 2 days, and he was on oral and topical antibiotics. He had these recurrent episodes since 2 years. The syringing was documented patent since 2012, and the last one was done in 2015, which was elsewhere. The rest of the ocular and the systemic history was insignificant. On ocular examination, the visual acuity was within normal limits. On examination, there was a left eye lower lid swelling, which was tender, and there was matting of eyelashes, as can be seen in the external photographs. The rest of the ocular examination, anterior segment and posterior segment, was within normal limits. So clinical diagnosis of left eye acute and chronic recurrent dacryocystitis with patent syringing was made. So as we know that, dacryocystitis and nasal lacrimal duct obstruction is a vicious cycle. So, but a nasal lacrimal duct obstruction would lead to a syringing which is not patent. So here came the first piece of a puzzle, which is acute dacryocystitis with patent syringing. We decided to investigate this further. And what we found were the differentials for acute dacryocystitis with patent syringing. One was atonic sac. The other was infected ethmoid air cells, which mimic acute dacryocystitis. The cryolids, and also certain congenital anomalies of the lacrimal system, like lacrimal sac diverticulum. So we decided to move on to the next piece of the puzzle and requested for a CT dacryocystogram of the patient. And we found that there was a filling of the lacrimal sac on the left side with the extra filling from outpouching from the lacrimal sac, as seen by the red arrow. And with these two pieces of puzzle, we were now fairly clear that we were dealing with a lacrimal sac diverticulum. So lacrimal sac diverticulum has been, there have been limited case reports and case series in the literature. So lacrimal sac diverticulum, from what we found in the literature, is basically outpouching which communicates with the lacrimal sac. The etiology can be congenital, traumatic, or inflammatory, the most common being congenital. So congenital white occurs during the 6th week of embryogenesis, when the lacrimal system is developing. There is extra imagination of the ectoderm cells, which leads to this outpouching and leading to the lacrimal sac diverticulum. So it has been noted that many people have this diverticulum, but it often goes unnoticed because it is asymptomatic. So that is why my presentation is titled, "Often you will not know it's there." And so congenital lacrimal sac diverticulum, when it is large enough, it causes pressure symptoms. And if it causes tearing and discharge. It is fixed to the deep tissue, but not to the skin. It is tense and fluctuant when clinically apparent. It is lateral to the lacrimal sac because that is where the space is there for the outpouching to grow. And the dacryocystogram is necessary for diagnosis. So coming back to our case, our next piece of puzzle was management of this case, which we managed by a diverticulectomy. I'm just putting snippets of the surgery because of paucity of time. So a theater of incision was made. So syringing, when it was first done, it was not patent. As you can see, regurgitation of the fluorescein dye. The diverticulum was excised from the underlying tissue and the lacrimal sac. And then a communication, if you can see in the photograph, was noted between the lacrimal sac and the diverticulum, which was closed off, and suture and syringing at the end was patent. So this was the post-operative day 1 picture, post-operative day 1 week, and at 3 months, the patient was asymptomatic. So the excised tissue was sent for histopathology, and the lining of the tissue was noticed to be a stratified columnar epithelium, which was corresponding to the lacrimal sac lining, and this clinched the diagnosis of our 4 pieces of puzzle together, and thus we had our diagnosis of lacrimal sac. We pieced the puzzle of lacrimal sac diverticulum. So the take-home message, puzzle by piece by piece, is acute dacryocystitis with patent syringing. Lacrimal sac diverticulum is a rare but important cause of dacryocystitis and should be kept in mind. Imaging like a CT dacryocystogram is an important diagnostic tool in suspected cases of lacrimal sac diverticulum. And diverticulectomy may suffice alone, and it may prevent the need for DCR surgery. What is essential for diagnosis is the pathology of the cystic wall should be identical to the lacrimal sac. So thank you so much. With this, I end my presentation. Thank you.
Thank you, ma'am. Now over to the judges.
Yes. Thank you, Nupur. That's an interesting presentation. Is there any role, I mean, this is more from my understanding, any role of atony of the sac, which is also responsible for this in these cases, or it's basically more like an anatomical thing?
So it's more of an anatomic thing. So as I mentioned that most people have this diverticulum, but unless and until it is large enough to cause pressure symptoms, it often goes undetected. So atonic sac is one of the causes for dacryocystitis with a patent syringing. So yes.
Right. Okay, yeah. Thanks. Great presentation. Yeah. Something to learn today for me too.
Nice
Ma'am,
presentation.
what was the last follow-up of the patient, ma'am?
So last follow-up, so this case I had seen during my fellowship with Dr. Tarjini. So when I passed, I had already finished my fellowship. I did follow up on the patient. So I think it was 1 or 2 years. I did ask the fellows over there. The patient was asymptomatic and doing well. They had sent me the EMR snapshot. So the patient was doing. Yes.
So usually in such scenarios, do they have watering? Like epiphora will still persist, right? Like because it only is not going to go away even if you remove the diverticulum.
No, so this patient, the epiphora had resolved.
Okay.
So the atonicity of the sac, what I believe is that it goes off once the your drainage system starts functioning. With some time, the atony of the sac also sorts of it resolves.
So it was the diverticulum was like it was creating another passage. So the fluid was getting collected somewhere else.
Was
What you're trying to
the
say?
passage was sutured. Yes, yes. At that hole that I showed, we closed that hole as well. The communication was closed.
Basically, in this,
did you place any canicular stent or something just to ensure that? Was there any need of any roll of any canicular stent or master stent, something, just to ensure that the
because
sac
the
is still
syringing was patent at the end.
okay? Even there was no need for it. Okay, yeah, obviously, absolutely.
And the dictum is that
I
if
understand.
it had gone into a repeat thing, then we would have probably
nice presentation.
Yeah. Basically, I think the outputs which are developed congenitally was getting inflamed in between and it compressing that area, and swelling was happening. And simple removal of that was sufficient in this case.
So what is
But
also
I had a couple of patients in whom after surgery also there was after DCR also there was recurrence. So that's why I was asking what was the last follow-up of your patient.
Yeah. So just a learning point, that's what I've learned from discussing the case with people is that one of the causes of your failed DCR could be a diverticulum which has gone unidentified. So that is something you need to keep in mind. So that
especially in young patients.
Yes.
But in older patients, I mean, chances are there that even if you don't excise the diverticulum also, even if the surgery fails, the patient will only have epiphora. Unlike in younger patients where they might have recurrent dacryocystitis.
Correct. Yes.
Okay, ma'am. Very nice presentation.
Thank you, Nupur ma'am.
Thank you for the opportunity, everybody. And yeah.
Thank you, ma'am, for an enlightening case, and thank you, dear judges. We'll move to the next speaker, Dr. Miriam.
Am I audible, sir?
Yeah.
So is my screen visible, sir?
Yes.
You can start, doctor.
I'll be presenting a very good evening to one and all. I'll be presenting on a rare case of orbital schwannoma, a surgeon's surprise. Schwannomas, also known as neurilomomas, are benign tumors originating from Schwann cells typically found along peripheral nerves. While they can develop along any nerve, the eighth cranial nerve is a common site. Orbital schwannomas are rare, comprising only 1% of orbital neoplasms. We were presented with a challenging case, which is as follows. A 53-year-old female presented with protrusion of the left eye over the past 2 months. The onset was gradual and progressive. There was no history of transient obscuration of vision, palpitations, tremors, weight loss, diplopia, eye pain, photophobia, flashes, floaters. There was no significant past or personal history. There was no history of thyroid disease. On general examination, patient was moderately built and nourished. Systemic examination, all systems were within normal limits. Ocular examination, the head posture was erect. Extraocular movements were full and free in both eyes. On inspection, navsigal sign was positive. On palpation, orbital margins were intact. We were able to insinuate the finger around the globe. Resistance to retropulsion was positive. It was a non-reducible proptosis. There was no warmth, tenderness, thrills, or lymphadenopathy. On auscultation, there was no growing. A proptosis measurement was done and was found to have an absolute value of 20 millimeter in the right eye and 22 millimeter in the left eye, with a relative difference of 2 millimeter between both eyes. Vision aided in both eyes was 6/6 and 6. Color vision was 16/16. Intraocular pressure was 14 millimeter mercury in both eyes. Slit lamp examination was within normal limits in the right eye. Left eye showed mild proptosis of axial type. Pupils and lens were normal. Fundoscopic evaluation in the right eye was normal. Left eye showed mild pallor of the disc. We went ahead and performed an MRI orbit, which showed well-defined round altered signal lesions with fluid levels and septations in the left intracorneal retrobulbar space, which mildly displaced the optic nerve. The radiological features were highly suggestive of lymphangioma of the left orbit. We came to a provisional diagnosis of left eye intracorneal space cyst measuring 21 into 19 into 20 millimeters. We went ahead and performed a left eye lateral orbitotomy with complete excision of the cyst under general anesthesia. A single gray-white globular cystic soft tissue was excised and sent for histopathological examination. This is a picture of the patient pre-op, followed by a picture post-op. On histopathological report showed Antony A pattern, which was hypercellular with bundles of fascicles of compact spindle cells and Verrucay bodies arranged in palisades, and Antony B pattern, which was hypercellular and less organized vacuolated cells arranged in sheets within a myxoid or microcystic matrix. Immunohistochemistry was performed and was found to be strongly positive for S100, mildly positive for CD34, mildly with a low index in Ki67. Epithelial membrane antigen was not positive. Glial fibrillary acidic protein was mildly positive. The features following histopathological examination were more in favor of a benign tumor of neural origin, suggesting an orbital cystic schwannoma. In this case, clinical and radiological investigation suggested a lymphangioma, probably due to its similarities with schwannoma of intracorneal location, growth pattern, well-defined borders, cystic lesion, characteristic enhancement patterns. Therefore, we can say lymphangiomas, also known as lymphatic malformations, are multicystic localized malformations that involve the lymphatic and vascular systems, whereas cystic schwannomas is a type of conventional schwannoma but has degenerated microcystic and myxoid areas that have coalesced to form a macrocyst seen on low-power microscopy. We conclude by saying that in diagnostic dilemmas such as this case, though clinical suspicion was high and radiological investigation suggested to be a case of lymphangioma, the final diagnosis was confirmed as cystic schwannoma only histopathologically. A timely excision biopsy was crucial in preventing a potential vision loss. Thank you.
Can you stop sharing, ma'am?
Yes, sir.
Thank you. Now to the judges.
I think this case is definitely demonstrating that the power of a tissue diagnosis or a tissue biopsy that's there in terms of making the diagnosis. But was there any were there any clinical signs in terms of your differential as to why you were thinking of lymphangioma versus this to begin with? What else would you have seen if you didn't have the tissue diagnosis?
So lymphangioma is usually more common in children, so we did not have that as a diagnosis initially. We knew that's an intracorneal space cyst, but on radiological examination, because it was a cystic lesion, it was confused to be lymphangioma. So we were still apprehensive about it because of the more probability in a pediatric age group. So we were keen on getting a histopathological examination done.
Right. But clinically, there wouldn't be very easy to differentiate between the two, is it?
Yes. Clinically, it would be more difficult, sir, since it was it both show a gradual progressive onset. One of the differentiating features is the age of onset, sir.
Right. So obviously, it was not there in the earlier. The onset was much later. So
yes, sir.
Okay, interesting. But I think probably the other judges would have something more to say in oculoplasty. But
so the lymphangioma which you have kept as a differential, was it your diagnosis or was it a radiologist diagnosis?
It was a radiologist diagnosis, sir. We knew that it's an intracorneal cyst, sir, because of the axial proptosis, and we had it in one of our differentials.
What else the differentials you had?
We had the differentials of cavernous hemangioma, meningioma.
Meningioma, I mean, it should be fusiform enlargement along the optic nerve, right? It was separate from the optic nerve.
No, sir. Before the radiological investigation, clinically we had. I
mean, after radiological investigation, at the end, before going to surgery, I'm asking.
After radiological investigation, we felt it could be lymphangioma. Since it was cystic, sir, we thought it could be lymphangioma or it could be something of cystic origin, like cystic
There
orbital.
was in MRI, you could see different levels of contrast, right? So
Yes, sir.
it was kind of why basically the radiologist thought of lymphangioma because of the fluid levels.
Fluid levels, cystic fluid levels.
So even in one condition, if you can tell what is the condition where you will see solid fluid level. Can you name that condition? That is also a closed differential, I mean, which you should have kept. It's an orbital dermoid where
Yes,
there
sir.
will be a different consistency. So there will be a solid fluid level.
Okay, sir.
Okay, and there is a condition, I think, adult onset lymphangioma. Characteristics will be different.
Yes, sir.
From which nerve do you think this schwannoma might have arisen?
The optic nerve sheath, sir. Peripheral.
Optic nerve sheath. Okay, that's very rare.
Yes, sir. This is it's rare. Usually, it's in related to the eighth cranial nerve. But
Related, I mean, the nerve of origin is usually from the extraocular muscles, whichever nerves come from there. From those nerves it comes, or from the ciliary nerves. Rarely, very rarely from the sympathetic vessels, sympathetic nerves around the ciliary vessels, from which it arises. We call it as optic nerve schwannoma.
Yes, sir.
Okay, nice presentation.
Thank you, sir.
No questions from my side. Sujit has already, I think, discussed most of it.
Thanks.
Yeah. Okay.
Yeah, nice presentation. We might move on to the next presenter. Yeah.
Abhishek Paul.
Am I audible?
Yes.
Yeah.
Okay, so is my screen also visible?
Yes.
So, good evening, everyone. Thank you for this opportunity. I will be presenting on the topic mystery of the cyst. So, conjunctival cystic mass is not an uncommon clinical scenario after strabismus surgery. Common differentials include inclusion cyst, pyogenic granuloma, extruded Tenon's fascia, and parasitic cyst. Management options vary depending on conservative means surgical options, which are customized for each patient. So we present a case of an 11-year-old girl who presented to us 2 months after squint surgery done elsewhere with recalcitrant swelling and redness in the lateral part of her operated left eye. She underwent left eye medial rectus recession and lateral rectus resection for esotropia. She developed swelling with redness and pain 2 weeks after surgery, which persisted despite medical management by the operating surgeon. There was no history of trauma. On examination, her best corrected visual acuity was 6.6 partial in right eye and 6.9 partial, 6.9 in the left eye with respective cylinders. Alternate prism cover test revealed 10 prism diopters of residual esotropia for distance and 14 prism diopter for near in primary gaze. There was no limitation of ocular motility. Slit lamp examination showed well-delineated cystic mass measuring around 3.5 to 3 millimeters square at the insertion of lateral rectus muscle, which showed no improvement. Rest of the anterior segment and fundus examination as well as other eye examination was within normal limit. So clinical diagnosis of inclusion cyst was made and the lesion was surgically excised in toto. However, within a week, the swelling recurred and patient developed intense redness and pain in the operated eye, as shown in this figure. Anterior segment and dilated fundus examination with IOP was noted to be normal. Other eye examination was also normal. At this point of time, B scan was advised, which showed a well-defined cystic space with clear fluid without any hyperechogenicity within the lateral rectus muscle. Considering the acute exacerbated clinical picture with high possibility of infection, the diagnosis of extraocular muscle cysticercosis was given a consideration. Patient was started on combination therapy with albendazole and prednisolone along with topical loteprednol and lubricants. Clinical improvement was noted within 2 weeks, and after the entire duration of 6 weeks, the swelling, redness, and pain subsided. Other examinations were also done. Patient was also referred to pediatrician for systemic evaluation. She maintained a quiet anterior segment after 3 months following termination of medical therapy. Coming to discussion, Cystic mass, which is conjunctival, can be primary or acquired. Acquired can be following trauma, inflammation, or surgery. Conjunctival cyst has been described after all ocular surgeries. Most common etiology after strabismus surgery is a retained or inclusion cyst, but recurrence is very rare after a thorough removal. Due to the rapid recurrence, painful clinical picture, and patient being in Indian subcontinent, alternative diagnosis of cysticercosis was considered. As compared to literature review, in our case, presenting features were conjunctival mass with inflammatory signs. B-scan appearance was of an active or viable cyst, which has been shown to be susceptible to oral antihelminthic therapy. The treatment has been different in different studies. Most studies have included combination therapy. Some have also included double dose oral albendazole. We have included conventional therapy of albendazole with prednisolone in tapered doses. The time to resolution was also around 42 days in our study, which is slightly less as compared to the other studies of 65 days. Take-home message is that high index of suspicion should be kept for diagnosis extraocular muscle cysticercosis in a young patient with conjunctival mass. And in these cases, B-scan is of diagnostic utility. These are my references. Thank you.
Great, Dr. Abhishek. Now over to the judges. Deep sir, Sujit sir.
So this was what purely conjunctival cyst that cysticercosis that you're saying?
Sir, it looked like a conjunctival cyst in the beginning. When we excised it thoroughly, after that it again recurred. That time it was slightly below the level of conjunctiva, in the outer layer of extraocular muscle.
Okay, so
it
started on albendazole, but was any steroid started prior to it or any other imaging?
Steroid we started on albendazole 400 mg along with prednisolone, which was tapered in 6 weeks.
Okay, an MRI was performed or anything?
CT scan we performed, sir. CT scan brain was within normal limit.
Okay, it was in normal limits.
Yes.
Usually such cysts, they come out on their own. Even if you don't do anything, the conjunctival ones, those which are not limited to the ocular muscles, there are incidences where they usually come out on their own. Because the conjunctiva is relatively thin structure to, and with time, because of inflammation, the conjunctiva gives away and the cyst in toto, they comes out like on its own. That's what I have seen in many cases. But it's an interesting scenario that you have removed it, however it recurred.
Yes,
interesting.
So this was the site where the procedure was also done earlier, is it? The surgical, the squint surgery. Because actually that changes the the nature of the conjunctiva. It becomes more fibrous, more thicker. It's no longer the nascent conjunctiva from where the cyst will be able to come out on its own. That's why probably that it tends to persist. As also the probably, I don't know whether it's also to do with chance that was there, or there was some change in the vasculature because of the procedure that led to a higher chance of it going and sticking itself there. Because but yes, and definitely a rare and interesting case that way. And as you said, you rightly said, I mean, of course the CT is there, but an MRI also works well to rule it out from other places. And it also covered the orbit for you? Was there anything else anywhere else in the orbit, or it was just this single one?
No, sir. There was no other lesion in the CT scan which I did. It was totally.
Right. Interesting, definitely.
Did you start albendazole before getting a CT brain done, or after CT brain was done?
Sir, I started albendazole before getting CT brain done. I thought of the differential diagnosis and ruled more in favor of cysticercosis. I immediately referred the patient for CTs also, but then I started before waiting for the result.
You should never start
You
like
not
that.
have done that in that way, yeah. Because the idea is the point of starting steroid is that in case the patient has neurocysticercosis, which we have not picked up, not always the patient will have CNS symptoms, right? So even if you're not audible, that's why now you have started steroids previously, or you started albendazole first?
Albendazole before.
So if you start albendazole, what will happen? There will be
I started. before CT scan. CT scan, I sent the patient for CT scan. Medical management I started. Concurrently, I started both on albendazole as well as steroids.
There are like
there is chances that the cyst might start
rupture
dying
and lies, and
dying,
that will
and then
invoke inflammation.
the
So
patient
the
will
idea is
have
to
serious
get
attack.
the investigations first done to rule out, that's what the recent literature says. Like you can
What
actually
about
start both of them
the
together, but
retinal
first you
cyst?
should get the investigations done.
Sorry, sir?
Did you rule out any intraocular cyst before starting the albendazole in the other eye or in the same eye? Dilated retinal examination was it done? Because ultrasound you had done in the left eye.
Retinal examination showed no cyst. It was totally normal.
I mean, you had done, right? That's what I'm asking.
Yes,
because Caesar you can get away with, but intraocular cysticercosis, if it ruptures, then the patient will have sterile endophthalmitis, and there are cases described to be ending up with phthisis bulbar. That's why.
Yes, sir. We did the examination. Other eye and this eye was also totally normal. There was no intraocular cysts anywhere.
Yeah. So we always miss doing somehow ultrasound, even though we know that we can pick up cysticercosis in cystic lesions.
Yes.
But somehow we miss. So you are rightfully said in the ending that P scan should be done in the all cystic lesions. And whenever if you diagnose the cysticercosis, just starting albendazole, can sometimes patient come with spontaneous exclusion of the cyst. You need not go with surgery also. And the primary surgery which they had done might not have been required in this case, because the patient came with a presentation of paralytic case of LR. Cysticercosis is known to present as a cranial nerve palsy also, which sometimes people miss.
Yes, sir.
Actually, there's a survey article by Dr. Sujit. He is one of the co-authors. It's I think systematic review of cysticercosis. You can go through it.
Okay.
Ophthalmic and orbital cysticercosis by Sujit himself.
Okay. Thank you.
There's a big table in which all the ocular presentations are written. You can just go through that. Then we need not read any other articles.
Sure, sir. I will do that. Thank you.
Nice presentation, Dr. Abhishek, and nice discussion, judges. Going towards the last contestant, the presenter, Dr. Disha Agarwal. Dr. Disha?
Yes, sir. I am just sharing my screen.
Yes.
Is my screen visible, sir?
Yes, your screen is visible, Dr. Disha. You can continue.
Good evening, one and all. I'll be presenting a case of unusual ocular manifestation in Wolfram syndrome. So we had a patient, 18-year-old male patient, complaining of diminution of vision in both eyes for the past 5 to 6 years. There was no history of any other significant ocular history and no history of previous ophthalmic consultation. The patient was a known case of diabetes mellitus on treatment for the past 8 years. He had hearing difficulties for the last 5 years, for which he was using hearing aids, and he was also diagnosed with vesicoureteric reflux disease for the last 3 years, for which he was consulting a nephrologist. Coming to the ocular examination, his BCVA was in right eye 636 N18 and in the left eye 660 with near vision improving to N18. Pupil examination showed both eyes showed a direct and consensual reactions were sluggish. Lens examination showed that in both eyes zonular cataract was present with a posterior subcapsular component as well. And the fundus examination revealed both eyes optic disc pallor suggestive of optic atrophy. So this was the basically the examination finding, positive examination finding. So we summarized the case to be a 18-year-old male patient who was born out of a consanguineous marriage with complaints of painless progressive diminution of vision in both eye for 5 to 6 years, and he was a known case of juvenile diabetes, vesicoureteric reflux disease, and hearing difficulties. With examination findings being BCVA in right eye 636 N18, left eye 660 N18, both eyes sluggishly reacting pupils, and zonular cataract with PSC and optic atrophy in both the eyes. We diagnosed the case as both eyes developmental cataract with optic atrophy with Wolfram syndrome. Wolfram syndrome was basically diagnosed by the criteria given by EuroVAB, which is a European registry for Wolfram, Alström, and Bardet-Biedl syndromes. The major criteria being diabetes mellitus less than 16 years and optic atrophy in less than 16 years. And minor criteria being diabetes insipidus, diabetes mellitus more than 16 years onset, optic atrophy more than 16 years at age more than 16 years of onset, sensory neural deafness, neurological signs, renal tract abnormalities, loss of function mutation in WFS1 and CISD2 gene, or family history. Basically, the diagnosis needs 2 of the major criteria to be fulfilled, or 1 major along with 2 minor. In our case, there was 1 major criteria, that is diabetes mellitus at less than 16 years of age, and 3 of the minor criteria, that is optic atrophy more than 16 years, sensory neural deafness, and renal tract abnormalities. However, we could not perform a genetic analysis due to financial constraints. We went ahead with lens aspiration with PCIOL implantation in both the cases, left eye followed by right eye, and the vision improved post-operatively to in right eye 624 with near vision and left eye 618. Near vision with a plus 2.5 add improved to N18, N10 in the right eye with N12 in the left eye. Post-operatively, we also performed an OCT RNFL, which showed diffuse RNFL thinning in all the quadrants in both the eyes. A low vision aid for distance was prescribed for the management of the patient. Coming to the discussion, so Wolfram syndrome is basically also known as Didmode syndrome on the basis of the 4 most common presentations, that is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Most common of these being early onset diabetes mellitus and bilateral optic atrophy. Diabetes mostly presents by 6 years of age and optic atrophy by 11 years of age. It has been reported that 1 out of 150 cases of juvenile diabetes with optic atrophy gets diagnosed as Wolfram syndrome. The major pathogenic mutation reported is WFS1 gene on chromosome 4p16 or WFS2 gene, which is also called as CISD2 on chromosome 4q. Classically, Wolfram syndrome has been reported as autosomal recessive. However, autosomal dominant and mitochondrial inheritance has also been reported. Coming to other ophthalmic manifestations, so color vision defect, visual field defects, nystagmus, strabismus, cataract, and pigmentary retinopathy have been reported. Our case had a cataract, which is very rarely reported. So it has like variable in the cataracts have been reported, which are variable in prevalence, type, and also severity. There has been a study which reports 66.6% prevalence, with majority of cases being of snowflake type, whereas there is another study which reports 22% prevalence with various types of cataracts like blue dot cataract, snowflake cataract, posterior subcapsular cataract being reported. So the major pathogenesis of cataract in Wolfram syndrome has been associated, told to be acquired and associated with metabolic disturbances. However, reports of Wolfram syndrome with cataract preceding the diagnosis of diabetes mellitus are also present, which indicate towards a secondary pathogenesis. And also there have been reports of cases with autosomal dominant isolated congenital nuclear cataract in which WFS1 gene mutation have been found, which indicates that there might be some role of wolframin, that is the protein encoded by the WFS1 gene, having a role in the development of lens. However, there are not enough studies to support this pathogenesis, and few further genomic studies might be needed to support the third pathogenesis. So my take-home message will be the importance of appropriate pupil examination in all cases of juvenile diabetes mellitus and childhood cataract cases, because it can also help us to appropriately counsel the parents regarding the prognosis of the case post-operatively. Appropriate fundus and optic disc examination in all childhood cataract cases, both congenital and acquired, and importance of a thorough systemic history and pediatrician opinion if any systemic history is found to be significant. And Wolfram syndrome should be kept as a differential diagnosis in all cases of juvenile diabetes along with cataract. We can have among the other differentials like autosomal dominant optic atrophy and cataract, or maternally induced diabetes mellitus and deafness. Wolfram syndrome should also be an important differential diagnosis in all such cases. Thank you.
Nice presentation, Dr. Disha.
Yes, nice presentation there, and also I think highlighting some important points, and also I think true to the NOI NAADI concept, to seek out the disease and look beyond what else could be there. So I think that does fit in there very well. I think all the case presentations today have been quite wonderful. Now, as you suggested, so there is a challenge because we don't yet understand the pathogenesis fully to why this is actually happening, and therefore we know that all of these is integrated in some form or the other.
Yes, sir.
But what do you think would be the visual outcome for such a patient in terms of the cataract? Would it be something that is progressive? And then finally, in terms of the optic nerve, also we know that there are associations with the neuropathy as well. So,
Completely,
what kind of prognosis?
in my opinion, it completely depends on the grading of the cataract. Like in our case, the patient had a posterior subcapsular component as well. So the postoperative distant vision improved to some extent. But like in the studies that I mentioned, there were some patients who were having solely snowflake cataracts or blue dot cataracts. In those cases, the vision will there will be minimal vision improvement even if we go ahead for surgery, because the diminution of vision will mostly be related to the optic atrophy component rather than the cataract component. So I think the appropriate examination of the cataract grading and then the grading of the optic atrophy is important in such cases.
Yes, I think that's something very important because we do in my neuro-ophthalmology clinic, I do see a lot of children or adolescents who are coming with these, optic neuropathies, and they will have some forms of cataract very often, which are, it's very important to differentiate between the significant forms which require you to do something versus the not so significant forms, because, sometimes they actually don't perform that well because once they lose their accommodation and other things, right now at the moment, they can bring things close to read when they're going to a class or when they're going to read their notebooks and all. And that does get hampered to some extent. So it's actually more challenging. And I've seen that change for a patient who was operated, that he felt he was better off earlier than he was now after that. So and remember, and we're not being able to, even in terms of the IOLs and all that we can put in these cases gets limited. You can't offer them, the whole.
And that is what also leads to their late presentation to an ophthalmologist, because like in my patient, he had presented for all the 3 other complaints to some specialist, but the last presentation was to an ophthalmologist. So that because they are well off with their reading abilities.
Yes, exactly. So but interesting. Yes, I think that's a good concept there.
Deep sir, Sujit sir.
Thank you. It was a nice case. Well, most of it has been already discussed by Dr. Digvijay sir. It was overall this session was very good. That's the only thing I would like to add. Dr. Disha, you're presenting it. I think it's the second case that you're presenting, right?
Yes, sir.
Yeah. Both of the cases are very nice. Were very nice. Yeah. Okay. So I don't have anything additional to give you any further inputs regarding this. It's very thoroughly presented. That's all.
Sujit sir.
I think Dr.
Sujit sir. Oh, he's.
Anyway, Pranesh.
Yeah, you can go ahead.
If I may request all the presenters to stay back for the virtual certificate distribution. Digvijay sir, we would like to have it under your presence. We also have our sponsors for this event, Elazar, who requested us to play this video. We are going to have this video followed by the certificate distribution as well.
Sure, yes.
An auto perimeter is too big an investment to make, particularly.
The screen visible?
Yes, screen is visible. Audio also is clear.
Perfect.
For my clinical.
My patients have to travel to another hospital just for perimetry, sometimes to a different city.
Because of these reasons, many glaucoma patients miss out. AVA bridges this gap by being a diagnostic device for glaucoma with the accuracy of gold standard perimeters at just 1/5 of the cost. Take one step towards expanding your ophthalmology practice and delighting your patients. Sign up for a demo today.
So we would like to thank AV Elazar for sponsoring this event. So with that, we have the virtual certificate distribution. So thank you to all the judges. So thank you, Vijay sir. So we have this distribution under your presence. So first we will have the judges certificate distribution. So we have Digvijay sir certificate here. So thank you, sir, for being one of the judges and sharing your wisdom through the course of this talk, the session. Then we have
Thank you.
Thank you, sir. That Dr. Sujit, thank you, sir, for being again part of last year as well, along with Digvijay sir again for this year in season 2, and sharing your expertise along with Deep Shekhar Das sir for again sharing a very good, interesting discussion and bringing out a lot of very important scientific focal points. Thanks to all the 3 judges. We also have the certificates of Dr. Hahan Shah, the presentation reversible cerebral vasoconstriction syndrome and papilledema, a case report. We have Dr. Pooja. Thank you, Dr. Pooja, for your presentation on optic nerve sheath fenestration, a savior for progressive benign intracranial hypertension. Dr. Gautam R. Unmasking the overlap, early Parkinsonism misdiagnosed as ocular myasthenia gravis. Dr. Disha Agarwal on arthritic AON as a presenting feature of Takayasu's arteritis. Dr. Nishi Prasad on post-varicella periocular necrotizing fasciitis associated with fasciitis associated with keratoconjunctivitis. And Dr. Arutpriya on lunar landscapes, analyzing congenital versus acquired optic disc pit. Dr. Nipu Goyal, ma'am, on piece the puzzle. Often you will not know it's there. And Dr. Miriam Ankita, a rare case of orbital schwannoma, a surgeon surprise. And Dr. Abhishek Paul for mystery of the cyst. So, and again, Dr. Disha Agarwal on unusual ocular manifestation in Wolfram syndrome. So with that, again, you can see the complete package of cases that we had for the first session and the second session. I'm handing over to Dr. Karthik for his closing comment for session 2 and starting the session 3. Over to you, Karthik.
Yeah. And thank you, Dr. Prasanna. It was a wonderful session. It was a very great and knowledgeable discussion by Dr. Digvijay sir and my friends, Dr. Deep and Dr. Sujit. The discussion was amazing. All the presentations were amazing. And Dr. Pranesh for a wonderful moderation. Okay. Now we'll move on to the next session.
Before moving on, Digvijay sir, few closing comments from you before we start the session 3, sir.
I think, like I said, wonderful cases, and they've all done justice to our topic, to our theme. And 2.0 definitely is twice as good as 1.0, and I'm sure this is going to keep growing. So, but great, wonderful, and thank you to the organizers, to you, Prasanna, to you, Karthikeyan, to you, Pranesh, all of you guys for putting this together.
Thank you, sir. Thank you for supporting this last year as well, and it has gone to the capsule 2 this year. Thank you, sir. Thank you.
All the best for the next session.
Yes, sir. Yes, sir. Thank you, sir. Thank you. Thanks to all session 2 judges and participants. So we will move to the session 3. So to Karthik, can we have the slides?
I'll start the presentation.
Yeah, we'll apologies for the 10-minute delay. We'll start and we'll try to make sure we finish on time. So with that, we had totally 20 cases so far with 6 judges. So we're moving on to the last lot. Yes, so I would like to invite Dr. Arshra Naike. So he's done more than 110 presentations, conducted workshops, ICs internationally, nationally, convened many national and international meetings, and he has won 2 Best Paper Awards, TNOA 2024, peer-reviewed publications, chapters, big grant recipient, IBAC, implantable capsular bag, patent file. So he's a medical scholar, innovator, researcher. Welcome, Dr. Ashraya. Hope I'm pronouncing you right. Thank you for consenting to be part of NOI NAADI season 2. Thank you for being here. Karthik, the next slide. Dr. Pranesh, over to you for inviting the next 2 judges.
Yes, I am really happy to invite Dr. Shreyas Temkar, who's completed his master's in AIMS RP Center, and he's a fellow of the ICO and senior residency from RP Center. He's completed his FICO with retina uvea and FICO in uvea. He's a uveitis surgical retina neuro-ophthalmology and phacoemulsification specialist, and is working as an AP in JIPMER Puducherry since 2021. We are very, very happy to be welcoming Dr. Shreyas. Welcome, sir.
Thank you, Team OC, for providing the opportunity to judge this session.
Pleasure is ours, sir. Karthik, next slide. And for the final judge, we have Dr. Sharath Hegde. Sharath sir has completed his MBBS in MS from JJMC Davangere and has completed his fellowship from L.V. Prasad in 2016. He's currently working as a retina consultant in Prasad Netralaya, Udupi, Karnataka. He's proficient in working on AI and diabetic retinopathy and active member in many ophthalmology forums. He has various publications and in journals and chapters in textbooks. Very happy to welcome you, sir, and we're happy that you're part of this NOI NAADI Prelims third session.
Thanks for inviting me, Pranesh.
Thank you, sir.
Yeah. Without much delay, can we have the first presenter?
Dr. Hansha.
Yeah.
Good evening, sir. Yes.
He was the first presenter of last session as well.
Are my slides visible? Am I audible?
Yes, both audible and visible. You can start.
Okay, thank you. So, intraocular foreign bodies. They account for 17 to 41% of open globe injuries, with a significant 60% of cases occurring in the age group of 20 to 40 years. They occur in primarily workplace settings, where hammering is involved in almost 80% of incidents, thus highlighting the serious occupational risk. With that said, let me begin on intraocular foreign body, a blink away from disaster. So, a 25-year-old male hailing from Bihar comes in the ophthal OPD with complaints of sudden onset gross diminution of vision following history of something going into the eye while hammering the chisel over stone earlier this evening. The diminution was associated with pain, redness, and watering. He was referred here for further management. There was no history of any protective glasses or equipment, no history of any treatment elsewhere, no history of any discharge from the eye also. General examination was within normal limits. Ocular examination of right eye again was within normal limits with a visual acuity of 6.6. Left eye, however, had a presenting visual acuity of just perception of light present. The patient had other features which are characteristic of a wound tract, as we are going to see in the further content. So eyelids had lower lid laceration, followed by conjunctiva with a subconjunctival hemorrhage and conjunctival laceration, which was hiding a corneoscleral laceration of approximately 3 mm cross 3 mm at 7 o'clock, associated with iris plugging. There was further an iris defect behind which there was a focal lens opacity. So this is the right eye examination, which is in normal limits, whereas left eye, as you can see here, there is a corneoscleral laceration, an iris defect, and sectoral wedge-shaped opacity in the lens. Fundus examination of right eye was the normal limits, but left eye view was obscured because of lens hydration and vitreous hemorrhage. So, with pertaining to a characteristic wound tract, a provisional diagnosis of left eye open globe injury suspected type C, that is intraocular foreign body, with grade 4 pupil negative zone 1 and 2 was made. Emergency imaging confirmed by showing a very strong hyperdense opacity in the orbit of approximately Hounsfield units of 3000, and otherwise the imaging was within normal limits. The patient underwent an immediate emergency repair. The primary globe repair was done after broad spectrum IV antibiotics along with injection of intravitreal antibiotics. As you can see here, the lens has been fully hydrated by this point. Postoperative gentle B scan was done, which is showing an opacity in the anterior inferior vitreous, where we can also see a comet tail artifact and an acoustic shadow, thus probably making a diagnosis of a metallic foreign body. So this video demonstrates the surgery done for this patient. I'll just move. Okay. So PPV ports were placed. Continuous curvular capsular access here is helping to establish a sulcus, which may help the IOL implantation later during the surgery. Side port was made, and also vitrectomy was used to aspirate the lens, thus providing a better view for the pars penna vitrectomy later on. After vitrectomy, as you can see here, a prominent metallic foreign body is noted in the anterior inferior vitreous. Following which, the posterior vitreous detachment was induced. So this was a young male. This is a bit difficult in this scenario, but delayed repair may contribute in helping the PVD induction. The clot was subsequently removed, thus clearing the view of posterior pole. And peripheries were screened to rule out any potential breaks. Ports were enlarged, and passing a magnet, the body was metallic object was gently retrieved. Submacular bleed and scar is noted in the image as shown here.
Dr. Han, can you
Yes,
wrap
I'd like
up the
to.
presentation, please?
Yeah. So the postoperative visual acuity was 660, and the patient, despite having a submacular bleed and scar, after counseling was satisfied with the result. I'd like to conclude by saying that comprehensive evaluation and imaging are very essential to confirm the diagnosis. And prophylactic IV antibiotics are helpful to prevent infection in cases of especially trauma, where bacterial endophthalmitis is common, Bacillus cereus and other such organisms. Surgical repair, regular follow-up, and prognostic factor where presenting visual acuity is the key determinant are indicators for a good outcome. Thank you.
Thank you, Han. Nice presentation. Over to the judges.
Stop sharing the screen.
Yeah. Ashray, sir.
I think it's a well-managed case, straightforward case of intraocular foreign body. Han, what was the gap between the primary repair and the retina surgery?
Sir, a period of 3 days, sir.
3 days. In the first, this thing, what was the antibiotic given?
Vancomycin and ceftazidime was given on IV and intravitreal by routes.
Usually, was any suspicion of endophthalmitis was done, or it was given prophylactically, or any vitreous biopsy was done?
Biopsy was not taken since the patient had history of hammering, where the foreign body is usually sterilized by the friction generated through the heat. We did not expect endophthalmitis to develop in this scenario, and biopsy was not taken, sir.
Otherwise, it's a clear-cut, well-managed case. I don't think there was any controversy in how you manage the whole thing. The only thing is, if while removing the intraocular foreign body, one should be careful enough so that it doesn't fall on the macula and cause iatrogenic injury. Otherwise,
Yes.
that part is straightforward.
Okay. Thank you, sir.
Thank you, Ashray, sir. Over to Shreyas, sir, and Sarat, sir.
Yeah, Dr. Han, very well presented case. You have nicely highlighted that if there is a track which is seen starting from the cornea involving the lens, then you should have a very high suspicion of intraocular foreign body. I have a question for you. So,
Yes.
can you tell some locations in the eye where a foreign body can be missed even on detailed examination, and where you might require some special investigations apart from CT scan? So, your routine investigations.
Yes, sir. So the foreign body may be missed if it is behind the iris or is in the sulcus plane, and ultrasonic biomicroscopy can be a very valuable tool. But since this patient has an open globe injury,
Any other sites where it can be missed apart from your retro iris space?
even small intralenticular bodies may be missed.
Okay, somewhere in the anterior chamber, somewhere in the posterior segment.
Angle of the anterior chamber, and where the slit lamp examination may be inconclusive, and posterior segment near the ora serrata and in the peripheries where.
Yes, even ciliary body region, foreign bodies can be sometimes missed. Okay, and for an angle foreign body, gonioscopy can be helpful. Okay, thank you.
Yes.
Sharat, sir.
A very nicely managed case, and this thing has of many other questions as asked by Ashraya and Shreyas. Well managed, no other questions.
Okay, thank you, sir. Now we go to the next presenter for this prelim session, Ms. Shruti, Dr. Shruti M. Nair. Are you there, ma'am?
Yes, sir. Good evening,
Yes,
sir.
please,
I'll
please.
share my screen.
Please share.
Is my screen visible, sir?
Screen is visible, ma'am. Your voice also is clear. You can go ahead.
Yeah, but
You can
full
start.
screen, you need to go for now it's fine. Perfect.
Good evening, everyone. I'm Dr. Shruti. I'm going to be presenting a case of intravitreal triamcinolone acetonide induced CSE or central serous chorioretinopathy. So we had a 51-year-old diabetic and hypertensive male who was a non-smoker who presented to us with gradual painless diminution of vision in both eyes since the past 3 months. He had history of cataract surgery done in the right eye 2 months back with incomplete visual recovery. And there was history of 2 intraocular injections in the right eye with no visual improvement. Avastin was given according to records. One was given along with the cataract surgery, and the second injection was given after 1 month. So the best corrected visual acuity was 612 parts in the right eye and 618 parts in the left eye. The anterior segment examination of both eyes were within normal limits, with the right eye being pseudophakic and left eye having early immature senile cataracts. The fundus examination showed both eye moderate non-proliferative diabetic retinopathy with clinically significant macular edema, and there was severe lipid exudation seen in both eyes. On OCT macula, there was both eye cystoid edema that was seen with neurosensory detachment and hard exudates with multiple hyperreflective foci. So the plan of management, we initially sent investigations. The blood sugars and renal functions came back normal. The lipid profile, however, was deranged with increased total cholesterol, triglycerides, and LDL levels and normal HDL. And so statins were initiated. We planned to give intravitreal triamcinolone acetonide in the right eye, followed by the left eye, and this was because of poor response of to previous anti-VEGF injections in the right eye and the presence of hyperreflective foci. So following intravitreal triamcinolone injection, we can see that after 2 weeks, the cystoid spaces have started to reduce. However, there is an increase in the neurosensory detachment height, which was initially 370. After 4 weeks, has increased to 520 microns. However, the cystoid spaces have completely reduced, and so we suspected a diagnosis of central serous chorioretinopathy. Following this, a fundus fluorescein angiogram was done, which showed a right eye focal leak with ink blot pattern along the superotemporal arcade, followed by late pooling. So treatment, he underwent a right eye focal laser to the point of the dye leak, and 8 weeks following this, there was resolution of the neurosensory detachment, and the visual acuity showed mild improvements from 612 to 69 parts. So coming to the discussion, as of now, the standard of care in center involving DME is intravitreal anti-VEGF agents. And in cases where there is poor response to anti-VEGF and in pseudophakics with OCT biomarkers of inflammation such as hyperreflective foci, we can go for intravitreal steroids. So IVTA was given to our patient, following which there was reduction in cystoid edema, which was noted, which suggested resolution of DME. However, there was concurrent increase in the neurosensory detachment, which was suggestive of an induced central serous chorioretinopathy. So CSE is a known side effect of steroid use. However, there is Lacanian literature on causation secondary to IVTA injection. Coexisting CSE and DR can pose a diagnostic dilemma, as neurosensory detachment may be present in both, and there's limited literature available on the same. So according to a study done by Durandar et al. And published in the British Journal of Ophthalmology, the features of CSE and DME associated with neurosensory detachment are features such as thickened footplates of photoreceptors at the roof of the NSD, pachychoroid, increased central macular and subfoveal choroidal thickness, and presence of hyperreflective dots, pigment epithelial detachment, and loss of ISOS integrity. Treatment options in this case would be, we can try focal laser. If not, we can go for topical dorzolamide, oral epinephrine, or finally vitreous lavage with removal of the IVTA crystals. The learning points are that IVTA can induce CSE. We have to look for CSE biomarkers in diabetic macular edema associated with neurosensory detachment, and increase in the neurosensory detachment after the IVTA, we have to suspect CSE. Thank you.
Great presentation, Doctor. Ashraya sir, your comments?
Though in the learning points you mentioned about CSE, it is quite a rare occurrence to have CSR post IVTA injections. We almost all protocols where steroids have been used, it is rarely it has happened. So though it is it can happen. But when you have a increase in neurosensory detachment, fluorescein angiography can give, but I don't think that should be the message going from this case. It can happen and it can be managed with focal laser. What is your opinion on VC trial, Dr. Shruti? It has what are the recommendations of VC trial? Because you mentioned oral eplerenone in your management.
I'm not aware of it.
So VC trial categorically said that it should not be used because it has no therapeutic effect. Of course, there are anecdotal evidence on the literature, but by and large, they don't really help in managing, especially if there is an acute CSR. So I don't think it should be in the management protocol because it categorically mentions that it has no effect.
Okay, sir. So actually, we had another case of BRVO-induced macular edema that we treated with IVT as well. We're still following up the patient, but oral eplerenone was given for that case, following which the patient is showing improvement. So this is based on anecdotal evidence only, but
you should read the Subhash Prasad et al. Of VC trial. They have Dr. Usha Chakravarti and all have stayed for almost 6 months, and that's what it's one of the trials which categorically prohibits the use of discourages the use of eplerenone. Anyways, I think it's a good presentation, but you should also be aware of Dr. Umesh Behra's new theory of using DEX implant for CSR. So
yes,
yeah.
Yes, sir.
Thank you, sir. Thank you very much, Shreyas, sir.
I agree with you, Dr. Ashraya, but I think when you have no options of treating a patient where there is a central leak, so I think there is no harm in giving a trial, is what I feel in such cases. What do you say?
In fact, that's what that trial actually gives after.
Yeah, I'm very well aware of that trial. But I think many retina surgeons, even in India, they don't agree with that trial. I think so.
If you can't,
no, it's a very well-designed study, and it has, as you said, categorically ruled out use of eplerenone in CSC. But until unless you have micropulse facility, I think eplerenone should be given as a trial, is what I feel like.
That too, now PDT is also not available.
Yeah.
Everywhere. Yeah, sometimes we use it, but nowadays it's a rare. After the study has come, if it is really nothing is working, then only we try it. Or else usually we won't give that also, as Dr. Ashra is saying. I have one question to for the case presentation. What happened in the other eye? You are given the
So
IVT
other
for the one eye.
no, sir, because the patient had CSC that developed in the right eye because of the steroid. As of now, we're just following up the patient. We haven't treated it. Cataract is also not of significant degree to do the cataract surgery. And anti-VEGF, there was no response. So as of now, we're following up. We'll decide further what to do.
Can you tell me how the hard exudates resolve in the retina?
Sir?
How hard exudates resolves in the retina?
Hard exudates are a result of chronic edema that occurs. So even though the edema resolves, the hard exudates may persist, and over a long period, over the course of a few months, they are gradually absorbed.
Usually these hard exudates, which they settle in the retina, is not directly lipid particles. They are engulfed by the macrophages which are there, which they come inside, and then they go and settle there. So gradually over a period of weeks, they resolve from the blood vessels. Usually it will take up to 6 weeks to 6 months also.
Yes, sir.
So depending on the macrophages, how much they are, if they convert into fibroblast, then they won't get resolved.
Okay.
Yeah.
Yes.
Great. Shruti, I have a question for you.
Yes, sir.
So as I observed in this case, like only after 2 anti-VEGF injections, we were like you have decided to give this thing steroid implant in this patient. So do you justify, or should we have given more injections in this patient? Like, so just I want to ask you, what is the definition of a persistent DME according to the DRCR protocol?
So actually, a minimum of 3 monthly injections have to be given, followed by, like, we can continue giving. But in this case, because of presence of other hyperreflective foci, it suggested, and severe lipid exudation, that was the reason we went for IVT or
According
steroid.
to DRCR protocol, it is like at least 4 monthly intravitreal injections you give and then see for the response. If there is no response, then you can decide for either switch over or go for a steroid implant. Okay, thank you.
Okay, thanks.
Thank you, Shreya sir. Now over to the next presenter, Dr. Mohsimi. Thank you, Shruti ma'am. Nice, great presentation, ma'am.
Thank you, sir.
Dr. Mohsimi?
Yes, sir. Am I audible?
You're audible. Yes, you can share. Yeah, screen is visible. You can start your presentation.
Good
Yes,
evening,
ma'am.
everyone. I'll be discussing a very unique and interesting pattern of choroidal detachment observed post-scleral buckling. So as we all know, the most common complication post-scleral buckling is choroidal detachment, and high myopia is one of the most common risk factors for it because it causes increased permeability of the choroidal vessels, leading to increased exudation of fluid from the vessels, and this, when associated with compression of the vortex vein by the buccal explant, can lead to choroidal detachment. Now, a 48-year-old male presented with sudden onset, painless, gradually progressive diminution of vision in the left eye for 2 days. There wasn't any similar history in the past, no history of any ocular trauma or any other significant systemic history. On ocular examination, right eye had a visual acuity of 6.9, left eye 6.18 partial, and anterior segment was within normal limit. Right eye fundus had multiple unlasered lattices with holes. In the left eye, we could see a supranasal fresh rhegmatogenous retinal detachment extending from 2 o'clock position till 6:30 position with multiple lattices and an superior HST with shallow fovea off. The refractive error in both the eyes was minus 21 diopter spherical with an axial length of 32 millimeter. We planned for a laser barrage of lattices in the right eye and scleral buckling in the left eye with drainage. So on first day post-op, to our surprise, we could see there was a large supratemporal choroidal mound. The break-buckle relationship was adequate. So we planned for a conservative management. And on post-op day 2, we could see another mound, choroidal mound in the infranasal quadrant with partial receding of the supratemporal mound. On day 4 post-op, we could see another large choroidal mound rising in the supranasal quadrant. And by day 7, almost all the CD mounts started receding. At post-op 1 month, we can see the retina is well attached with complete resolution of all the CD mounts with adequate break-buckle relationship and a visual acuity of 6.9. So when a surgeon faces complication, the first question we ask is, why me? But I thought this time I'll ask a different question. So instead of why did this happen, I learned to ask, what am I learning right now? So what were the questions in my mind? Why did the waxing and waning of the choroidal mounts occur? And why didn't it appear in the infratemporal quadrant? And how can we prevent such a complication? So coming to the first complication, first question, that a posterior buccal was placed superiorly, traversing 180 degree, and it was placed pretty beyond 14 millimeter beyond the muscle insertion. So because of the posterior placement, it might have resulted in obstruction of the supratemporal vortex vein. Now let's take a look in the ICG angiography picture. In the right eye, we can see increased uptake of the dye with prominent dilated ampulla in the supratemporal and infratemporal quadrant. Similarly, in the left eye also, we can see hypersenescence in the infratemporal quadrant. The supratemporal vortex vein is not visible, probably due to obstruction. And even in the late phase, we can appreciate the vortex vein ampulla in the infratemporal quadrant. So the location of the supratemporal vortex vein is further away from the optic disc than that of the supranasal and infranasal quadrants. Therefore, it makes it more prone to obstruction when a posterior buccal is placed. Moreover, because of the weakened choroidal vasculature in our patient due to high myopia, it led to subsequent development of new choroidal mounts. Now, interestingly, choroidal vasculature has a salient feature of plasticity, and because of the choroidal venous drainage rerouting, it can explain the complete resolution of the choroidal mounts eventually. Second question, why didn't it appear in the infratemporal quadrant? Because the maximum venous drainage was taking place via the infratemporal venous channel, as we saw in the ICG image. To support our hypothesis, Verma et al. Has also observed that vortex vein ampulla was slightly more frequent in the temporal and inferior quadrants. Now, how can we prevent such a complication? Venkatesh et al. Has suggested an idea that we can create a notch in the buccal segment overlying the vortex vein to prevent obstruction. Now, my take-home message is we know about the factors, risk factors, which can cause a choroidal detachment post-scleral buckling. In our patient, we had all the factors: hypotonic, cryopexy, posterior buccal sutures, high myopia, advanced stage, and vortex vein obstruction. So we need to anticipate such a complication in such cases. And when it occurs, we should not panic and we should understand the pathophysiology behind it. Thank you so much.
Great presentation, mostly, ma'am. Over to judges, Ashay, sir.
A nice presentation, Doctor. This drainage was at what site? Was the gas was injected at the end of the surgery, or
So gas was not injected. However, when we closed it, the pressure was maintained. It was not there wasn't hypotony at that time. So gas was not injected, sir.
how like it was just on digital pressure? Was it
Yes, sir.
checked?
On digital pressure, sir.
So what was the IOP during the course of the whole?
Sir, the IOP was maintained. It was between 14 mm of Hg to 16 mm to Hg. It varied between that in the complete post-op till post-op day 7.
But usually both coronal detachment can happen in both hypotony and higher pressure. In hypotony, there is the pressure gradient between the choroidal capillary plexus and the interstitial choroidal space. But in when there is high IOP, again there is increase in hydrostatic pressure, so it can happen. So I think since the buccal works really well, and in this case, though you had initially a bit of a storm, it settled down. But what is the main reason for a failed buccal?
So main reason is, first of all, the most important thing, like in our case also we saw, there was a adequate break-buccal relationship in the first day post-operative. So if it is not, if we don't get a adequate break-buccal relationship, so it's likely to fail.
No, usually the most common reason for failed buccal is a missed break. So you have made a wonderful diagram. So if we have multiple lattices and holes, and on table, if we don't take care of all these things, you can end up having a failed buccal. So the most important thing you have to do is a good examination and a good diagram like what you have done. Otherwise, well managed case.
Thank you, sir.
Very nicely managed and very nice surgery. One of the time where we commonly see this choroidal detachment in buccal is when we do excess cryo, or when we remove the cryo suddenly, especially in high myopic patients, because the sclera will be very thin. So when you before you put a saline and defrozen, thawing it, and if you remove it, that may be one of the reason to cause choroidal detachment. And nice explanation from the part of you. What you have explained. Yeah.
Thank you.
Dr. Mausam, it was nicely managed. I have one a point or a clarification. Like because here we know the patient had was a very high myope, and we expect that the scleral rigidity will be less in such patients. So they are always prone for one of the risk factors for post-buckling choroidal detachment is high myopia. So when we knew this thing to happen, like could we have done a non-drainage in this patient, and we could have, because very well supported with buccal and gas alone, and just waited for, like, this is my anticipation.
Yes, sir,
Could we
you
have
are
gone for
absolutely right.
yes,
Probably that is
non-drainage
also one
surgery?
of the learnings which we got after the surgery, because we did not anticipate such a huge choroidal mounts which are migrating from one place to another. So yes, that is true, that probably if we wouldn't have done a drainage, then it could have reduced the chances of the choroidal mounts.
Okay, thank you.
Thanks.
Thank you, Shrey, sir. Now over to the next presenter, Dr. Gautam. You can share your screen, Dr. Gautam. Yes. You can start the slideshow.
Good evening, everyone. Am I audible?
Yes, doctor, you're audible and slides are visible. You can go
I'll
ahead.
be presenting my case of recurrent lipemia retinalis. So our patient is an asymptomatic lady in her 30s with familial hypercholesterolemia. She was referred to us by her physician for fundus examination. She had no ocular complaints. Her best corrected visual acuity was 20 by 20 in both eyes. Anterior segment examination of both eyes was within normal limits. Coming to the fundus examination showed creamy orange discoloration of retinal vessels, suggestive of lipemia retinalis in both the eyes, as you can see in these images. Blood investigations revealed highly elevated total cholesterol and extremely elevated serum triglyceride levels. She was initiated on lipid-lowering therapy, omega-3 fatty acid 300 mg capsules 5 times per day, and tablet fenofibrate 145 mg once daily. There was resolution of fundus findings in her after 4 months of therapy. Blood investigations at this point showed total cholesterol reduced and triglycerides were reported as more than 1000 milligram per deciliter. As you can see in this fundus images, the creamy appearance of the retinal vessels have resolved after 4 months of lipid lowering therapy. When she came for follow-up after a month, we noticed a recurrence of the fundus findings. As you can see, the creamy vessels have begun to recur. On inquiry, the patient revealed that she had stopped medications since a month as she had no complaints. Blood investigations done during this visit showed that total cholesterol was elevated compared to the previous visit, and triglycerides were still reported as more than 1000 milligram per deciliter. The patient was explained the need for strict compliance to medications in order to avoid systemic complications. Coming to the discussion, familial hypercholesterolemia is a rare genetic disease of cholesterol metabolism associated with very high serum triglyceride levels. Patients are typically asymptomatic but at risk for life-threatening complications like ischemic heart disease. Lipemia retinalis is characterized by creamy appearance of retinal blood vessels due to extremely high triglyceride levels, and it occurs from light scattering by chylomicrons in the triglyceride-packed retinal vessels. It does not affect visual acuity and is usually asymptomatic. Coming to the response to therapy, there have been reports of lipemia retinalis improving with lipid-lowering medications. However, our case is unique because this case shows recurrence of lipemia retinalis due to non-compliance with medication. Coming to the role of fundus examination in such cases, repeated fundus exams can help assess medication compliance. Labs in India usually do not give exact triglyceride levels in extreme cases because of their problem in machine calibration. They often report the value as more than 1000 milligram per deciliter. Fundus findings appear when triglyceride levels exceed 2500 milligram per deciliter, allowing for an approximate estimation of triglyceride levels. Say, for example, if a patient has lipemia retinalis, we can assume that the serum triglyceride levels are more than 2500 milligram per deciliter. Whereas if there are no features of lipemia retinalis, we can assume that the serum triglyceride levels are between 1000 to 2500 milligram per deciliter. The take-home messages are: lipemia retinalis is an ophthalmological manifestation of familial hypercholesterolemia, which is an asymptomatic but can lead to life-threatening complications. Early diagnosis and cholesterol control are crucial for such patients. Lipemia retinalis can resolve with appropriate lipid-lowering therapy and may recur if treatment is stopped. Fundus examination is therefore essential for both diagnosis and follow-up of patients to assess compliance and control of triglyceride levels. These are my references. Thank you.
Nice presentation, Gautam. Ashay, sir, your comments?
Gautam, after we stopped the therapy, was there increase in triglycerides?
Actually, the reports usually they mention it as more than 1000 milligram per deciliter. The total cholesterols were actually elevated, but serum triglyceride levels per se were reported as more than 1000 milligram per deciliter in our institute during those visits. So we could not get the exact value of serum triglyceride levels, but the total cholesterol showed elevation when the patient was not compliant to medications, and when she was taking her medications, the total cholesterol subsequently reduced.
So you mentioned it to be unique, but isn't it very obvious that if you don't take treatment, things like how diabetic macular edema comes back? So don't you think it is obvious?
The problem here is labs don't give a value with lipemia retinalis. I mean, familial hypercholesterolemia cases, sir. They usually report it as more than 1000 milligram per deciliter. So usually, even if the patient is on treatment or without treatment, it will be reported as more than 1000 milligram per deciliter. So fundus examination can add as an adjunct to see whether the patient is on treatment or not.
Oh.
Shreyas, sir? Shreyas, sir? Sharad, sir?
Yeah. I think you told in the 4 months it completely resolved. But if you can see the vessels, still these vessels are in the periphery. If you go, they're more whitish only, right? So it's not been completely resolved. It takes very long time to resolve, or it may not also in lipemia retinalis. And when you see this picture, if you see the first picture, what all differential diagnosis will come in your mind? The first time you don't know the patient is having why the patient came to you?
Actually, she was diagnosed as hypercholesterolemia by her general medicine practitioner.
if you don't know the diagnosis, what are differential diagnosis you will keep in your mind when you see this picture?
Sir, it can be albinism cases, the underlying blood vessels can be seen, but such presentation won't be there. This is usually more classical for this lipemia retinitis.
Yeah,
I'm
any
not sure of it.
differential diagnosis you can think for, like it's a classical presentation, I agree. But if you want to think any other differential diagnosis, so what is the different pattern? What we can say, any morphological diagnosis you can think for, if there are cells and all, for example.
Retinal vasculitis can also sometimes present like this.
Vasculitis, okay, still more. We can try what type of appearance we can think for. Some classic appearance.
Prostate branchitis can be like this.
Prostate branchitis. Okay, that also you should keep in mind when you. This is a classical case. Usually there is no other differential diagnosis you can say directly, but still, if they come for the first time, keep in mind of differential diagnosis of this condition.
Okay.
Yes, sir.
Dr. Gautam, as Dr. Sharath pointed out, no, because your earlier images are with 45-50 degree field photos, and the later follow-up you are used wide field images. So probably that also is contributing, whether it will not very clearly tell whether there is resolution or not. This will be little problematic. Usually you should have same images when you are comparing.
Nice.
And what we can learn from this case is that because the patient usually don't have any visual problems, so they remain asymptomatic, and it is very difficult to convince them the need for treatment because they don't affect the vision nor cause any retinal problems. So what we can take home message from this thing is that if you have serial images, you can show to the patient when there is a resolution, and this is how you should maintain it. Something like that educative matter can be taken up for the patient.
Okay.
Otherwise, well presented. Thank you.
Thank you, sir.
Thank you, judges. Gautam, nice presentation. You can stop sharing and we'll go to the next presenter. Dr. Deepanshu Agarwal, sir. Yes, sir, you can share your slides.
Visible?
Yes, it's visible, sir. Yeah.
Very good evening, all. My case is of a 25-year-old lab technician who presented with complaints of diminution of vision bilaterally since 9 months. He had history of repeated episodes of fever since September 2023, for which he consulted at various places, and he was diagnosed to have pneumonia back then and was treated for the same. He was also injected with intravitreal triamcinolone acetonide in December 2023 and was on and off topical as well as systemic steroids, as you have consulted at multiple places. At presentation, his visual acuity in the right eye and left eye was 20/1200 bilaterally, and intraocular pressure was 48 and 40 millimeters of mercury in the right and left eye respectively. There was presence of neovascularization of iris along with presence of ectropia and UV developing in the right eye. On gonioscopy, we noted that there was partially closed angles with multiple pars formations and neovascularization of angle was noted. When we did a dilated fundus evaluation, we noted that there were florid NVD which was noted bilaterally, but there were patches of retinitis which were present involving fovea and extending towards the disc. And also there was some ischemic cotton wool spots present. When we did a peripheral examination, there were multiple intraretinal hemorrhages, and 360-degree there was sclerosed vessels were noted, and similar picture was present in the left eye. OCT through the macula revealed that the retinal lesions which were present corresponded to the intraretinal thickening which is seen here, along with cystoid macular edema and epiretinal membrane. When we did an OCT angio of this patient bilaterally, to our surprise, we noted that there was total capillary non-perfusion in both the maculas, and NVD, which was very florid on the clinical examination, is very beautifully depicted here on OCT angio of the disc. We did a basic uveitic profile workup. Few tests were previously done and few we did repeated. All came out to be negative or inconclusive. So we made a diagnosis of bilateral neovascular glaucoma, status post fever retinitis. We started the patient on topical and systemic corticosteroids as well as anti-glaucoma medication, and patient was planned for pan-retinal photocoagulation. These are the post PRP pictures that follow 4 weeks. We can see that extensive PRP has been done, and intraocular pressure, however, at 6-week follow-up, but remained in the range of 40s and 50s with 4 drug therapy. So this patient was planned for trabeculectomy along with mitomycin C, but preoperatively intravitreal anti-VEGF was given. These are the post-op 1 week pictures. Surgery was done 10 weeks apart in the right and left eye respectively. And intraocular pressure was maintained at 16 and 18 with well-formed bleb. Similar picture with well-formed bleb and mid-teens of intraocular pressure with no anti-glaucoma medications were noted at 1 month follow-up. So when we compare the pre and post-treatment pictures, we can see there's significant reduction in the neovascularization as depicted on this OCT angio of the disc. Intraretinal thickening had somewhat reduced. Extensive PRP and glaucoma filtering surgery helped us in reducing the intraocular pressure, and it was maintained in mid-teens with no AGMs. And there was mild improvement in the visual acuity of up to 20/600. So I would like to conclude by saying that post-fever retinitis leading to occlusive vasculitis leading to bilateral NVG is sort of slightly a rarer entity. Systemic workup is always advisable in these patients to, if there is any systemic association in the found, if it can be associated. And timely intervention can help us in preventing the visual loss. I would like to acknowledge the glaucoma service consultant, Dr. Teen Mani here, for helping me with this case. Thank you.
Great presentation, Deepanshu sir. Over to Ashay sir.
Nice presentation. I have a couple of doubts. We had a contraindication for angiography, or it was patient was ill, or
No, so it was not working at our place actually that time.
okay. So, did you think of other causes of neovascularization like ocular ischemic or a vein occlusion? Because bilateral post-fever retinitis, as you mentioned, it's quite rare. So,
Yes,
did you do this carotid insufficiency?
so we did a carotid Doppler. Cardiac profile was also done since he was a young patient with bilateral occlusive vasculitis. But that came out to be negative and inconclusive. He was otherwise systemic profile also was within normal limit actually. There was no abnormality found. So that and then there was presence of retinitis patches, and the history of fever was on and off since past 9 months. Like he had fever, he used to have diminution of vision, then he used to go to the doctor, get treated symptomatically, and then he presented to us 9 months later.
See, post-fever retinitis, I have a problem in that diagnosis because post-fever generally, after 2 weeks, there is increased circulation of immune complexes. That is what blocks these blood vessels and causes something known as microangiopathy. That's what you see as infarcts here and there. So those kind of picture was not, I didn't see, or you didn't show, I guess, only those scattered hemorrhages were there. So to try, tell it as post-fever retinitis, I have a problem in that diagnosis. So otherwise, whenever you have a neovascularization, we have to end up doing PRP and manage the pressure. That part is fine, but that is where I'm not convinced about that part of the diagnosis.
Very nice images of OCT angio showing NVD, Deepanshu. But as Ashay sir was saying, still even I can open the image, first image. You can even still, I'm also not convinced of post-fever retinitis because more than 4 months or 9 months still that retinitis lesion is very rare to be seen. And it's so much of occlusive vasculitis also, which is not seen because the arteries, everything is attenuated everywhere you can see.
Yes.
And multiple cotton wool spots like this picture, we can see in the multiple peripheral areas also which are there, which also is very rare to be seen. I feel this is any connective tissue disorders to be associated with, which started as post-fever retinitis maybe initially, but there can be associated connective tissue disorders which has to be taken care, and he may require immunosuppression also. Treatment-wise, yes, PRP, everybody is PRP is the correct treatment. Only thing is I may add anti-VEGF also if the NVI was not regressing because that anti-VEGF help to regress very fast.
So we did inject with intravitreal Avastin, but that was pre-operatively. And after that, I think there was no recurrence. And I would also like to add that cardiologist as well as rheumatologist opinion was already taken for this patient, like during the treatment course, because we were also suspecting that if there is, because he had history of joint pain also on and off. So we did take a cardiology as well as cardiology for the cardiological workup, and rheumatological workup was also done, but there was no conclusive finding which we could treat for.
Sometimes only ocular features may be there. That time we need to tell them to start an immunosuppression.
Was sleep study done to see if, because that is another area where sleep apnea syndrome.
All right, sir. No, we did not do that, sir. I'll keep that in mind.
Dr. Deepanshu, well presented case. As other judges have said, I still have a doubt regarding labeling it as post-fever retinitis, because usually whether you treat or not, post-fever retinitis usually subsides on its own. So there is sometimes they say even no treatment is as such needed. So considering this patient is a young male with occlusive retinal vasculitis and large patches of retinitis, Behçet's would be one of my differentials. So I would still advise you to further work up this patient in terms of Behçet's. So post-fever retinitis somewhere should be kept down in the differentials. And I think autoimmune causes like Behçet's should be kept in the top for considering diagnosis in this patient. So, and again, I just want to know, here we are basically suspecting an inflammatory neovascularization. So, did you continue the patient on oral steroids?
So it was slowly tapered, and as an over a period of 6 months, he was on oral steroids. After that, intraocular pressures have come down, and we did not see any further signs of inflammation. So after 6 months, we have stopped it, sir. And the patient is following up with us and doing fine as of today.
Okay, as Dr. Ashray suggested, I think I would still prefer to do a fluorescent angiogram as well and work up the patient towards ruling out Behçet's. So this is my opinion. Okay,
Hypertension was not ruled out, right? Hypertension.
Sorry, sir?
Hypertension.
No. So the basic systemic workup as well as rheumat and cardiac workup was completely done. We did not come out with, it was not very conclusive of anything. So we continued with the basic treatment of ocular symptoms and signs.
Considering the patient is young, please do what Shrey said. That part also has to be evaluated. Sometimes you have to do repeated evaluations because it's too young to lose anything for this patient.
Thank you.
Great discussion, sir. Thank you, Deepanji, sir. Great presentation. We'll go to next to Dr. Shruti M. Nair. Ma'am, please. Yes, your slides are visible, ma'am. You can start your presentation.
Good evening, everyone. Today I'll be presenting a case of retinal hemangioblastoma. So we had a 14-year-old boy who presented to us with a diminution of vision in the right eye for the past 1.5 years. The child was apparently normal 1.5 years back when he had gradual, painless, progressive diminution of vision in the right eye. There was no history of spectacle usage, strabismus, or distortion of images. Family history, he was a single child of a non-consanguineous marriage, and there was no history of any systemic disorders in any of the family members. Past history, birth history was normal, and personal history was within normal limits. General physical examination and systemic examination was within normal limits. Pulse and BP were normal, and there were no CNS or abdominal irregularities. Ocular examination, anterior segment was within normal limits. The right eye showed a best corrected visual acuity of only 612. Apart from that, rest of the examination was normal. Coming to the fundus examination of the right eye, there was a reddish-orange oval-shaped lesion. Reddish-orange oval-shaped lesion at the 10 o'clock position in the superior-temporal peripheral retina with two prominent and dilated tortuous blood vessels that connected the lesion to the optic disc, which was suggestive of a hemangioblastoma. Along with that, there were surrounding tractional bands around the lesion, which extended to the macula, causing subretinal exudation also. Left eye fundus was within normal limits. So to summarize, we had a 14-year-old boy who presented with gradual diminution of vision in the right eye with no significant family history or other systemic complaints. On examination, right eye visual acuity was 612 with unremarkable anterior segment examination And fundus shown as solitary retinal hemangioblastoma with tractional bands extending to the macula and tractional detachment around the lesion with subretinal exudation. So we had a clinical diagnosis of right eye solitary retinal capillary hemangioblastoma. So coming to the investigations, ocular-wise, we did an OCT macula, which shows neurosensory detachment at the macula associated with some tractional detachment. And systemic investigations, he underwent an MRI brain, ultrasound KUB, abdominal CCT, and urine VMA to rule out other systemic associations of VHL, like the cerebellar hemangioblastoma, pheochromocytoma, RCC, and pancreatic cyst. Genetic analysis, however, was not done as the patient was not affordable for the same. So to come to the treatment, we administered intravitreal triamcinolone acetonide, and 1 week following the IVTA, the SRF at the macula reduced significantly. Following this, the NDR laser was done to the lesion as well as to the feeder vessels. And we can see that following the laser, there was reduction in the size of the lesion. However, there was fractional detachment surrounding the lesion with SRF at the fovea, and this was associated with a significant drop in vision. So this shows the extent of the subretinal exudation following the laser. And we can see that there's recurrence of the fluid at the macula with increased traction. So how to proceed in this scenario? There was a combined tractional as well as exudative detachment with vision drop to hand movements close to face. So we initially gave a preoperative intravitreal anti-VEGF followed by pars plana vitrectomy, which was combined with membrane peeling, truncation of membrane surrounding the lesion, and intraoperatively the laser was augmented. Sulfur hexafluoride gas was used to settle the detached retina. 3 months following this, the retina was attached immediate post-op, and there was no evidence of subretinal fluid. And 3 months following this, the vision gradually improved to 6 sparks. So the hospital course, initially we treated the exudative component with IVTA, which showed improvement in the macular edema. Following this, laser ablation was done to the feeder vessels, which showed shrinking of the lesion. However, there was increased tractional detachment, which led to a drop in vision. Following this, PPV was planned and we gave an intravitreal anti-VEGF agent. Following PPV, the post-op first day itself, retina was attached and the DCVA gradually improved to 6 sparks in 3 months. So the take-home message is that retinal detachment due to retinal hemangioblastomas can be exudative or tractional, or it can be mixed. Laser and steroids work well for exudative detachment. Early surgical intervention works well for tractional detachments. Late tractional detachments, however, will be very difficult to treat and will require combined approaches with buccal and band along with vitrectomy, and multiple surgeries may be required. Thank you.
Great presentation, ma'am. Ashay sir, your comments?
Nice case, beautiful pictures. By any chance, you had a surgical video of the RD?
No, sir. Video is not available.
The laser itself can cause breaks in some of these cases. So you have to be very careful. Otherwise, another approach people do is also do a choroidectomy of that area.
Yes, sir.
So
but there's increased risk of hemorrhage, and it's a very technically difficult procedure. So,
recently I was talking to one speaker abroad, and they regularly do it. It is not as dreaded it was to like when you touch a heavily vascular tissue, it does happen, but there is another technique which people can do it. Otherwise, again, a very well managed case. So congratulations.
Thank you.
Very nice case. I have 2 questions. One thing, you are written as a NDI glazer. Did you use the NDI glazer? Double frequency NDI?
Double frequency.
Yeah. And can you go to that OCT image if you are able to show? It's okay. Why are you saying it's a tractional retinal detachment instead of exudative in the first?
So initially, in the first visit, it's exudative only, so which is why it resolved following the IVTA. It was following the laser that the tractional component developed.
Because I think you told the tractional detachment in the initial part, so I was
Initially, there was traction surrounding the lesion, sir, but not involving the macula. So there was traction along the lesion itself and the other vessels, but at the macula, it was only exudative detachment. Following the laser, the traction extended to the macula, so there was exudation as well as traction.
As Dr. Ashish said, this is an exudative detachment. Sometimes doing a laser can increase your exudation and this thing, breaks also it can cause. And definitely the membranes, inflammation will increase and can cause a membranes also can form. If it is infratemporal location, any other differential diagnosis you would have suspected?
This morphology is very classic of capillary hemangioblastoma, sir, but other AV malformations of vasoproliferative tumors also.
There's something called as vasoproliferative tumor,
Yes,
secondary
sir.
vasoproliferative
Yes, sir.
tumors. You have to keep in mind of those also.
Yes, sir.
Yeah.
Actually, the feeder vessels give set away, so there is
yes, sir.
we can't think of things. So, anyways, nice images.
Well presented, Dr. Stuti. I have two questions for you. So apart from this frequency doubled laser, photocoagulative laser, any other treatment options are there in the management of these capillary hemangioblastomas?
If it's anterior lesions and smaller lesions, we can try cryotherapy also, sir. But again,
Very good.
it's
If it's
associated with
something
increased
posterior lesion
inflammation.
where you cannot reach with cryo, any other treatment?
Transpupillary thermotherapy can be tried.
Very good. TTT can also be tried. Any other? Even PDT can be tried in such cases.
Okay, sir.
So one more question. If you have a peripheral tractional retinal detachment due to these hemangiomas, so how can you manage such patients when you don't want to do a partial vitrectomy? Any other option is there?
Can we demarcate the area of the tractional detachment with
Somewhere you have
laser?
it peripherally. So no, not demarcation. I'm telling you that there is a traction there. So any other surgical option is there?
Buckling, a buckle can be done.
We can very well support it with a buckle.
External tamponade.
We can do cryo and then support it with a buckle. Okay. Nice presentation. Thank you.
Just to add, when you have something juxtapapillary, PDT used to work really well. We had a case and we had managed well with the PDT. But again, now since PDT is gone away from the market, whatever the other means are there, that works well.
Yes.
Okay, we can move on to the next presentation.
Great. Thank you, Shruti ma'am. Great presentation.
Thank
Next,
you.
Dr. Mausmi. Please, you can share your slides, ma'am. Great. Your slides are visible, ma'am. You can start your presentation.
So, good evening, everyone. I'll be discussing a case titled BRU in a young female with MRKH syndrome type 2 with cardiac malformations. So, as we know, BRU of the young is a rare and understudied entity, and the etiological factors for BRU of the young differs from that of the elderly. So, the commonest causes of BRU of the young comprises of hyperhomocystinemia, hypercoagulability, etc. And in the elderly, most common causes are embolic episodes. Now, a 22-year-old female from rural India presented with sudden onset painless loss of the superior half of her visual field for one day. There wasn't any history of any other ocular symptoms, no history of breathlessness, fatigue, palpitations, recurrent respiratory infections, or any other systemic illness was noted. However, on repeated inquiry, she gave a history of primary amenorrhea. On ocular examination, the visual acuity in the right eye was 6.6. However, the patient appreciated the lower half of the alphabets on Snellen's chart. There was an REPD in the right eye. And on fundus examination, there was a wedge-shaped bell retina along the infratemporal arcade and sparing the fovea, which was better appreciated on red-free imaging. On OCT through the BRU, we could depict a hyperreflectivity and thickening of the inner retinal layers with a preserved foveal contour. And the visual fields also corroborated with the superior visual field defect. So we came to a diagnosis of BRU of the young in the right eye, and a detailed systemic workup was ordered. So the blood sugar and serum homocysteine were within normal limits, and a gynecological and cardiological evaluation was also sought. However, it's important to say that the patient and her relatives were initially very reluctant to undergo any systemic checkups, and we had to emphasize the importance of systemic workup in such a case before they agreed for that. So on gynecological evaluation, a raised FSH and prolactin was noted. And on ultrasound abdomen, there was bilateral ectopic kidney with pelvic cyst with a possibility of type 2 MRKH syndrome. So MRI of the abdomen and pelvis was ordered. On coronal T2 MRI, it depicted a ectopic left kidney. On sagittal MRI, there was absence of uterus, cervix, and vaginal canal. And on axial T2 MRI, there were no Mullerian duct structures behind the urinary bladder. On cardiological evaluation, a pansystolic murmur was noted, was appreciated on auscultation, and on 2D ecography, there was an atrial septal defect with a diameter of around 25 millimeter with severe pulmonary valve stenosis appreciated. So the patient was treated with ocular massage, IRP lowering agent, antiplatelet anticoagulant therapy, and also counseled for vaginoplasty. And a psychiatric evaluation was also sought because the patient was anxious as well as depressed after the diagnosis. So what is MRKH? It's also known as Mullerian aplasia. It is characterized by agenesis or aplasia of the uterus and the upper part of the vagina in females with a normal female karyotype. The prevalence is around 1 in 5,000 live births. The type 1 MRKH is usually the isolated form. However, like our case, it was a type 2 MRKH, which is characterized by Mullerian duct aplasia, renal aplasia, and cervicothoracic dysplasia. Now, we did a little bit of literature search to see the cardiac association with MRKH type 2, and we saw that ASD, pulmonary valve stenosis, tetralogy of Fallot are some of the common associations noted. Now, interestingly, the most common cardiac abnormality is ASD. However, pulmonary valve stenosis is quite rare. When ASD and pulmonary valve stenosis occur simultaneously, it is reported to be even more uncommon. And in our case, we had both the pathologies together. Now, why does BRO occur in ASD? Usually it occurs due to paradoxical embolism. However, when there is an undiagnosed ASD, vascular occlusion of the vital circulations can lead to BRO. Now, more than 10 millimeter defects usually present sooner. But then why was the patient asymptomatic? Because severe pulmonary stenosis was a blessing in disguise here, as it prevented the outflow obstruction and provided vascular protection until adulthood. So what were the challenges which we faced here? The reluctance faced from the relatives to comply with the investigations and follow-up, and repeated probing was needed before the patient gave a positive history. So this emphasizes the lack of social awareness to address these issues and clinicians' role to show the utmost compassion and create a safe environment for the patient to confide in. So my take-home message will be the importance of a comprehensive systemic workup cannot be undermined in a BRO of the young, and counseling the patient and relatives regarding the association of this ophthalmic manifestation with systemic disorder is important. And patients with MRKH suffer from depression and anxiety, so proper psychosocial assistance is also required. I'll finish with a quote that a good physician treats the disease, but a great physician treats the patient who has the disease. Thank you so much.
Great, ma'am. Ashraya, sir?
Nice presentation, Doctor. Though MRKH is described, but BRO is not often described because a lot of patients do have ASDs, and very rarely they give rise to these emboli, and maybe because did you diagnose MRKH after the ocular manifestation?
Yes, sir. That probably MRKH per se is not the contributing factor here. The ASD is a factor, but MRKH was diagnosed only after the ocular manifestation because the patient never consulted a doctor because of the. That's why, sir, the rural environment is very important because they are not so aware of this conditions, and they don't want to talk about these conditions.
Yeah, absolutely. That's what I wanted to say, because MRKH associated with BRO, I don't think I have seen any case. But having said that, whether you are dealing with a Marfan syndrome or a Marfan habitus, or where this cardiological manifestations patients have, it is always important to see this part, these manifestations to get an echo done. However, everything will be all right. It is important to that is a learning point, on all these. Especially we, all of us, get to see a lot of Marfan syndrome. It is important to roll out as based on your last quote by William Osler. You get your eye, heart, and skeletal. Obviously, it is visible, but to get that evaluated. Otherwise, nice presentation.
Thank you.
Very nice case, and I think the main important point what I feel to emphasize here is the history taking, which many people miss it, seeing the diagnosis and just send for investigation. The investigation of asking the history, probing them the history, very important, and you have done that very nice case.
But actually, that is the reason I had presented this case, because on repeated inquiry, if you had noted, I've highlighted it because I had to send all the patients outside because I saw the patient had she was hesitant to talk about anything because I was repeatedly probing her any kind of positive history. So that's why it felt like a personal vein to me. So that's why I presented. Thank you, sir.
A nice case, Dr. Mosami. Actually, as everyone pointed out, when you have a case of PRAO, definitely some underlying cardiac etiology will be there, and that has to be we have to rule out that possibility. And in your case, as you nicely elaborated how you came to the systemic diagnosis, it would have been more interesting to know what prophylactic management was done for this patient. Was the patient put on any anticoagulant so that the patient does not land up with stroke or involvement of the other eye?
So I've mentioned that the patient was started on
maybe I missed that. Okay.
Yes, yes. The patient was.
So because that is much more important now, like apart from the systemic diagnosis, to protect the other eye or the patient landing up with stroke.
Yes,
Otherwise, it's a very nicely presented case. Thank you.
Great. Thank you, sir. Thank you, judges. Thank you, Mosami ma'am. Can we go to the next participant, Miss Dr. Priyanka?
Hi, sir.
Yeah, you can share your slides, ma'am.
So can you see my slides, sir?
Yes, your voice is audible. Your slides are visible. You can go ahead, ma'am. Thank you.
I'll be presenting a case on unusual coach-like response in occlusive retinal periphlebitis. My patient, a 42-year-old male who's a resident of West Bengal, who complained of diminution of vision in the left eye for past 1 month, which was gradual, painless, progressive diminution of vision and associated with flashes and floaters. There is no significant negative history and there is no systemic comorbidities with the patient. Systemic examination within normal limits. Coming to ocular examination, his right eye vision was 6/6 and the anterior segment and posterior segment examination was normal. Left eye vision was 6/24 and the anterior chamber was within normal limits. There is presence of retrolental cells. Coming to the fundus examination of the left eye, there was media haze of grade 1 and disc was there is blurring of margin 360 degrees associated with cuffing noted along the peripheral venules suggestive of active periphlebitis. There is also collateral suggestive of old retinal vein occlusion, and there is sclerous vessel present adjacent to it. Perivascular exudation was noted in the temporal and infratemporal areas, and there are few retinal hemorrhages along with the retinal thickening. This suggestive of recent branch vein occlusion. Ill-defined yellow subretinal patches along the infratemporal arcade and temporal to the macula suggestive of subretinal exudation. And there was hard exudates near the fovea. To summarize, a middle-aged male with progressive diminution of vision associated with floaters and flashes in the left eye for past 1 month. His vision is 6/24 and there is mild vitritis and cuffing of peripheral veins with multiple venous occlusion and paravascular exudation suggestive of occlusive periphlebitis. And there is presence of subretinal exudation in infratemporal and temporal areas. There is diffuse telangiectatic changes with a few peripheral microorganisms. These two suggested us that it was looking like a coach-like response. So my clinical diagnosis would be left eye occlusive retinal periphlebitis, secondary to coach-like response. My close differentials would be Ehlers disease as patient is young and severe retinitis, Behçet's disease and IR1. On further investigating with motion in macula, there is presence of macular edema of 466 micrometer and presence of epiretinal membrane with few cystoid spaces and subretinal fluid with the hyperreflective foci suggestive that it's an inflammatory response. There is retinal thickening along the area of branch retinal vein occlusion. On FFA, in the arterial phase, there is blocked fluorescence suggestive of retinal thickening and hemorrhages. And in early venous phase, there is delayed filling of supratemporal and infratemporal quadrants suggestive of BRVO. And in the late phase, there are multiple telangiectatic vessels with few microaneurysms. In late phase, there is leak from those microaneurysms and along the disc and peripheral veins. And there is increasing leak in the late phase. This picture shows that there is progressive leak from the microaneurysms with multiple telangiectatic vessels around it. The systemic examination was within normal limits, but his CSR was mildly elevated of 24 mm per hour. We started on oral steroids of 50 mg per OD and tapered slowly over 2 months. We can see that at presentation there was a macular edema in OCT, but in 2 weeks and 2 months there was a reduction of macular edema. The patient symptomatically improved. His vision improved to 6/9 by 2 months only on oral steroids. So the various literature showed that the course-like response would be associated with retinitis pigmentosa, retinitis vasculitis, pars planitis, macular telangiectasia, ischemic BRVO, and ROP. But in our case, it was associated with occlusive retinal vasculitis. So my take-home messages will be a few microorganisms, telangiectic changes with mild exudation can be sign of BRVO. But course-like response with subretinal and perivascular exudation is a rare presentation of occlusive retinal periphlebitis. A good clinical observation and FFA helped us in arriving the early diagnosis so that the early treatment will prevent the deprivation of the vision. Control of the inflammation with the oral steroids alone showed a good response, as we can see the resolution of macular edema and the retinal thickening over the period of 2 months. Thank you.
Great presentation, ma'am. Akshay, sir?
I think it was a quite a well-managed case, but I had a doubt. Can you go back to the fundus picture? So they were associated retinitis and these hemorrhages noted. Did you consider investigating for any viral etiology, or the patient immunocompetent?
Yes, sir. We also sent for HIV serology, which was turned out to be negative, and VDRL toxo also turned out to be negative.
No, not HIV. This patient, I guess, was immunocompetent, right?
Yes, sir.
HSV and VZV, anything of those sorts were investigated?
No, sir, we did not investigate. Patient was like immunocompetent, so we did only HIV serology.
Okay. No, because this when you have this kind of picture, one of the other differentials we have to keep in mind is the viral retinitis.
Yes, sir.
So because if there is a viral component, then antiviral drugs for a longer time is needed to avoid any recurrences. So otherwise, I think with steroids it settled down. And there was any history of fever before this?
No, sir. In the history I've mentioned there is no history of fever, joint pain, no inflammatory.
Any history of IV fluids?
No, sir. No symptoms.
Okay. Yeah, I think patient got lucky with only management of steroids, but well managed.
Thank you, sir.
Very nice images and fluorescent images and which can be seen. And as you know, occlusive vasculitis or any vein occlusion, there will be a formation of secondary microorganisms and telangiectasias, which are nicely depicted. But as Dr. Asha is saying, any uveitis, I think further investigation is important. Still more further investigation, especially viral. Nowadays, viral, most of my cases, I kept in my battery of tests. Usually, I include viral also, because we see very commonly in this, and this is a chronic occlusive vasculitis. Along steroid definitely will help, but yes, infective etiology has to be taken care for.
I think most of the comments the two judges have given. I don't have any further comments.
Okay, thank you, judges, for your comments. We can move on to the next presenter, Dr. Dipanshu.
Hi, am I audible?
Yeah, you're audible.
Is it visible now?
Yeah, visible. You can keep the full screen mode and do slideshow.
All right. Good evening, one and all. So my case is of a 60-year-old male factory worker who had complaints of diminution of vision in the left eye since 3 days. This was following trauma with iron nail. He had a vision of 20/600 in the left eye, and there was a presence of corneal tear in the left eye. So we made a diagnosis of open globe injury in the left eye with corneal tear, and patient basic pre-op profile was done along with basic systemic medications were advised, and patient was planned for corneal tear repair under local anesthesia. The patient, after the surgery, day 1 follow-up, patient was lost to follow-up, and he presented only after 2 months, wherein we could see that there is suture-related endophthalmitis was noted. There was hypopyon on B scan also. There was dense vitritis, and since there was media haze and the clarity of the fundus was not there, we advised the patient for vitreous biopsy along with intravitreal antibiotics and dexamethasone. On multiple injections of antibiotics and dexamethasone, subsequently the wound healed and the endophthalmitis resolved, but it only resulted in a corneal scar and cataract. So eventually at 8 months follow-up, when there was healed corneal scar and and there was cataract with no view of fundus, the patient was planned for left eye optical penetrating keratoplasty with phacoemulsification and intraocular lens implantation. So patient was doing fine till 3 weeks, but at 6 weeks follow-up, we noted that the bag IOL was not there, and bag was noted to be compromised. So there was IOL dislocated to the vitreous cavity. Again, another intervention was planned in this patient with pars plana vitrectomy with IOL explantation and scleral fixated IOL. So these are the images of patient follow-up visits at day 1, 4 weeks, and 10 weeks. Patient currently is doing well with BCVA of 20/120. Despite having these many interventions, the patient maintained a decent vision of 20/120. So these are comparative images showing the images at presentation with subsequent follow-up visits with multiple interventions. So in these patients, this critical tricky situations may arise with multiple complications that might arise during the treatment plan. We require patience in treating this patient, as well as patient follow-up is also important. Otherwise, these eyes might go into phthisis if not intervened timely, and if patient does not follow up. And documentation is the key to. I would like to acknowledge my cornea colleague, Dr. Nupur Dubey, for this case. Thank you.
Nice presentation. Over to you, judges.
Dr. Dipanshu, you mentioned about suture-related endophthalmitis. Did you take the vitreous biopsy? Did the microbiology? Did you get anything out of it?
Sir, actually, we had sent the sample for vitreous biopsy, but again, it did not have any conclusive organism out of it.
No. How did you come to the diagnosis of endophthalmitis?
So there was hypopyon, there was corneal infiltrate, as well as there was dense vitritis in the vitreous cavities, and patient had painful vision loss as well.
No. With one single dose of
No, sir. We had injected nearly 5 doses of intravitreal because the view was not clear, so we could not go in and intervene surgically. So we intervened, we injected nearly 5 doses of intravitreal vancomycin and dexamethasone.
Alternate day or every 48 hours?
Initially, it was initial 3 doses were at 2 days or like 48 hours gap, and the last 2 doses were at like 72 hours gap. So,
can you just show me that B scan, Doctor?
1 second. Getting shared. Is it visible?
No, not yet.
I think it's not getting shared.
Okay.
I'm trying.
We can see your screen, but the slides are not getting changed.
Okay.
So basically, without vitrectomy, only on intravitreal, this thing we manage the end of, right?
Yes, sir.
Okay. So that is where again I have a little bit of issue there, but otherwise, post that, I think it was well managed, and the patient did get good vision. But coming to the endophthalmitis, when you have an endophthalmitis and if cornea is involved, generally our practice pattern is if the microbiology is very crucial, because if we don't get the microbiology, we are always shooting in the dark. We don't know what antibiotic to be given. So once you have favorable organisms, then you can manage with without intervening with the corneal intervention. But if it is like a gram-negative bacilli or cocci and all, gram-negative cocci and all, then definitely I would resort to the primary PK and do a complete vitrectomy. And sometimes if the retina is necrotic, I even will go to the extent of putting an oil to avoid any complications. Otherwise, you were lucky to get away with this kind of pathology with a very good outcome. Congratulations on that.
Actually, it did not look very aggressive, sir. When we intervened also with multiple injection, it appeared like it will heal or it will resolve on its own. So with the intravitreal injection. That's why we did not do a primary PK and we waited. If it would have worsened despite the injection, probably we would have done the primary PK and gone with the vitrectomy.
Yeah, correct.
After how many months the suture-related end-off happened?
So 2 months.
2 months. So
he presented after 2 months. He had symptoms like
after 2
10,
months.
11 days. He managed that also. And after that, he presented at 2 months follow-up.
So I would be very hesitant to use dexamethasone that too 5 times after 2 months without any, because it's a delayed, it can be fungal also.
Fungal also.
It is not resolving and we don't have a histopathology. I think even the suture would have been sent for culture to see what is the organism maybe. Luckily, it
So
can
we
be
had sent suture, we had sent anterior
Mhm.
segment, the inflammatory material as well as vitreous ectodates. But somehow we were unlucky to have any organism out of it.
What you made, what you made to you 4-5 intravitreal injections. It was not resolving, or what was your thought process of giving the further injections, like fourth injection or thing? What was the clinical picture? Was still worsening, or it was same, or it was what you made you to think of giving multiple injections?
So actually, the issue was, sir, I was not able to go in and do a primary vitrectomy, and since it showed response to vancomycin, so like my thought process was that whether we should the resolution of vitritis at least should be decent, should be sustainable, so that later on, if we require to intervene, by the time endophthalmitis should resolve, or if it does not resolve, then we will have to do PK as well as vitrectomies.
So one thing, the DEXA thing, we should be very careful. It's a very nice thing, but it can be double-edged sword where you're using when we don't know the pathology. That's the one part. And second thing, when you're doing the SF file, how was the inside part? You was able to any end of features, anything was there when you went doing a vitrectomy?
So there were few sclerosed vessels in the periphery. The PVD was already there, and vitrectomy did not have any such issues. As in, by that time, inflammation had subsided significantly, sir. So
usually,
it was
if there is endophthalmitis and you are treating only with injection, the exudates will take a lot of time to go. This will stay like a vitreous opacities many times. That also may indicate the amount of endophthalmitis.
Dr. Deepanshu, it was a very nicely managed case. I have one question. What was the cause of end-off in this patient? What would you actually suspect? You said it's a suture-related endophthalmitis. So were the sutures not buried, or were there any cut sutures, or were the sutures loose? Like, what was the etiology in this patient landing up with endophthalmitis after 2 months of primary surgery?
no, sir. Actually, the thing is, the patient after discharging on the day 1 did not come for follow-up at all. So he came only at the 2-month follow-up with pain and redness and vision loss complaints since 10 to 12 days.
So probably the patient was asymptomatic, so he did not bother to come to you
for the follow-up visits. And then
so
later
probably
on, when he
within
developed,
those 1 week or 10 days, he has developed signs of endophthalmitis and inflammation and pain. So he has come to you. So no, I just wanted to know, like, why the sutures? Why are you suspecting it's a case of suture-related endophthalmitis? So
because there was corneal infiltrate around the suture site as well.
were the
And,
sutures nicely buried inside, or?
It was, yes, sir. It was done by a cornea surgeon only, and primary surgery went well. There were only 3 sutures placed actually, so it was not a very large wound.
Okay.
Eventually, when he came, the sutures were loose, and there was corneal infiltrate around the suture, around the site.
So probably the sutures would have got loosened up, and the patient did not follow up, and probably the loose sutures might have accumulated organisms and would have led to local infiltration and endophthalmitis, is what I guess, like in this patient.
So this is more of a suspicious diagnosis. Like it could be post-trauma also without suture, but since there was cornea involved in it, and sutures were loose at that point of time, and patient had not followed up with us, and he was not using medications on very clear properly. So probably that was the reason we suspected it as suture related.
Okay. Just in continuation of what Dr. Sharath has asked you, like what were the signs like you saw when you said that there was improvement, whether it was an ultrasound or clinical evaluation, you could say
So
that there was
both
improvement.
clinically as well as on B scan, we noted that vitritis was reducing as well as the anterior chamber inflammation was going down. So that's how we thought we might not need to intervene with primary PK as well as primary vitrectomy.
Okay. Thank you.
Thank you.
You can, yeah, thank you, sir. For the next presentation, we have Dr. Monica Singh. Ma'am, you can share your slides.
The last one, right, Manish?
Yeah, that's the last one. Yeah.
Good evening. Am I audible?
You're audible, ma'am. Your slides are visible. You can start.
So my presentation is a case report on intraocular cysticercosis. An 11-year-old child presented with diminution of vision in right eye, which was insidious in onset and progressive in nature since 2 weeks, associated with floaters and redness. He also complained of paritotemporal headache since 2 weeks. No history of colored halos, diplopia, discharge, foreign body sensation. No past medical or surgical history or significant family history. General examination was normal. Systemic examination was also normal. Clinical examination revealed right eye. Best correct visual acuity was hand movements close to face. Conjunctiva showed circumcorneal congestion. Cornea showed endothelial dusting, small-sized keratic precipitates, anterior chamber cells 2+. Iris was edematous. Pupil was 3 mm, sluggishly reacting to light. Lens was clear and IOP was normal. Fundus examination by IDO. Right eye revealed profuse vitritis, hyperemic disc, a large elevated white mass, and surrounding hemorrhage, suggesting of an inflammatory granulomatous lesion. Further evaluation revealed it to be a translucent white cyst with dense white spot formed by the invaginated squelex with typical undulating movements. Left eye examination was normal. So diagnosis reached was pediatric panuveitis with parasitic inflammation. The differential considered were posterior uveitis due to bacterial TB or fungal infection or diffuse unilateral subacute neuroretinitis. Investigation showed on A scan high amplitude spikes corresponding to the cyst wall and scolex was appreciated. B scan showed a well-defined intravitreal cystic lesion with a hyperechoic focus adherent to the retina along with the signs of complete PVD and serous retinal detachment. MRI showed few ring enhancing lesions with perilesional edema in bilateral parietal and left medial temporal lobe and right globe. The ELISA was positive for tinea solium. So management, the patient was started on homotropin and nepafenac eye drops. In consultation with the neurologist, the patient was started on tablet prednisolone and tablet albendazole and was monitored closely with heightened vigilance. Subsequently, surgical intervention of pars plana vitrectomy of the right eye was performed. This is the pars plana vitrectomy. The sequelae, ocular cysticercosis was treated and the vision improved to 660 and near vision N12. However, one of the cysts was buried subretinally as a retinal granuloma. This case highlights the critical importance of the ophthalmic examination in diagnosing curable life-threatening systemic diseases such as cysticercosis. Co-infection with neurocysticercosis and intraocular cysticercosis frequently encountered in endemic regions such as India. Ophthalmic evaluation provides a window to diagnose an otherwise asymptomatic condition, and additionally, this case emphasizes the significance of prudent early ophthalmic intervention, which not only mitigated the high risk of visual impairment but also significantly improved the quality of life. So ocular and orbital cysticercosis has varied presentation depending upon the site of involvement, number of lesions, and the host immune response. Pars plana vitrectomy is the safest and effective technique to remove the cyst by creating a retinotomy and bringing the cyst into the vitreous cavity. Small subretinal cysticercus are treated with xenon or argon photocoagulation. Subretinal cyst anterior to the equator may be removed sclerally, whereas subretinal cysts posterior to the equator are best removed transvitreally. Thank you.
So Dr. Monica, so you didn't mention about the duration of the albendazole and steroid therapy and what dosage was given.
Yes, sir. It was 6 weeks of albendazole and steroid was given. Steroid was tapered after 4 weeks.
So was it given 50 milligram per kg, or did you, since I guess even the MRI had a few lesions?
Yes, sir.
Did you, what dosing protocol did you use?
Sir, 50 mg per kg was given.
Okay. So even steroid was given at what dosing level? So those things, especially in the pediatric cases, can make a lot of difference in the management. So that needs to be there. And the other thing is the argon and xenon photocoagulation are of historical significance. I don't think anyone is using that right now. Otherwise, if it is in the vitreous cavity, people generally try to remove it in toto, but otherwise, even if it ruptures, because we have high speed vitrectomy and there is very low exposure to the antigen, and you just swallow all the antigens and you can be free of this thing, free of the disease.
Yes.
Otherwise, the cysticercosis are visually very good to see in retina, but otherwise it is quite dangerous for the patient, especially when it happens in involving the brain, especially in a child. So, yes,
Dr. Monica, yeah.
Yeah.
Do you want to continue, sir?
No. I think well-managed case. Just that those 2 points were missing in the presentation, so I just wanted to highlight.
Dr. Monica, I have 2 observations. In this patient, I don't think DUSN should be a differential because DUSN rather has a very different presentation. You see multiple subretinal tracts. You don't see a particular subretinal cyst kind of appearance in these patients of DUSN. And one more question for you, like why was this patient not initially thought of managing with vitrectomy? Why was the patient started on antiparasitic and steroids? Because we know that the dying cyst is the one which incites intense inflammation. So did we not delay in management of this patient? Like why the antihelminthic treatment was started in the beginning, like rather than planning vitrectomy?
So while the vitrectomy was being planned, we started on antihelminthics and steroids, sir.
Okay, so because I know I'll be little concerned because if the cyst dies there, it would rather worsen the situation and the patient will end up with intense inflammation. So I think treatment of choice for a subretinal or a intravitreal cyst is you directly go there and do the vitrectomy.
Okay, sir.
Otherwise, it was well managed case.
Then I think Shreyas, the other part was this brain involvement.
Okay.
Yeah, maybe Dr. Monica, want to throw some light? You wanted to treat that and then come here, or?
Yes, sir. Actually, we discussed it with the neurologist. So they suggested to start the antihelminthics so we were monitoring closely. As soon as we could do the surgery, we proceeded with the surgery. So because of that involvement, we started early and then we continued the treatment.
Maybe sometimes that even getting a GA fitness for such patients will be difficult,
Yes.
and they might be initially managed medically and probably subsequently planned surgery.
Yes,
So
sir.
that might be one of the reasons. So.
Very well managed case. As of everybody is saying, neurosurgical sarcosis is the first important thing to be taken care for. Yes, surgically, the main management. Along with that, controlling of inflammation is also important. With eating high with steroids is also important. Yeah.
I think all the judges have finished with the last presenter. And big thanks to Ashaya sir, Sharat sir, and Shreya sir for being judges for this session. And by this session, we conclude the prelims for NOI NAADI 2.0, the case presentation competition. And Nilesh,
Sorry to interrupt. We have joined by Dr. Nilesh, our UC Secretary, Honorary General Secretary of UC. Welcome, Dr. Nilesh.
Yeah.
Thank you for being.
Good evening. Good evening and good evening, Ashray sir, Sharat sir. I am just here to take the limelight, using my position for all hard work has been done by Prasanna
I
sir,
called you.
Pranesh sir, Kartikeya and Niranjan. Niranjan, I am not able to see.
Yeah, Niranjan is gone for some other good news. We'll announce it tomorrow.
Okay,
Yeah.
okay. So,
Thank you, Nilesh. It is out of love that I called and disturbed you, and I wanted you to be here.
Good evening, Nilesh sir. Good evening.
Good evening. Good evening.
I'm very much here. Had to just switch off the video. How are you, sir? Welcome to our NOI NAADI season 2.0.
Yeah, it was really a marathon, sir. I think for 3 sessions and so many presentations, I think from NOI NAADI 1 to 2, it has grown thrice.
It's been 5-hour marathon. Nilesh,
Yeah.
and thank you for being here at such short notice on a phone call. So we had this Google Excel sheet, so we were able to get the marks on live. So we thought we'll announce it on live. So that was the idea. We wanted you also to be part of the announcement where Dr. Karthik is just checking the results as we speak, all the 3 sessions. So before we announce the results, so we have our sponsors, Elazar. So a 40-second video was what was they wanted us to play it. So we'll play that video first. Then we'll have the certificates of the participants distributed next. Then we'll be giving the announcement, which is just a couple of minutes away. So first for the video of our sponsors of this particular event. Elazar is our sponsor, and we thank our sponsors once again.
an autoperimeter is too big an investment to make, particularly for my clinical side.
My patients have to travel to another hospital just for perimetry, sometimes to a different city.
Because of these reasons, many glaucoma patients miss out. AVA bridges this gap by being a diagnostic device for glaucoma with the accuracy of gold standard perimeters at just 1/5 of the cost. Take one step towards expanding your ophthalmology practice and delighting your patients. Sign up for a demo today.
Thank you, Elazar, for sponsoring this event. And we'll next have the last set of the certificates of the day. Our session 3. Pranesh, over to you to do the honors. I'll keep changing. You can.
Okay. First, we'll certify the participants for the last session. Dr. Miriam.
Just a moment.
Yeah, no. You're going with judges. Okay, no,
Just a moment. Yes.
We are really grateful for judges of the retina session, Ashaya sir, my retina mentor. Then
Thank you.
Dr. Shreyas Temkar. Thank you very much, sir, for being part of this.
Thank you. Thanks a lot.
Dr. Sharat sir, thank you, sir. Thank you very much for being a part of this, sir.
Thank you for calling me.
Then going over to the participants, Dr. Han Shah, who presented a IO intraocular foreign body, a blink away from disaster. Dr. Shruti M. Nair, double-edged sword, IVT induced CSC. Dr. Mosmi Banerjee, waxing and waning pattern of choroidal detachment post-scleral buckle. Dr. Gautam R, IS and index of cholesterol levels, a case of recurrent lipemia retinalis. Dr. Deepanshu Agarwal, from fever to vision loss, understanding neovascular glaucoma and post-fever retinitis. Dr. Shruti M. Nair, retinal hemangioblastoma, strike at the right time. Dr. Mosmi Banerjee, branch retinal artery occlusion in young female with a Mayer-Rokitansky-Kuster-Hauser syndrome, type 2 with cardiac malformations. Dr. Priyanka R, unusual coach-like response in occlusive retinal peripheral uveitis. Dr. Deepanshu Agarwal, ocular trauma and visual recovery, a case of complex surgical interventions. And finally, Dr. Monica Singh, while parasite attack, a case report on intraocular cysticercosis. Had great presentations for this retina session. Thanks a lot, participants, for taking the efforts to make such good presentations.
I had a small point to add.
Yes, sir, please.
So I think there was, we were given the guidelines to score. I think one critical thing which we all have to do in our daily practice is critical thinking in what we have to do. Based on that, we will improve as clinicians. So critical thinking is very, very important because it is nothing but what you do every day. So when a patient comes, you analyze and you interpret, you evaluate if there is anything needs to be done, and you decide based on all these things. So if you do it every day, I think this is what this whole presentation is designed for. So I think it was a great learning for me, and people who inculcate these things can become better clinicians.
Thank you. Thank you, sir. Thank you very much. So,
Thank you very
Prashna,
much.
you're not audible. Prashna, you're not audible.
Any other judges, any other comments that you have? Because we have got the results and we'll be announcing it very shortly before any other closing comments from other judges.
No, please go ahead. We don't have any other comments.
If possible, I would humbly request all the participants to switch on your camera. We would all like to get the picture documented for our newsletter. Of course, after the results, I think each one of us will have different other needs to attend to. Can each one of you switch on your camera for a quick OC photograph, our mandatory O photograph? It's hard to see at 10 o'clock in the night, almost 28 participants. I think that proves the success of NOI NAADI from season 1 to 2. It's a big cheers to all of us. Yeah. Karthik, you are also taking the photo. I am also taking. You also can just. So we have a very vibrant newsletter under Dr. Niranjan as well as our dynamic secretary, Dr. Nilesh. So this will be coming in our newsletter. So it's all a documentation for us so that we have this good memory with us. Yeah, once more. 3, 2, 1. Cheers. Once more. Karthik, you also make sure you also click some clicks. So at this advent of after 4 years, 10 o'clock in the night, 28 people, I think it serves as a perfect testimonial for our NOI NAADI season 2. Nilesh, I have shared it to you also. So first 2 people, I think each one called 2. So we have 4 plus 1, and you can call the first 2 people. Yeah.
So,
if you want to break the suspense very early, or you want to make it.
This is no specific order. I'm sorry to interrupt. This is no
Yeah,
specific
there is no
order. This is
specific order.
the amalgamation of all the best of each of the prelim sessions. So this is a no specific order. So we have just tried to mash it up and give you the top 10 finalists. Yes.
Yeah, but I'll go serially. Otherwise, it becomes. Yeah.
1 second, Nilesh. So yeah, correct. Before we announce, so tomorrow we have 3 more chief judges along with the chief guest, and all the judges. We would like to humbly request all the judges of the 3 sessions today to be among the panel tomorrow for the finals, and over to our secretary, Dr. Nilesh, to do the honors.
So I'll go from left-hand side, first 2. And my extreme pleasure are very dynamic, very energetic, Dr. Nupur Goyal. She is the first finalist. Congratulations, ma'am.
Nilesh, you have to announce the heading also, because many people had 2, 3 presentations.
Yeah, so the heading for Nupur ma'am is Piece the Puzzle. Often you will not know what's it's there. So that is her presentation that is going to be in finals. And second one is my senior from Lotus Eye Hospital, Dr. Arulpriya. She is going to present on lunar landscape analyzing congenital versus acquired optic disc. So these 2 for me. Congratulations.
Congrats, Nupur ma'am, Arulpriya. Arutpriya is my junior at
At the MS College. Yeah.
Pranesh.
Yeah. Now announcing the next two finalists. The third number would be Dr. Disha Agarwal. Dr. Disha has presented a case on arthritic AON as a presenting feature of Takayasu arteritis. Heartiest congratulations, Dr. Disha. And the fourth finalist for the night is Dr. Gautam R. Unmasking the overlap, early Parkinsonism, misdiagnosed as ocular myasthenia gravis. Heartiest congratulations, Dr. Gautam.
And a big shout out to Dr. Niranjan. So Niranjan is expecting a child anytime, now or later also. So that shows his commitment. Thank you, Niranjan. He was not able to be in this webinar this 3 hours, but he has done a lot of groundwork for this webinar. And he's soon to be a father, and he's here. Thank you for that, Niranjan.
Congratulations,
sir. Thank you
congratulations.
so much for
Hopefully
the
in finals we will
opportunity.
have.
Yeah, we'll have a
We will have the
Yes,
good
sir.
news in
Yes,
finals.
sir.
And over to you
Need
to
all your
announce the-
prayers and support as well. Thank you so much, Prasanna
Thank you for your
sir.
commitment.
Advance wishes.
Over to the announcement of next two people.
Yes, sir. It is indeed my pleasure and privilege to announce the next two finalists. First is Dr. Vijita Deb, and congrats, ma'am. And her topic was sheath in the shining armor, Tenon's patch with amniotic membrane graft for corneal perforation. And next is Dr. Raj Shekhar Paul, bubble trouble, a stitch in time. Once again, hearty congratulations to both of you and wish you all the very best for the final that's coming up tomorrow. Thank you, sir. Thank you, Nilesh sir.
Niranjan.
Thank you, everyone.
Thank you for being here and being one of the pivot of the NOI NAADI event. So next, I'll be announcing the next two and leave the tough job to Karthik. so Dr. Kirtana Kasi, a tale of two hypersensitivities. Congrats, Dr. Kirtana. Are you here?
Yeah, she is here, but she's
Yeah,
not.
she is here.
Yes, sir,
Anyway,
thank you.
yeah. Congrats, tale of two hypersensitivities. And next, a very beloved friend as well as junior Dr. Mousmi Banerjee. Excellent presentations by you today. And today, your selected thing is on waxing and waning pattern of choroidal detachment post-scleral buckle. A big congrats to you and for entering the finals, Dr. Kirtana as well as Dr. Mousmi. And over to Dr. Karthikeyan. So Dr. Karthikeyan was the one who coined the term NOI NAADI when 1.5 years back in March 2023, when we all started collaborated or wanted to do something, the term, most of the protocol is what Dr. Karthikeyan coined, and then we all started adding on to it. So Karthikeyan, over to you. So we have 38 are entered out of the remaining. I have given the tough job to you.
Yeah, thanks. Thank you, Dr. Prasanna. Here we have last two participants who are going to enter the finals. This nail biting finisher. So the last two participants, one is Dr. Shruti Nair for the case retinal hemangioblastoma, strike at the right eye. Yeah. Then the last presenter who is going to finals will be, any guesses? Yeah, no. We'll see it with Dr. Ahan Shah for intraocular foreign body, a blink away from disaster. Okay, everyone has presented very well, but after so close, we could not isolate someone for the finals and some, but anyhow, only 10 can present in the finals. So we have selected these people. All the best to everyone who presented. Okay.
And Nilesh, a few closing comments from you before we have the vote of thanks.
Yeah,
Thanks
I think it was very well, like I could catch on YouTube only. I was not, I didn't join on Zoom. I'll be there tomorrow. So it was very, very nicely conducted. I have been fan of all these guys, Prasanna sir, Pranesh sir, Niranjan, Karthikeyan. Like the zeal is so much, like UOC gets so much out of them. And it has been growing because of their hard work, I think. And very great to have Ashish is still hanging around. Sir was there in Coimbatore when I was doing my post-graduation. And so many known faces are here right now, and everybody has presented so well. So I would like to point out one more thing. There's so many senior youths, like in UOC, they are so senior. Still, they choose to present like a normal candidate rather than being on panel and judge. So that shows that UC is something different than most of stuff that is going around. So thank you, everyone. Thank you. And thank you for calling me.
No, it's our pleasure. Thank you for being at such short notice over a phone call, and we are lucky to have you here, Nilesh.
And thank you for supporting us to conduct this
Yeah,
competition.
supporting the event. It's a 2-day event. It's been a part of our standard prototype now, and we had hopefully, I think the bars are set high. So anybody from the participants or the finalists, anybody would want to make a quick comment before we go to the vote of thanks?
Can I say something?
Yeah, ma'am, please go ahead.
Yeah, so I just want to compliment the whole team, Prasanna, Niranjan, Karthikeyan, Dr. Pranesh. I think it's so wonderful, as Nilesh said, the energy that you guys have brought to the entire, this entire event, it's so palpable. And thank you for, letting us also participate. I was a little skeptical that should I not, but Pranesh kept sending me messages, Google form entry last date, Google form entry last date. So that was so nice. So thank you. I think it was so nice. And I think case presentations are always a great way to learn, from each other. So I think that's fantastic. And the way it was conducted was excellent. Plus the teamwork, the camaraderie that the four or five of you have is just amazing. That is the first thing that struck me. So, Prasanna, what is the meaning of NOI NAADI? Can you just tell us that? You said Karthikeyan coined the term.
The creator of NOI NAADI is
Okay.
down.
Yes.
It's right only if it comes from his mouth.
Yeah,
No. I'll stop here. There, you should go and watch on YouTube. There, at last NOI NAADI, there was an elaborate discussion on this.
Okay. Also, we will.
And to make the flavor right, we are. Last time Nirmal Frederick sir was decoding it. If I'm not wrong. I think this time also a similar template, but I think the good sound. Yeah, Karthi, you just decode what is NOI NAADI and we'll go for the vote of thanks.
Okay, NOI NAADI. No, I think I will say it tomorrow, in the finals.
No, tell today also. We are waiting to hear it from.
On the thing, it's a Tamil proverb. I'll say in English explanation. One is you have to find the disease and find the cause for the disease and treat the disease and treat it in a right way.
Okay, thank you, Karthi. Thank you all for.
So it stems from the ancient literature called Peripheral, where it starts off with this NOI NAADI. So we have 1,330 verses in that, and of which our subsection is about medicine and treatment. So this is how it goes. NOI NAADI, NOI Mudal NAADI, Althanikum Vainadi Vaipachel. So that is the verse, how it starts, is NOI NAADI. So we've given our we started it off saying NOI NAADI, and I think it's grown to 2.0 in greater strength and vigor, I suppose.
Thank you, Dr. Niranjan. And over to Dr. Niranjan and Pranesh for the vote of thanks. We had 3 marathon sessions and we have a young father-to-be. Thank you, Niranjan. We missed you today, but we know why we missed you today. The work was already done for us so that it was easier for us to take on. And Dr. Pranesh and Dr. Niranjan, over to you for the vote of thanks.
Niranjan, you can take the mic.
Honors.
He's been absent for quite some time.
Thank you, Prasanna sir. Thank you, Pranesh sir. At the outset, firstly, I would like to thank our governing council, our dynamic president Devakant sir, Karan Bhatia sir, Nilesh sir, for their unstoppable support. I mean, without them giving us the green signal, none of this would have been possible. And so at the outset, I would like to start by thanking them. And next up, of course, our guide, Prasanna sir, who has been so pivotal in making this happen, and Karthikeyan Mahalingam sir, because sir and Pranesh sir, I mean, I'm probably the youngest of them all, and with their very support is how I have been able to be a part of this wonderful team. So thank you, sirs. And next up, the judges for the 3 different sessions. So it's a long list and divided into 5-hour marathon, like what sir has said. So I would, at the outset, like to thank our dear judges who have taken out their time on a busy weekday and been with us for so long and had the patience to listen to each and every presenter and given their wonderful inputs. And as well, it's not too easy to score them and mark them on a Google sheet and keep up with the trend of online case presentations. And they've really been so kind to us to adhere to the instructions, and it's been a cakewalk. And making it happen on a live basis, on a real-time basis is not at all possible if it's not for them. So thank you, dear judges, for doing this, carrying out your responsibilities in such manner which made it so easy. And next up, the participants. It really gives us so much motivation and happiness to see the record number of submissions. And we really had to brainstorm to see how we could accommodate each and every one of them. And so we had to divide it into 3 different sessions and identify the judges accordingly. And each and every participant, I suppose, is a winner because they've come forward. They've really been here on this very evening to present their cases. So it is not an easy thing considering the kind of practice busy they are. So thank you to each and every single participant who has submitted. And of course, congratulations to the winners as well. And then, Pranay sir, if I missed out anybody, please fill in the gaps.
No, you come down the ladder from top tier to bottom tier, everything you have covered. Good job.
Thank you, one and all. In case I missed anybody, please do forgive me for this missing, if at all. Thank you.
Oh, issues great. I think Niranjan has covered everything. I'm really, really grateful.
Just wanted to add thanks to Numorotech team. I think for this kind of effortless and seamless webinar. I think Numorotech team is there. Hopefully, Sai sir or Manjula ma'am, you are here.
Yeah, we are here, doctor.
Yeah, thank you, Numorotech team. The clocker that you gave, the time clock for 4 minutes, it really helped us a lot. And thank you, dear all. And with that, we are not ending today because it's just the beginning. So I would like Dr. Pranesh to do the honors of. I'm just sharing the screen, Pranesh. You can call it out. And I think
we'll call it a day.
One second, I'm just sharing the screen of the tomorrow's flyer. And we can just.
Sir, and also I missed out on thanking our sponsors for today, Ellie sir. So again, they've been so kind to support our initiative from the word
You
go.
want me to share? I'll do it.
Done.
Done now. Okay.
Definitely have to give them their thanks, and over to you, Prasanna sir.
Over to Pranesh to introduce what is that lined up for tomorrow.
For tomorrow, we start at 6:30, and very grateful to have Satyan sir as the chief guest. And judges, we have Hemanandani ma'am, Malarvili ma'am, and Vasanta ma'am. All are sweethearts. We're really thankful to them for taking part in this. And Satyan sir, a big thank you to him also. And we would like all the judges present today for the prelims to be as a part of the panel and ask questions so that it will be more enriching for the judges also, and for the participants and for the viewers also. So that's it. Had a really great time and varied facets of information. It was very nice, and thank you all. Thank you, participants, viewers, and my co-organizers and judges. Thank you all for the opportunity. Great time learning.
Sai sir, we can go off live, Sai sir. Sai sir?
I think. Yes, doctor, I'm going offline.
Yeah, we can go off.
I'm going offline.
Okay, I was calling the site.